Good morning. My name is Dave Shidlow. I'm a pediatric cardiologist and director of the Heterotaxy program at Boston Children's Hospital. Along with my colleagues, Dr. Tom Saba and Nisha Sabin, I serve as the co-executive director of the Heterotaxy Research and Clinical Care Collaborative, or HRC3. On behalf of the conference chairs, Tom, myself, Dr. Ken Haver, Dr. Steve Spurgeon, and Nisha Sabin, I am delighted to welcome you to Boston and to the first in-person HRC3 scientific sessions. HRC3, by way of background, brings together physicians and scientists who are working to advance research and improve clinical care for individuals with heterotaxy and their families. We obviously have a long way to go, but this meeting is a terrific next step in that shared mission. With the exception of last year's virtual conference, which was terrific, this is the first conference of its kind. We have clinicians from across disciplines, all united by a commitment to care for individuals and families affected by a very complex condition. I don't need to tell everyone in this room that we each see heterotaxy from a slightly different vantage point. For some, it's complex congenital heart disease. For others, ciliary or immune dysfunction, hepatobiliary or intestinal malformations, genetic complexity. And for families, it's a journey marked by uncertainty, resilience, and hope. But we're all here for the same reason, and that's to realize the name of this conference, which is Facing Heterotaxy Together. Over the next 2 days, we hope you'll find these sessions illuminating and engaging. We encourage you to collaborate, connect with colleagues from other centers and disciplines, share your expertise, and spark new ideas for research. I want to briefly acknowledge the people and organizations who made this meeting possible. Heterotaxy Connection has played a tremendous role, graciously supporting and enthusiastically handling much of the behind-the-scenes work to bring this meeting to life. The Benderson Family Heart Center at Boston Children's Hospital has also provided generous support for the conference. And of course, we're deeply grateful to the families and advocates of Heterotaxy Connection, whose partnership and perspective keep our work grounded in what truly matters. To our speakers and attendees, thank you in advance for sharing your time, enthusiasm, and expertise. To all of you, thank you for being here, for the work that you do every day, and to helping to move this field forward. We're very excited for what this conference will bring. With that, I'm going to turn things over to my co-executive director, Dr. Tom Saba, for a few additional remarks and instructions.
Thank you, Dave. Over the next 2 days, our course will be divided up into 7 sessions. In each of those sessions, there will be a number of speakers, and after those speakers are finished, there will be a time for questions. So please ask some questions, but save them till the end of all the speakers. There'll be plenty of time to ask those questions. For people that have posters to be put up at the poster session, the room is not quite ready for those posters yet, so you can give your poster to Ali or bring it down at lunchtime. You can hang it up at lunchtime for the afternoon poster session. You are entitled to receive CME credit for this conference, so keep your eye open for an email that you'll be getting, which will give you instructions on how to get those credits. So I also wanted to share that this conference has a little bit of a unique theme that many other medical conferences don't have, which is this is not just experts talking about their expertise. This is clinicians who work at the bedside. This is scientists who work in the lab. And these are families and patients who live with this condition every single day of their lives and know their bodies better than anybody. And the idea behind this conference is not for people to just share with everyone, here's what I know, but rather for us to ask questions to each other about what their expertise are and how we can work together to find solutions in heterotaxy clinical care and research. And I hope that at the end of this conference, we don't leave with a really perfect, great understanding for heterotaxy, but rather a list of questions that we aim to explore over the course of the next year. Dr. Shidlow will introduce our first speaker, and then I will take over moderating the rest of the session.
Okay, thanks, Tom. So our first speaker is Dr. Tal Geva. Dr. Geva is the Alexander Natus Professor of Pediatrics at Harvard Medical School. His major clinical and research interests are multimodality imaging of congenital heart disease. His research has focused on the use of echocardiography and cardiovascular magnetic resonance to define imaging biomarkers predictive of outcomes of pediatric and congenital heart disease. Together with collaborators from North America and Europe, he has established the Indicator Cohort, a multi-center international registry of patients with repaired tetralogy of Fallot. He has been a member of the American Society of Echo for more than 30 years, chaired the Pediatric Congenital Council in 2006 and 2007, and was the recipient of the Council's Teaching Award in 2014 and the Founders Award for Lifetime Achievement in Echocardiography for Pediatric and Congenital Heart Disease in 2024. On a personal note, Dr. Geva's passion for complex congenital heart disease, especially heterotaxy, has inspired countless trainees, myself included, to strive for excellence in patient care and research. He has been extraordinarily supportive of the heterotaxy program at Boston Children's, helping it grow into a model for other centers across the country. With deep gratitude and respect, it is truly my honor to welcome my mentor, colleague, and friend, Dr. Tal Geva, as our first speaker today.
Thank you, David. I could use some help,
Yes.
I guess. Terrific. Thank you so much, David. And I just want to share with the audience how much I appreciate the invitation, how much I appreciate David's enthusiasm and pursuit of setting up a comprehensive program for heterotaxy syndrome. This is something that was certainly missing, and putting the patients in the center of all of this. Us cardiologists, pulmonologists, immunologists, gastroenterologists, surgeons, and scientists, that's all super important. Having the patients in the center is even more important. With that in mind, what I would like to dedicate this talk to the memory of my teachers, Richard and Stella Van Praag. Stella was the person who introduced me to heterotaxy. Those of you who didn't know Stella or haven't heard about Stella, she was a pediatric cardiologist who grew up in Crete during World War II, which was quite influential in terms of her life. She was just the most wonderful person, and amongst many other things, she was fluent in classical ancient Greek and was able to read original texts. So some of the definitions here translated from Greek is thanks to Stella. There's just not enough time for me to tell you how influential Stella was in my life. And Richard is just a giant in the field of cardiac pathology, morphology. And the two of them, a husband and wife, were just giants in our field. Richard just died at the age of 95 several weeks ago. So, my topic is heterotaxy nomenclature, and where we were, where we are, and where we are going. And what I'd like to do in this talk is to just spend a moment on why nomenclature matters, what's heterotaxy syndrome, which I promise, I know that this audience is familiar with that. How did we get here, current state, and where we need to go, or where I think we should go. So the cartoon on the right essentially suggests why do we need to spell out things that are seemingly obvious. Nomenclature is a system of names or terms or the rules of forming these terms in a particular field of art or sciences. It's a theoretical field of studying nomenclature, is something referred to as onymology or taxonomy. And the reason or reasons that we need nomenclature is that it provides a common, precise, and standardized language for communication. Without it, it's the Tower of Babylon. We would not be able to communicate effectively with one another, and we won't be able to analyze data in a meaningful way. We won't be able to compare and draw conclusions in any meaningful way. That's why nomenclature. As I promised, I won't spend too much time on what is heterotaxy, other than to remind everybody that it's defined as incomplete or inappropriate lateralization of the thoracic and abdominal organs. I'm actually quite curious as the field evolves whether or not there are some issues with the brain and other organs that we don't pay that are not currently we don't pay too much attention to. The origin is from Greece. Hetero is other or different, and taxis is order or arrangement. So a different arrangement, it refers to the visceral organs. And the etiology, as we understand it today, is a developmental abnormality of the normal process of left-right asymmetry. It's tightly genetically controlled. It's an embryonic process that begins approximately at age 3, so 19 to 21 days after fertilization. Oftentimes, the mother doesn't necessarily know she's pregnant at that stage, but the left-right lateralization process starts in earnest at that point in time. And it impacts multi-systems involved with a highly variable anatomic and functional manifestations. The left-right patterning that is extensively studied by biologists, geneticists, now for quite a while is a highly, highly complex process. It's a foundational process during embryogenesis. And if you look at nature, you look at the most fundamental building blocks of structure in nature, from molecules all the way to the entire organism level. The concept of asymmetry is vital to life. And any abnormality in that process of asymmetry has major consequences in terms of phenotype and functional consequences. So this is on the left right here. I don't know if you can see an arrow. You can. So this diagram just shows the process here from very early on, the primitive streak that develops on the dorsal aspect of the there you go, of the embryo, is the location where the process of lateralization begins. And then you can see on the second phase here, the notochord developing, head fold, and then by 20, this is fish. by the time that you get to 24 hours in this fast-forwarding or fast-paced development, you can see the embryo with the head and the heart starting to loop. Let's see if I can make this. And this is just an illustration of the cilia in the primitive streak, causing the or moving around in a highly coordinated fashion that leads to a motion from right to left in order to initiate the process of lateralization. So we talked about the definition of heterotaxy, which is an impairment of that left-right lateralization process. And the diagnosis is established by a set of criteria as opposed to any single pathognomonic test. And that just has to do with the fact that we still have a challenge in terms of how to conclusively diagnose heterotaxy syndrome. This is this table summarizes the diagnostic criteria that we developed. This is back in a paper published in 2014, collaboration between geneticists, epidemiologists, and one cardiologist. And it was fun to negotiate that set of criteria. And what we came up with at the time were 8 categories. At the top, situs inversus totalis. Then that in itself would be would establish a diagnosis. And then in groups 1 through 8, having at least 3 features or more from a set of specific congenital heart disease, biliary atresia, situs abnormalities of the abdominal organs, spleen anomalies, isomerism of the bronchi, isomerism of the lungs, atrial appendage isomerism, and systemic venous anomalies. Looking back is fascinating. Turns out that you can go back to 330 BC, and and that's Stella's insights. Aristotle noted abdominal situs inversus in animals, and you can find that in his writings. And go and fast forward to the mid-1700s, a paper on partial situs inversus by Trochel, and then a series of either case reports or small case series that noted different aspects of heterotaxy syndrome. The paper from Ivermark in 1955 is very interesting and pertinent because he linked the embryogenesis of the spleen with congenital heart disease and was the first to note the link between splenic anomalies and a particular pattern of congenital heart disease. So polysplenia and asplenia and normal spleen. And Stella, many years later, noted that single right-sided spleen very much goes along with the congenital heart disease that you see in asplenia. The term isomerism was first mentioned in 1958 by Brandt and Labo, who referred to it when it came to the lungs. Van Meerop and Wigglesworth they are from the University of Florida, used it for the first time in the context of the heart and referred to right atrial isomerism. Richard and Stella in 1990 claimed or provided arguments why this concept is erroneous, and I'll touch on that in just a few slides. In terms of classification, the two most commonly used classification themes are either based on the status of the spleen, normal polysplenia, asplenia, or a single right-sided spleen, or isomerism that has been used to describe the lungs and bronchi, but also the right and left atria and the appendages. So these two classification schemes are most prevalent in today's literature. And certainly they overlap. Those who use polysplenia, asplenia, or single right-sided spleen can connect those to either left or right isomerism in one form or another. The truth is that there is a substantial amount of overlap between these two nomenclature schemes. And it is also true that neither one of those is actually adequate. Both systems rely on a pattern of cardiac and non-cardiac anomalies with only modest consistency. Isomerism exists in the lungs and bronchi, but in fact does not exist anywhere else. There's no isomerism of the liver, stomach, and spleen, and of course what's controversial is whether or not it exists in the heart. And there is modest at best relations between one of either nomenclature scheme and genetics and clinical outcomes. So, few words about isomerism. This is Richard and Stella's title in the paper published in the American Journal of Cardiology, saying that the atrial isomerism is an erroneous concept. They noted that isomerism came from Greek. Isos means equal, and meros, part, so equal parts. And they reminded us that the heart begins as a caudalocephalad organized straight tube that subsequently undergoes lateralization, and the heart doesn't start as a paired organ. And there's no cardiac segments that comprise equal parts. There are no two left-right atria, no two left ventricles, no two right ventricles, no two pulmonary aortic valves, and I think that you can get their argument here. And the atrial appendages, they can be similar to each other, but they are rarely identical. And in fact, the atrial appendages in heterotaxy syndrome is typically asymmetrically abnormal. In other words, they're both abnormal, but they're not classical left, they're not classical right. An interesting paper that was published by Louise Calder from New Zealand back in 2011. She's a pediatric pathologist, and she conducted a study of 306 specimen heart and visceral organs specimens. And of those, 250 were with cytosolitus and 56 heterotaxy. What she found was that in patients with heterotaxy syndrome, bronchial atrial discordance occurred in 16% of the cases. In other words, in 16% of the cases, you could have, let's say, for example, bilateral left bronchi morphology, or left isomerism of the bronchi, but the atrial anatomy would not be that of bilateral left atrial appendage morphology. And she concluded that, and that's a quote, "No feature is completely reliable by which to diagnose thoracic situs. Bronchial situs does not always correlate with atrial situs and vice versa." A more recent paper published in 2018, Circulation Cardiovascular Imaging, from my good friends at Sick Kids in Toronto, looked at 110 patients at cross-sectional imaging, CT and MRI, of 110 patients with heterotaxy syndrome, defined as splenic anomalies. And they identified about nearly 40% with asplenia, nearly 57% with polysplenia, and 4% with normal spleen. The take-home message from this paper is that 20% of patients exhibited an incongruent pattern using appendage isomerism and spleen. So the appendage and spleen status could not be determined in 15% and 3.5% respectively, which one way to look at it is that notion of either categorizing heterotaxy patient based on the status of the spleen or the concept of atrial isomerism is highly variable and unreliable. And I put this CT image down here in the right corner of the slide to make the point that they gave this example as one of a classic left isomerism and polysplenia. That actually one of the cases that in their view corresponded, there was alignment between the status of the spleen and the concept of isomerism. And I would argue that if you look carefully at these two appendages, they are not isomeric. They just don't, they both look abnormal, perhaps a variant of a left atrial appendage, but they're not mirror image of each other. So together with Steve Sanders, we wrote an editorial to this paper, and also this is my summary slide. And what we pointed out is that the existing classification system used in heterotaxy are only modestly predictive of expected anatomic pattern and are inadequate to guide diagnosis, therapy, or to determine prognosis. And we called for to develop a new paradigm for classification of heterotaxy syndrome based on genetics, developmental biology, sophisticated imaging biomarkers, and advanced statistical methods to distinguish between different risk groups. So my own perspective is that classification of heterotaxy should be informed by all of these analytical methods in order to risk stratify patients that can then inform management strategies. And the development of such new paradigm requires a robust prospective national and international registry. We need data, and I understand that work is being done in that direction, and I'm here to help in any way that I can or Boston Children's can in order to make this as robust as possible. Thank you.
Thank you, Dr. Geva. Okay, so I'm going to ask Dr. Shapiro, Dr. Wilson, Dr. Batlivala, and Dr. Geddes to come up and prep for the next talk. So as I mentioned a few minutes ago, one of my main objectives in this conference is to generate a lot of questions. I'm constantly jotting down notes in my book. What do these definitions mean for building a registry? How can we unify a definition nationwide that everyone adopts and feels comfortable with? So this next talk is intentionally presented very early in this conference because we have 4 experts in their respective fields who are here to present to you what are some of the main questions in their unique fields of practice that we should try to address over the next year or so. We have the 4 talks. When you're ready, you could just pull up your talk, everybody. Is that okay? Yeah. Your 2 slides. Okay, so we have Dr. Batlivala, Associate Professor in Pediatric Cardiology at Cincinnati Children's Hospital, who specializes in interventional cardiology. We have Dr. Joe Wilson, an Assistant Professor in Allergy, Immunology, and Rheumatology at University of Wisconsin, who does extensive research in immune disorders and heterotaxy and respiratory mucosal biology. We have Dr. Geddes, who's an Associate Professor of Clinical and Medical Molecular Genetics at Indiana University, who specializes in cardiovascular genetics. And we have Dr. Adam Shapiro, Associate Professor in Pediatric Respirology at McGill University in Montreal, who's the Medical Director of the North American Clinical and Research Center for Primary Ciliary Dyskinesia. And although you're going to have a lot of questions for these presenters, let's keep them till the end of the session, please.
Good morning, everybody. I'm Sean Batlivala. I'm a cardiologist at Cincinnati Children's. First, I want to say genuinely thank you to the organizers for inviting me. I was very excited to learn from Dr. Shidla, who we trained together here, that this group exists, because I've been very interested in trying to develop this exact type of program in Cincinnati. So I really appreciate it. Thank you all. So the topic was kind of the future directions or needed areas in cardiology or in heterotaxy. So from a cardiac standpoint, Dr. Geva just said it best. Completely agree. Standardizing definitions is really important, and not to go off on too much of a tangent, but and I know we all know this, but the words we use matter. So for instance, we will sometimes see patients where people will talk about a collateral versus it might just be a normal blood vessel. That's one small example, but really understanding the words that we use, because it has implications for how we treat patients. I think it's crucially important. And I trained here. I'm a student of Von Prague also, Cincinnati. We had a chairman who was from a different kind of persuasion in anatomic definition. There's a Dr. Anderson, and they're both brilliant. But that also, that there's a disconnect there, and we'll oftentimes be saying different things about the same patient. So that's crucially important. Along that line, trying to identify if there's different isomers of specific outcomes. So for instance, one thing I'll mention tomorrow, and one of the reasons I got really involved in heterotaxy is certain patients with what is called the left atrial isomerism group will have significant abnormal venous connections that have very significant implications for their care, specifically with things related to like heterotaxy and shunting. Understanding those differences and trying to understand those outcomes is obviously crucially important. This is actually work that's going on great, and I know this seems like a fancy picture, but the point is the new advanced imaging techniques are really helping, and they've been really helping surgeons. And again, Dr. Ho, I know there's some great surgeons and cardiologists here. To the cardiologist, this is probably not as exciting of a picture as it seems. But it's been very helpful for preoperative planning. For my work in the cath lab, it's actually been very, very helpful to do 3D reconstructions. And we'll actually use VR headsets to put on, and it instantly, the saying a picture's worth 1,000 words, it will instantly make my approach in the cath lab just much more effective, because I'll be able to go in and kind of have a targeted way that I'll approach the case that wasn't possible before. Hepatic factor is, I think, a hugely important thing. It's something that I'm interested in, and one of the things that I think we can talk about is from a catheterization standpoint, it's dawned on me a few years ago, the cardiac cath lab is one of the few places in the hospital where we get blood samples from different parts of the body, right? When you go to the lab, you just get a phlebotomy from your vein. I've been banking a significant number of samples from SVCs, IVCs, hepatic veins, pulmonary arteries, pulmonary veins, to hopefully start teasing this out. And quite honestly, and we'll talk about this tomorrow, I need help with some of this. I've done a little bit, but would love to work on that with people. And then the last thing, I'm not an electrophysiologist, but understanding the conduction aspects of this. We joke in cardiology that oftentimes electrophysiology is sort of an not well understood even among cardiologists aspect of things, and that they'll oftentimes be doing their own thing. But as Dr. Gava showed, all those significant abnormal anatomic variations, the cardiac conduction system flows through much of those same patterns, and it's not very well understood. And understanding that obviously will have important impacts for our patients. Thank you.
That's not. Good morning, everybody. I'm Dr. Wilson. I am at University of Wisconsin-Madison, and my organ is going to be the spleen. And I thought this was a really interesting way to start off the day. So there's a lot of interesting questions in heterotaxy to do with the spleen, but I chose to focus on one thing that interests me in the diagnostic realm and then one thing in the therapeutic realm. So my slides are a little bit text dense, so I'll kind of walk you through them. But we know that our patients with heterotaxy struggle with splenic dysfunction, and there's many different forms of that, as has already been presented this morning. And testing our patients and the degree of splenic dysfunction that they have is really important early in life. Historically, we relied on the Howell-Jolly body, which is something that you can see on a standard CBC to look at splenic function. But as many of you already know, you really only see that in profound splenic dysfunction. So it's not sensitive for our patients that still have splenic dysfunction, but have some preserved function where they don't have those Howell-Jolly bodies that you see on CBC. So one big advancement in our field has been the discovery of pits or pocks that you can see with phase microscopy. So we use this in our clinic often, and you'll hear a talk later today that talks a lot about this too. There's a picture at the top of the screen that, and on the left side is where you see these Howell-Jolly bodies. It's this blue thing here in the red blood cell. And then in phase D here, this is the phase microscopy where you can start to see these pocks develop. So this is something that naturally happens to an age red blood cell, and the spleen is sort of responsible for removing these from circulation. So this becomes our more sensitive and more reliable marker of splenic dysfunction in our heterotaxy patients. And so we consider greater than 4% abnormal, but greater than 10% a marker of severe lack of function. But my big problem with this, and where we need more research in these patients, is that it's not super reliable in neonates. So neonates naturally will have more pocked or pitted red blood cells. And as we'll talk about later in my next talk this afternoon, these are our highest risk babies because sepsis happens early on in life. So we really have to find a way to identify the patients that have worse splenic function and the children that are highest risk. The next thing that I wanted to talk about in terms of the problems or areas where we need further research, and we'll talk about this later today too, is antibiotic prophylaxis. There's so much disagreement in the field with what's the right way to do this, and the reason why there's disagreement is that there's just not good data. And so we really need to collect more data so that we can accurately prepare our patients for what are their best options after 5 years old. So as we'll talk about later, before 5, there's really great agreement that everybody needs antibiotic prophylaxis. But later in life, there's 2 big problems that we just don't know the answers to. One is we just don't know the landscape of antibiotic resistance in people that are on lifelong prophylaxis. And if we can't prepare our patients for what the risks are, it's really hard to ask them to sign on to lifelong daily prophylaxis. Adherence is another huge problem. There's many studies that show that adherence is really low when we prescribe these lifelong regimens. So the answer to this is really knowing more information, collecting more information so that we can appropriately prepare our patients for the future.
Hi, I'm Elle Geddes. I'm a cardiovascular geneticist in Indiana, and my slides are much less entertaining than our other speakers so far. But when they first asked me about unexplained, unanswered questions in heterotaxy related to genetics, my thought was all of them. And so one thing that we see is we'll often see people call heterotaxy a syndrome, and that's been a historical name for it. But in genetics, syndromes have a known cause, and we don't know the cause of heterotaxy. And so it can be very difficult to sort of classify things. We talk about associations where there's patterns of anomalies, but like we've just gone through, the patterns are not consistent. And hopefully in my talk a little later, that will make a little bit more sense. And so how do we improve diagnostic, genetic, and genomic testing? Because in most patients, we still don't find a clear answer. And we know that the genetics of heterotaxy seems to be more complex than a sort of one gene, one disruption, one phenotype. And then, so how do we quantify those multigenic effects and interactions across multiple different genes that are either in a pathway or in a mechanical system together? And then finally, how do we understand genotype-phenotype variation? Because we know that patients in the exact same family with the exact same change have different phenotypes. And hopefully we'll have some insight to that as well. But how do we predict that, and how do we know when we're trying to predict what's happening, why those differences are occurring and what they mean for clinical care and ultimately outcomes? And so I think when we're thinking about genetics, we have to think about creative ways to analyze genomic information, throw out some of our old conventions in thinking about how to define and classify heterotaxy molecularly, and then try to find some sorts of ways that we can predict genotype-phenotype variation, which would involve lots of registries and things, and I think will be a very, very difficult thing to do. And when I say my slides were boring, this is it. So, so I think that genetics has a lot of potential if we put our heads together and get a little creative in how we're going to, again, put things together. Because some changes that maybe it's a combination of 20 different changes, which is why you have laterality anomalies. And then there's an aspect of randomness to it too, which again, a little spoiler for what I'm going to talk about a little later. But I think that the most important thing is how do we identify patients that would benefit from specific care from our partners in immunology, our partners in cardiology, our partners in pulmonology, and all our partners. And so I think that those are the big questions. And so it's kind of a really frustrating and really exciting thing to think about, because there's so much potential, but there's also so much unknown. Thank you. Sorry.
Hi, everyone. Sorry, just pulling this up real quick. And there we go. Great. So I'm Adam Shapiro. I'm a pediatric respirologist in Canada, a pulmonologist to you in the US, but in Canada we respire, we don't pulmonate. So I wanted to talk to you a little bit about a disease you're going to hear quite a bit about today called primary ciliary dyskinesia. So this is a disease where there's defective mucus clearance from the upper and lower airways caused by more than 60 different genes, and it's caused by a type of cilia that's found called motile cilia throughout the body. You heard about one type in our opening cardiology talk today, the embryonic nodal cilia, and you have problems between that and respiratory cilia after you're born. So the cilia don't beat correctly, as you can see down at the bottom, they're stiff or dysmotile. And you get a lot of mucus buildup and you develop chronic ear, sinus, and pulmonary infections. Many patients go on to have bronchiectasis, which is irreversible airway dilatation or scarring, and respiratory failure in their 30s, 40s, and 50s in some patients. And the reason that this is being talked about at a heterotaxy conference is that about 50% of the people with PCD, or primary ciliary dyskinesia, have situs inversus totalis, where your organs are completely flipped, but about 12 to 24% will have heterotaxy, and that can include heart defects, and it can include all sorts of organ defects that don't involve the heart. And so that's why we're talking about it today. When we look at people with primary ciliary dyskinesia, and we look at their laterality defects and heterotaxy type defects, we know that those people with heterotaxy and PCD do much worse than people with PCD and, say, situs solatus, normal arrangement, or situs inversus totalis. And we don't really know why they do so much worse. It seems to be associated with more severe congenital heart defects needing surgical repairs, or with splenic architectural defects. And no one has gone through and looked at the splenic function in all of these children. If you're not getting sepsis, normally we don't look for it. And should we be looking for it? Is there an intermediate form of splenic dysfunction that we're not appreciating? The other thing we know is that most of us lung doctors are pretty bad at looking for laterality defects, as Yadira Rivera-Sanchez will tell us about later today. And we'll often miss those. And what clinical impacts does that have when you're walking around with intestinal malrotation that may or may not volvulize? Seems like it's less likely in heterotaxy by the reports, but we don't know for certain. And then we know that not all forms of PCD get the same amount of laterality defects. So there's one gene in particular, DNAH5, which causes about 20% of all PCD, and there are many, many more laterality defects seen in that. When you compare to other genes like CCDC39 and CCDC40, there's no patients with congenital heart disease that are seen with those genes, but still a lot of laterality defects. So we don't understand what the quantitative and qualitative effects on embryonic nodal cilia beating. We don't know what those effects are by genotype. We don't really know if loss of function versus missense variance affects embryonic nodal beating and cilia dysfunction more or less, and that's why some people with some genotypes of heterotaxy or PCD get more or less heterotaxy. And we don't know if there's a survival bias or genetic modifiers. It might be that all people with CCDC39 or CCDC40 actually die in utero or die early in life before you have time to really define their laterality and heart defects, because those are two of the more severe forms of the genes that cause respiratory dysfunction. Those patients do much worse from a respiratory standpoint as life goes on. And then if we reverse it and go the other way and look at children with heterotaxy and try and understand how many of them have PCD, it's still completely unclear. It's better than it was a decade ago when I started doing this. We now know that if you genotype a large collection of patients with congenital heart disease with or without heterotaxy, you can find PCD in 0.2 up to 40%, depending on how consanguineous that population is. So it's all over the board. We don't know what the best genetic diagnosis for PCD is in people with heterotaxy. We think it's genetics, but you're going to see some work with high-speed video microscopy and other presentations from other researchers in this conference. And then outside of classic PCD, when you can't really diagnose classic PCD based on the set of diagnostic criteria that I'm going to talk to you a little about later, is there an underlying respiratory cilia dysfunction called heterotaxy-associated ciliary dysfunction? in vitro studies of high-speed video microscopy of ciliary beat patterns and nasal nitric oxide levels suggest yes, there is. But we have no in vivo studies to prove that these people actually have decreased mucociliary clearance. What if you have multiple hits and multiple PCD genes, heterozygous hits, but not two biallelic mutations? Is that enough to affect your mucociliary clearance and make your outcomes, especially around times of stress, i.e. congenital heart disease repairs? Will that make your respiratory outcomes worse? What is the prevalence of severe respiratory outcomes in patients with heterotaxy? We really don't know. It's been reported in small cohorts. And then finally, are there benefits to me going in and telling your cardiologist and cardiac surgeon, delay the surgery for 2 weeks so we can do good airway clearance antibiotics, and have them laugh me out of the room when I say that? Okay, so we don't know. And then the last question is heterotaxy a ciliopathy? Should we be looking at the brain, the kidneys, the bones, to try and pick things up that we're completely missing, because this is a body-wide problem caused by cilia? We just don't know. So looking forward to trying to answer some of these. Thank you.
Okay, thank you to our panel. We will invite you back at the end of the session for questions. So as we move on this morning, we will invite Dr. Sarah Morton to discuss a little bit about prenatal diagnosis and what this all means to a family when they find out that their child is going to indeed have heterotaxy. Dr. Morton is an assistant professor in neonatal intensive care and a physician scientist at Boston Children's Hospital, and her research focuses on the genetic factors leading to congenital heart disease and heterotaxy.
Great, thank you so much. Thank you all for the opportunity to be here today. I am glad to speak to you about the neonatologist perspective on heterotaxy. Oops, sorry. And so I have no disclosures relevant to the content of these slides. My main disclosure is that I am a developmental biologist, a research geneticist, and a neonatologist. So I have many different perspectives on all of the different topics coming up today, and really look forward to all of your thoughts. What we'll talk about with you briefly today is one example of a family's experience with prenatal diagnosis of heterotaxy, what it is that we are able to share with families in those early first days of having a diagnosis, but how that might link to later lifelong outcomes. And then finally, I'll talk about multidisciplinary care, because I am someone who loves taking care of my smallest patients, but there might only be 1 or 2 patients who have heterotaxy that we care for in a year. And so it's really this large multidisciplinary group that we all lean on to get the best possible information to each family. In particular, when we talk about prenatal diagnosis, most of the evidence in this area has focused on neonatal mortality as one of the outcomes. So that's a lot of what I'll tell you about right now, but wanted to focus on kind of when that doesn't happen by telling you about a particular patient. And I'm sorry, I am a Mac native, and so some of my figures did not translate well to the Windows world. And so this was a family who in the 12th week of pregnancy had initially had a twin pregnancy, and there had been the loss of 1 twin at 12 weeks. The surviving twin was noted to have an omphalocele, which you can see right there with that little green arrow. It was very small, not particularly large, and thought to impact lung development or anything. And there was a 2-vessel umbilical cord. So already a lot of heavy information for the family at that first 12-week ultrasound. Just 3 weeks later, improved resolution showed that there was now complete atrioventricular canal diagnosis, as well as some cerebellar malformations that were noted for the family. Came to our hospital, had an MRI at 20 weeks, and this was the first sign of heterotaxy, which was that the stomach was on the right, and so had some kind of difference in visceral organ placement. And so this was the first time that heterotaxy was discussed with the family. Baby was delivered at 38 weeks, was a rock star, so vigorous at delivery. APGARs were 9 and 9, gave us no problems. Didn't need any early respiratory support. We basically took an ultrasound probe and went head to toe with this small young man, did confirm the right-sided stomach. There was a midline liver and asplenia. He had an echocardiogram completed that showed complete atrioventricular canal with a double outlet right ventricle. He did great. He was in room air. He never needed any significant respiratory support during his NICU admission. He did ultimately have a ciliary biopsy done that was negative for PCD. He did come back at 2 months, and it was not PCD that was his problem. He actually had a Morgagni hernia, so ended up having that repaired also. And so that's where his diaphragm had kind of incompletely attached to his body wall, leading to respiratory distress. He did have overcirculation related to his congenital heart disease, ultimately had cardiac repair first at palliation at 6 months, and then underwent a Fontan procedure at 3 years. His omphalocele was no problem at all when he was a week old. Our lovely surgeons tucked that little bit of tissue back into his abdomen, and he went home on full ad-lib feeding. He did ultimately, as a school-aged child, get ciprofloxacin for appetite stimulation, and that was the only intervention he really needed to maintain on an appropriate growth trajectory. He had Hal Jolly bodies, and so he was nice and obvious for us. Also, there had been no spleen on the ultrasound, so he did get his amoxicillin prophylaxis, and then ultimately was found to have hypogammaglobulinemia. One thing that made his presentation a little more unique is he actually had an extension of his spine, and so that was actually one of the more notable parts of his care. So he had a lot of follow-up by neurosurgery and actually grew into his spine just fine and did not have any problems with his lower motor function. And so these are some happy pictures of him. He's always been a delight. And just to really show that, you could see the paragraph of all of his diagnoses, but actually his quality of life is quite high. And so I think it's always that balance as a neonatologist between these terrible words that someone may go Google and the actual life experience. And so our job in prenatal counseling is to try to provide information so parents can be as informed as possible as they make healthcare decisions in the future, but also know that they don't necessarily, I always say never read anything about patients before 2010, because there is a lot that was true, but is not relevant to the life that your child will have. And so we kind of balance those messages in counseling. And so at 2 years, he was meeting all of his milestones for development. And so his was a case of how early heterotaxy can be developed. And again, I apologize for the blurring of the images, but really ultrasounds as early as those kind of very first scans looking for fetal viability at 12 weeks can start to provide information that heterotaxy might be present. And this is mostly in the case of seeing some visceral isomerism. There's also, with our increasing resolution of prenatal echocardiography, more and more often atrial isomerism is detected prenatally as well. As has been shown by many people in this room, prenatal echocardiography can help show heterotaxy, in particular because I just think the resolution we have with fetal echocardiography kind of excels beyond that of what we often see with our ultrasonography, especially depending on the habitus of the pregnant person and many other features. And so the whole reason to find one of these is not only to provide the diagnosis, but I in the delivery room will behave differently if I have a sense of what type of congenital heart disease might be present, right? We might target a different oxygenation. I might not be concerned if we can't get the oxygen, the baby's oxygen into the 90s, right? That might be an appropriate transition for a baby who's always going to have a lot of intracardiac mixing. There are certain other kinds, as was highlighted by this study as well, any kinds of congenital heart disease that are ductal dependent. We roll into that delivery room with our prostaglandins and a plan to have one nurse whose only job is to place that PIV, right? So our whole team's structure of how to resuscitate an infant is hugely guided by this prenatal information. And so just, this was also, just looking overall again with more evidence just showing that knowing the exact type of CHD can help guide that initial time, not only with our initiation of prostaglandins, but also how long we might stay in the NICU before transitioning to the cardiac ICU. So we'll hear a lot more about genetic testing, but this is a rapidly evolving field, both in terms of what types of testing can be offered, as well as how we can interpret the variants that are identified. This was a meta-analysis that put together many different studies of heterotaxy. They had almost 2,000 pregnancies in the combined data set. And everyone was ascertained based on having fetal congenital heart disease. And actually among that group, as is often the case, people lumped together complex congenital heart disease and heterotaxy into a single diagnostic category. But that was the category that had the highest increase in yield from having exome sequencing compared to microarrays. So microarray is often the first level test for individuals with congenital heart disease. It's excellent at finding deletions and duplications, but is not able to discern single gene variants. And as we heard, especially because a lot of our genotypes might be recessive and might be single gene disorders, we're not really catching those as much with microarray. And so just thinking about CHD in particular as an indication to consider a prenatal exome, but also our more complex forms of congenital heart disease. And so then when we counsel families, what do we have in those initial meetings that can help us know exactly what to plan? How long are you going to plan to be in the hospital for that first period? Because many families will only get a certain amount of weeks off of work, and maybe you want to take it not at the beginning, but towards your transition home. That kind of information is actually very pragmatically helpful for families. And so these were two different studies from a lot of people in this room again, but looking at two different centers that generally the overall survival is really increased over the past decades. And so if you look historically, the survival was less than 50% once you got into adolescence. But now at both of these centers, we're having survival to 70 or 80%. And that is not just because of advances in congenital heart disease surgery, but as we heard about, also advances in how we take care of the risk for serious infection, because that in itself is also a strong risk for mortality in the first years of life. I really loved this gray graph. Every line there is a person, and this was their path through cardiac repair. And so what I really loved about this was that, you know, we can't always state the course at the beginning of exactly how someone is going to proceed through their cardiac surgeries, but the idea that regardless of which path people were taking, this mortality overall is really been improved in the past decades. So survival is one thing that people often want to know about in the prenatal period, knowing that there is often fetal demise with heterotaxy. And so this was a study done here at Boston with about 158 pregnancies where there was fetal heterotaxy. And this does span a good number of years, which is why there's enough kind of episodes for us to learn from, but also knowing that this was a more historical time periods, we would only expect these outcomes to be better since then. And so overall, there was a less than 10% rate of fetal demise, but the strongest predictor was the presence of fetal bradycardia or AV block. And so really being able to identify those fetal heart rate anomalies was most important in this group. And all of those arrhythmias happened in fetuses with polysplenia and none with asplenia. And so that's why the splenic status combined with the heart rate analysis was able to give us the best information in terms of thinking about fetal demise. When looking at early mortality, so this is within the first hospitalization after birth, this was where in particular the group with asplenia faced a much higher risk of mortality, and in particular those with pulmonary vein stenosis or extracardiac anomalies in the multivariate analysis where you can kind of control for all of the complex factors that might affect survival with heterotaxy. Those were the two that really stood out. And so when we're doing our prenatal counseling, when we see extracardiac anomalies like the omphalocele that our young patient had, those are things that might point us to tell a family to anticipate perhaps a longer initial hospitalization. And then obviously just thinking about this with the PCD always being in the background, that there is evidence that PCD is associated with a higher rate of respiratory distress after birth, especially among term infants. And so just keeping that in mind, that sometimes the breathing alone, not even the cardiac status or other extracardiac anomalies, might not affect survival, but the expectations for that initial length of stay in the NICU might be different. Another very high-risk feature is hydrops, which I always hate all of these incredibly phenomenologic terms, right? Like hydrops sounds like we could have diagnosed it 200 years ago, and we probably could have. And it's basically, right, when there's just such a huge amount of tissue edema, but it's profound because it affects every organ. Like you don't just have hydrops that's like edema. The hydrops it's in your gut, it's in your lungs, it's everywhere. And so that is really one of our strongest prognostic signs for survival. And so this was, again, a study, it was a relatively small number of fetal deaths, and so there were 19. But in terms of looking at those, and so it was a cohort of 19, and so in terms of looking at those who were non-surviving, there was a higher association with hydrops there. And then looking at postnatal death, hydrops persisted in being difficult. And so I think that's actually true for hydrops regardless of whether or not there's heterotaxy, but is sometimes one of the indications for early delivery, because the concern is if the hydrops progresses, it will actually exceed the risk of prematurity in terms of overall survival. And then so this is the part that I will be brief about just to stay on time, but thinking about the multidisciplinary care. And so this is where each of you in the room with your own perspective is really meeting with the families postnatally. And so what's on these slides are the things that I know to say as a neonatologist, but I always look forward to each of these topics being updated as we continue to learn more in the area. And so there was this lovely paper that was published in the past few years, just really saying, you know, if you are meeting a patient who has heterotaxy, what are the things you really must do to provide high quality care for that infant? And so this was just breaking it down by systems. And so obviously everyone here knows to assess for cardiac anomalies. It's rare, but there can be craniofacial anomalies. In particular, there can be differences in the palate that might affect feeding safety that can't always be seen just when you shine a light into their mouth, but sometimes can be more posterior. We always get a abdominal ultrasound pretty early. In particular, protosystemic shunts are another feature that are associated with longer term risks to health. And so identifying those early so that all of our plans are appropriate. We'll hear a lot about intestinal health, but all of us are, you know, you never want to miss malrotation if you end up having volvulus in your unit. And so we always are very careful when monitoring feeding tolerance, when placing any kind of enteral tubes. We want to be sure that it's placed in an appropriate location for that infant's anatomy. And so being aware of any malrotation is important. We heard about the immunologic phenotypes. The blood you have to send to do B and T cell profiling is inappropriate volume for most infants, and so we don't routinely send it in those first few weeks, but we make sure that all of our patients have immunology follow-up for B and T cell characterization later in life. We tend to always do a head ultrasound. This great question has come up of, you know, how is laterality different in the brain as well? And so we've been looking into that in the fetal period because there's so much that happens postnatally that could lead to secondary changes in brain structure that, you know, we get the MRIs to have our baseline sense, but then we're also very interested in kind of how the patterning might be different. And a different brain structure doesn't always mean a different brain function, right? And so that's something that we always are very clear about with families is we also care for infants who might have strokes of the extent that would stop you or I from functioning. But babies can actually continue to develop in a very resilient way. So just always having that balance of hope as well as information when we look at brain MRI in particular. We often work with our pulmonologists to get more of the pulmonary phenotypes. I know this often comes up because in one of our papers with the Pediatric Cardiac Genomics Consortium, when we looked at risk factors for outcomes after cardiac surgery, having a cilial gene variant was actually one of the major risk factors for prolonged intubation. And so it was very sympathetic to the idea of thinking of pulmonary optimization, both pre and post-surgical. And then, you know, the other things that we always look at, just getting ultrasounds to look at kidney and spleen function. And then I work at a center where almost everyone has esophageal atresia, so we just always look for vertebral anomalies. It's kind of what you do when you get admitted to our NICU, and that is a part of our heterotaxy evaluation as well. So we'll hear more about pulmonary health in the future. And again, I'm very sorry for the pixelation here, but it was just showing that infants with heterotaxy and primary ciliary dyskinesia are more likely to have a hospitalization event, but that was actually true. So it's even more likely if someone has situs inversus and pulmonary ciliary dyskinesia as compared to pulmonary ciliary dyskinesia without situs inversus. So just saying that those patients who have the overlap of those two diagnoses do seem to have the highest risk for requiring hospitalization. We'll hear a lot more about malrotation. This, as a neonatologist, feels very uncomfortable to know that there's malrotation and not always surgically corrected. And so that is one place where I know we're having a lot of evolving care along with our surgeons, because it is another procedure. It's a exposure to anesthesia during a time when a lot of your neurons are migrating to have their best possible function. And so it's not that everyone has to have a LADS, but it is something we always pass off and hand out, because it's a very different evaluation if someone does have signs of bowel obstruction. And so approximately 70% of infants will have malrotation if they have heterotaxy. One study that looked at over 1,000 infants with heterotaxy did find that there was about 6% rate of volvulus, midgut volvulus, in infants who weren't screened. And so that's where we always want to at least have the information to know how to respond to those events when they happen. And then of those infants who do have a LADS procedure, and this was a study of about 5,000 of them, those who had heterotaxy had a much higher rate of post-operative complications, and not just respiratory, but actually, which makes sense with immune function, having a higher rate of wound dehiscence, which is obviously a serious complication that can really prolong hospitalization. And so we always balance those risks of adverse outcome with the benefit of having the LADS. And I think we'll hear a lot more about that this afternoon. We'll also hear more about the hepatobiliary screening, but for us, I actually found that this portosystemic shunt diagnosis has been one of the biggest for how we consider our care, monitoring ammonia levels, and otherwise just making sure that the shunt is not causing any difficulty for the infant. And then I feel like we work everyone up for biliary atresia, right? Because there's such a short window for ideal operative repair of biliary atresia. And so in heterotaxy, we have a very low threshold for proceeding to HIDA scan. We'll hear more about infectious risks, and we started to hear about it a little bit this morning, but there are a couple of very lovely algorithms that have been published, both for kind of when to start prophylaxis, which is the top one, and how to respond to an infant with concern for infection. And so just the idea that a fever is not to be responded to in the typical fashion, but there's such a higher risk for invasive bacterial infection, especially for encapsulated organisms. And so having that shift how extensive your evaluation is and which antibiotics are used. And then genetics, which we'll hear a lot about later. But so when people have grouped individuals with congenital heart disease based on a difference in laterality, when people do detailed deep dives into the potential causal genes, you can find potential causal genes in almost everyone. The difference is moving that from some sort of scientific evidence to having the grade of information that lets us give a clinical diagnosis. And so I think that's where a lot of us are very excited in developing new models to be able to evaluate that. And what you see down here is this was another lovely study that came out recently that was just looking at what tests should be sent. And it was showing that infants with heterotaxy, about a third of them get their diagnosis by microarray, the other 2/3 by exome. And you know what? If you did genome sequencing, you catch them all in one test that will come back usually in 1 or 2 weeks. So just showing that genome sequencing doesn't lose any of the previous diagnoses and should be heavily considered for infants with heterotaxy. So we've gone through all the systems. I really am excited to hear about how each and every one of you, as we talk, will update those slides for new things we should be doing. But thank you again for being here today.
Thank you, Dr. Morton. Next, we will take a little bit of a deeper dive into the underlying pathogenesis of heterotaxy. What are some of the genetic factors that contribute to the pathogenesis, and how do those molecules work in utero to actually cause this phenotype? We met Dr. Geddes already, clinical and medical and molecular geneticist from Indiana University. Is this the right one?
Yes. Hi again, thank you all so much for inviting me to come speak to you. I have no conflicts of interest or disclosures, other than I guess I have a lot of passion for patients with heterotaxy. And so we're going to talk about and be really focused on how laterality is established. This is to give a foundation to better understand why patients with heterotaxy can have the spectrum of findings they do. Then we'll also review one gene and how it's been understood over time to affect laterality to sort of illustrate the complexity of the process. And when developing, there are 3 axes or sides that are defined. The process is generally thought to be highly conserved across all vertebrates and even some invertebrates. This fairly universal conservation means we've been able to learn a lot about these 3 axes from animal models. The anterior-posterior axis differentiates head from tail, and the dorsal-ventral axis differentiates belly from back. The naming for these first 2 makes much more sense if you picture it from our 4-legged relatives' perspective. And then the last one is the left-right axis, which this is the main axis we're interested in here. Though if either of the prior 2 axes are also disrupted, the left-right axis is disrupted too. The exact order of events is unclear, as the majority of this happens in the first 2 weeks of development. There have even been some researchers that suggest that the axes are established as early as the 2-cell stage. But evidence is still lacking as to what exactly is occurring and what the exact order is. But it's clear that both the anterior-posterior and dorsal-ventral axes need to be defined prior to left-right, as they're required to orient left-right. And so I'm going to try to briefly summarize the developmental process in left-right axis determination with a fairly generalized big picture approach. I'm keeping to generalities partially due to time, but also, as previously mentioned, there's still some uncertainty related to the exact details, but the majority of publications seem to be in agreement. And so the node, as we saw in our first talk, is a ciliated embryonic cavity established at the anterior aspect of the primitive streak, critical to multiple aspects of development. The node plays a functional role in establishment of laterality, though laterality is at least partially established by cellular signaling that happens upstream of the node prior to complete node formation or presence of cilia. And then both cilia within and surrounding the node further define laterality. Cells within the node are monociliated with rotary modal cilia that share configuration typically attributed to sensory cilia. The nodal cilia will begin to have a clockwise rotation, which begins to circulate fluids in the node from right to left. While the modal functioning of these cilia within the node break the symmetry in this action, it's actually the sensory cilia that are on the cells surrounding the node that result in the embryologic developmental changes. These changes in flows cause different gene expression at the lateral plate mesoderm and ultimately affect organ formation. And molecular genetic information we have supports the importance of the node and ciliary function to establish laterality. This is a critical part of research and understanding the process. When you can identify underlying genes guiding the process, you can then begin to alter models to both better understand that gene's function as well as get a better overall picture of the developmental process by seeing where specific disruptions affect specific steps and what the effects are. So we're going to dive into this a little bit more by focusing on one gene and the evolution of understanding and its role in heterotaxy over time. And so to illustrate some of the concepts related to how laterality is established, we're going to focus on ZIG3. ZIG3 is an interesting gene for a number of reasons. It's X-linked. It's still the only X-linked cause of heterotaxy we've identified. I'm not going to be able to do the story justice here, but as we're going to see, ZIG3 also has direct implications for node formation as well as ciliary function. This allows ZIG3 to be a unique research target and to learn about heterotaxy and establishment of laterality. Focusing on ZIG3 also allows me to focus a little on one aspect of my partner, Dr. Stephanie Ware's work in heterotaxy, which is an opportunity I'm always happy to take. Now, Dr. Ware's first paper on ZIG3 came out in 2002, but we're going to start with one a few years later in 2004. As an aside, in 2002, I was tweezer feeding pieces of baby brine shrimp to inbred jellyfish under a microscope, and I'm pretty sure all I understood about genetics was Punnett squares. So, but this paper describes 5 patients with ZIG3 variants identified within a cohort of patients with heterotaxy or isolated cardiovascular malformations, and also reviewed a few other published variants. Based on the location of these variants and what was understood about ZIG3's function at the time as a transcription coactivator, they were able to show their variants resulted in decreased transactivation of an SV40 luciferase reporter. This bar graph shows the different ZIG3 variants they tested across the bottom, and then shows the level of luciferase activity relative to the controls. They also looked for nuclear co-localization of this transcription factor and found that a number of their variants resulted in abnormal presence of ZIG3 in the cytoplasm of the cell. And so this first vertical pane shows the location of ZIG3 for each variant tested in red. The second one shows the nucleus for the same view in blue. And then this last pane is the overlapping. And so you see in the normal ZIG3 function, panel C up in the corner here, there's a complete overlap. And then the lower 4 pictures, F, I, L, and O, you see that there's representation of ZIG3 in the cytoplasm of the cells. And so we're going to skip a few years to a couple of 2006 publications. At this time, they've been working on a ZIG3 mouse model. They've shown that mice null for ZIG3 have a number of functional embryologic anomalies, including abnormal formation of the node. And so panel G here, right in the center, shows decreased expression of T at the node compared to the normal mouse embryo and F right above it. And so they also crossed the ZIG3 mouse with a nodal mouse model and found that based on those results that ZIG3 resulted in abnormal nodal expression fitting into that period of upstream of the node development of the left-right axis. Now we're going to time travel quite a bit into this 2013 publication where they're evaluating the timing of expression differences in ZIG3 and the ZIG3 mouse. They looked at mice with conditional loss of ZIG3 function. Since you can get isolated cardiovascular malformations with ZIG3 anomalies, they wanted to know if the effects on cardiovascular malformation were early or if they were part of the actual cardiac formation. So they made different conditional ZIG3 deficient mice that showed deficiency in cardiac tissue at different stages of heart development. And the results of this study suggested that all of the effects that ZIG3 had that disrupted laterality and heart development occur within the node and prior to cardiac tissue formation. And now we get to a 2018 book chapter where they're summarizing what's known about ZIG3 and the establishment of laterality. At this point, there's embryologic data from mice, frogs, zebrafish, and data from humans found to have ZIG3 variants. And both loss of function and gain of function of ZIG3 seems to disrupt laterality in animal models. Now, we're going to look at this 2021 paper that looks at ZIG3's role in establishing laterality. This paper describes how ZIG3 helps position the rotary monocilia appropriately on the nodal cells. In the title, you'll see a term we haven't explicitly discussed, planar cell polarity, which means the cells are organized uniformly across a tissue to asymmetrically express features in a two-dimensional plane, specifically the anterior-posterior axis. And they found that ZIG3 disrupts planar cell polarity with multiple apparent mechanisms. For example, they found that when located in the nucleus, ZIG3 seems to work with RAC1, a gene known to regulate cytoskeletal elements of planar cell polarity, and synergistically transactivate elements to establish the axis. They showed as a result the nodal cilia are not positioned appropriately, which will disrupt the node's ability to initiate laterality formation. This figure illustrates in the top of the figure labeled A, staining of the cytoskeletal elements actin in green and tubulin in red. And so the two top pictures on the left show normal ZIG3 function, and the top two pictures on the right show when there is ZIG3 disruption. So those red dots represent the position of a basal body of an individual cilia in an individual nodal cell of the node. And then the lower images labeled B similarly have normal ZIG3 function on the left and abnormal ZIG3 function on the right, and show the position of the basal bodies of the cilia in red across the anterior-posterior axis. And so this effect on the anterior-posterior axis, in addition to the left-right axis, is why there can be a number of midline defects like neural tube defects in patients with ZIG3 anomalies. So in addition to interacting with nodal for the left-right axis that we saw back in that 2006 paper, and ZIG3 seems to have a ciliopathy of sorts due to abnormal positioning at the node for additional contribution to laterality anomalies. So overall, ZIG3 is a pretty interesting gene. And I mentioned I wasn't doing this story justice, and to really illustrate this, here's a non-comprehensive list of Dr. Ware's papers focused on just ZIG3 and heterotaxy, spanning from that 2002 up to just a few months ago. And this isn't addressing the work of many other researchers working on ZIG3, including one that we'll get to see a poster from this evening. And returning back to the big picture of laterality development, we know that things are set in motion for left-right axis formation long before we have any signs we can see. The first visible consequence of laterality is seen in the heart, which at least in part is because the heart is the first organ to form. This is one reason why cardiac involvement, often extremely complex congenital heart disease, is frequent in heterotaxy. However, we also know there are many patients with laterality disruption and no cardiac involvement. And these patients are really important to keep in mind because their anomalies might not be caught until later, and they may not be identified to have heterotaxy due to the misconception that heterotaxy patients must have cardiac involvement. For the moment, though, we're going to look at left-right axis as demonstrated by heart formation with another genetic example. These graphics come from a 2019 paper on DNAH5, a gene that results in primary ciliary dyskinesia in humans when you have biallelic disruption. And they studied the consequences of DNAH5 disruption on cardiac development in mice. So this is their graphic showing an overview of cardiac development. The top graphic labeled A shows some of the structures we've talked about in the embryo with the node in teal. And then the top right graphic labeled B is the node with the blue cells reflecting the monociliated cells that break left-right symmetry with their rotary function. And then these green monociliated cells are the sensory cells surrounding the node. And then this panel labeled C is a very brief overview of the nodal pathway and specifically calls out nodal lefty 1 and lefty 2 and PIDX2. And then across the bottom, labeled D through G, we see a timeline of cardiac formation, and you see where the heart develops progressive asymmetry. Now here we see the consequences of the biallelic DNAH5 disruption in the mouse embryos from that study. And they look specifically at nodal lefty 2 and PIDX2. And so since this figure is a little complicated, we'll orient ourselves. Down the left, we see A is focused on nodal, B is focused on lefty 2, and C is focused on PIDX2. Immediately to the right of that is a schematic of what view of the mouse embryo is being represented. And then immediately to the right of that are mice embryos that are representative of being heterozygous for DNAH5 loss of function, or what we would consider asymptomatic carriers. And then immediately to the right of that are 3 representative mouse embryos that have biallelic disruption, or what we would consider the primary ciliary dyskinesia. And you can see they all show different patterns of staining, and it's inconsistent across the different views. And then finally, all the way to the right are some graphs showing the patterns of expression for nodal, lefty 2, and PIDX2 in the embryos they assessed overall. And so for nodal, we have 2 sets of graphs representing the crown cells and then the lateral plate mesoderm. And then for lefty 2 and PIDX2, we just have the lateral plate mesoderm. So focusing just on the lateral plate mesoderm, these 3, you can see that it's color-coded to show that green is the proportion with no expression, light blue is expression on the left, gray is to show embryos with bilateral expression, and then the purple is those with expression on the right. And so this first row is embryos that have normal DNAH5. This second row is the heterozygous for DNAH5. And then this last one is the biallelic disruption, or the primary ciliary dyskinesia mice. And so for nodal, we can see that the DNAH5 biallelic disruption has increased incidence of no expression, some expression on the left, but then has bilateral and expression on the right. But the heterozygous, the asymptomatic carriers, also have a slightly different pattern of expression. They're more likely to have no expression. And for lefty 2, we similarly see that the primary ciliary dyskinesia mice are the only ones that have right or bilateral expression of lefty 2. And then the heterozygous ones maybe have a little bit more tendency to have left expression. And then for PIDX2, the DNAH5 disrupted mice are the only ones to have no expression, bilateral or right expression, and expression is on the left uniformly in the wild type and heterozygous mice. And so I think this is interesting to consider developmentally and clinically for two reasons. The first is that it reinforces that when signals are dependent on disrupted fluid flow in that node, that there will be an intrinsic randomness to how that abnormal flow will disrupt signaling, and that it can even be normal. The second is the embryos that we would consider asymptomatic carriers may show some predisposition to abnormal expression patterns or different expression patterns compared to those without, even though none have overtly abnormal expression. And I find that interesting because it supports something that we have evidence to suggest is true, which is burden of ciliary variants across a number of genes may predispose to laterality anomalies, even if they're just carriers, for multiple ciliopathies. And so while nothing is abnormal, it was different, and that makes it easier in my mind to imagine how a cumulative burden of variants may progressively predispose to laterality anomalies and ciliary dysfunction. And I think this is something that'll be important to patients with heterotaxy, as if we can identify ones with ciliopathies molecularly, we can potentially provide better supportive care. To do it, though, we have to be comfortable throwing out my 2002 Punnett squares out the window and putting our heads together in groups like this to come up with new innovative solutions, but no pressure. And that brings us to our take-home messages. Laterality is established really early in development and relies heavily on modal and sensory ciliary function. There is intrinsic randomness and unpredictable elements to establishing laterality. And I think that this supports that in order to better understand and care for patients with heterotaxy, we need to come up with some new ways to analyze genomic information, particularly related to ciliary genes. Thank you for your attention.
Thank you very much, Dr. Geddes. So for our final talk of the morning, I'd like to invite Samantha and Ali. These are two of our heterotaxy moms and warriors, and we thought it was so important to hear their story because we're learning a lot about the genetics and phenotypes and cardiac manifestations. We really want to know what this looks like from the perspective of our patients and families. Of course, this is one of the main themes of this conference, but we wanted that talk to happen really early so that we could set the tone for the rest of this conference and really kind of frame our questions based on what our families are experiencing. Ali and Samantha. I don't think do you have slides?
Yeah, they should be up there. I sent them to Davis.
Okay. Is that the one?
That's the one. Beauty. I'm gonna introduce Sam, or Samantha, for us. She is a mom. I'm trying to find her bio. Where'd you put your bio? Oh, there we go. I've got it. Goodness, this is the family experience here. We're doing our best. Samantha has spent the last 20 years as an advocate for survivors of trauma and abuse, and now as a parent to a brave child living with heterotaxy, she has turned her attention to navigating the challenges that come with this rare and complex medical condition. Although she is still in the beginning stages of understanding all that this entails, she has a deep desire to help others find support and strength when facing this diagnosis. So we're going to hear Samantha's story, and then I'm going to jump on and share ours. You just go forward. It should come up as soon as these guys are ready to. There you go. Yeah, I wasn't sure your timing, so.
Good morning, everyone. I am so honored to be able to take a few minutes and share my family's experience about dealing with heterotaxy. So my husband and I struggled with infertility for many, many years. Thanks to in vitro fertilization, we were able to have a daughter 4 years ago. When she was about a year old, we decided it was time for my son. So we began treatment in preparation to transfer his embryo. Unfortunately, about a week before his scheduled transfer, my father passed away. My fertility doctor asked, "Are you sure you want to go forward with this? Do you want to wait a few months just to give yourself some grieving?" And I told her, "No, we need to move forward. I need this, my family needs this. We need something to look forward to." So we proceeded with the transfer. 2 weeks later, I had confirmation that I was pregnant. We had something to look forward to, and it was wonderful. Everything proceeded as usual. At 10 weeks, I was transferred to the OBGYN department of our medical group. There, we had the first ultrasound scan. Again, everything was normal. My husband and I go in to have the ultrasound. The technician was doing the scan. Everything was normal. We were so happy. Then she walked out of the room to go check with the doctor, as they always do. Except this time, she came back, took more images, left again. And then she brought the doctor back with her. My heart sank. In all the ultrasounds I had had from my previous pregnancy, the doctor never came in. This was not a good sign. He starts talking. I don't remember what he said. I could hear him and my husband talking. The room was black. I couldn't comprehend anything. The only thing I remember from that meeting was one sentence. "If this comes back as severe heterotaxy, do you want to terminate the pregnancy?" I just lost my father, and now you're talking about losing my baby. We went home that day, and I did what you're not supposed to do and jump online and read all about this heterotaxy. I learned most don't make it to day 1 of life, and those that do, most don't live to their first birthday. I was devastated. I spent the next 3 days in bed crying. Pulled myself together and moved on with life. But every time I felt that baby move, every time I felt that baby kick, it was heartbreaking. Am I going to lose my son? Next comes the anatomy scan. We were prepared for the worst news possible. And yet what came out of that scan was dextrocardia. Everything else looked fine, just dextrocardia. We can handle this. Subsequent scans confirmed dextrocardia. The heart was functioning fine. We were ecstatic. We could finally be happy for this baby. We prepared for the baby shower. We started preparing the nursery. It was perfect. Of course, we were angry at the doctor who had suggested terminating this pregnancy, but we were okay. Go to the hospital. Son's delivered. Because of the dextrocardia and the suspicion of heterotaxy early on, they went ahead and started doing all the scans. It was from then that we started dealing with heterotaxy. By the time we left the hospital, we had referrals: cardiology, infectious disease, GI. We now had medications to take every day, and we left so confused. How could this happen? Because of the fertility treatments, both my husband and I had all of the genetic testing. Nothing was there. Even to this day, my son has had the genetic testing. They can't find anything. We don't know how this happened. We go home from the hospital for the next 8 months. It's a blur. Every doctor's appointment produced more tests. Each test produced more doctor's appointments. It was so confusing. Most of us don't have medical degrees. Most of us don't have a background in medicine. And all of a sudden, we need to become experts in our children, into the complexities of the human body. A condition like this changes everything about that child. And all of a sudden, we needed to know it in a very, very short period of time. It is rocked with confusion. It is rocked with blame. What did we do to cause this condition in our child? Every parent feels this. It's part of the process. You start to become isolated. Number one, because your life is built around this child, doctor's appointments. It's built around scans, tests, imaging. Your life becomes medical appointments. You start struggling at work because you're never at work. You're taking care of your child. Who has time to keep that marriage good and healthy? Who has time for dates? It's all about this child. Your marriage starts falling apart. You can't talk to any of your friends or family members because they've never heard of heterotaxy. I've never heard of heterotaxy. It is so rare that you don't come across it. You try to tell your friends and family about it, and they come back with silly suggestions on how to fix it. Questions of, well, just because the statistics say that, why are you worried about it? It's amazing some of the responses that you get. And pretty soon, you just stop talking about it, and you become isolated. One thing that all heterotaxy parents have in common is fear. I'm one of the lucky ones. My son is one of the lucky ones. He didn't have to have any surgeries in the first few days of life. Up to date, he hasn't had to have any surgeries. I don't know what it's like to have to watch my day one baby go into surgery for his heart. But I do understand that fear and anxiety every day. That fear that you are going to miss something that's going to cost your baby his life. That fear of when that fever first hits and you're waiting, is this it? Every scraped knee now becomes a problem. We all share fear. And as clinicians, you are on the front line to help us, not only with your medical background, to help us understand what is going on and to help our child, but to help take care of the family. My story is not that different from every other parent dealing with heterotaxy. We all feel that fear. We all feel that isolation. We all feel that worry. And from your standpoint, you guys are the best people to help us, to recommend getting in contact with others who share that same fear, to recommend finding a social group dedicated to heterotaxy or whatever rare disease or condition that's being talked about, to give that parent an outlet. You guys are there to be able to watch our mental health, because if the parent's mental health starts declining, who's there for the kids? The mom falls apart, the dad falls apart, marriage falls apart, the family's broken. And it takes a village to get these kids to continue. My final recommendation is to remind yourself, you guys are here to help. You spent a whole lot of years learning about this and learning how to best help. And you did that because you want to be there, you want to help. But remind yourself, to you guys, this is a case. This is a battle. But to us, it's our life. It is our child's life. And we thank you so much for being here today to learn and to understand. Thank you.
I can't. Now I have to follow Matthew? Come on. So like Tom said, I'm Ali Chandra. I'm the science director of Heterotaxy Connection. I am so thrilled that we are all here together, that we, like Tom said, that we're co-learning, that we are bringing families and clinicians together. It's so, so important. I am both a family and a clinician. I'm a pediatric nurse. I have been for 20 years. Probably most importantly, though, I'm Ethan's mom. If you see a kid with bright pink hair, that's my kid. He's 11 years old. He loves Lego and Minecraft and spiders. And it's a joy and a privilege to be his parent, and to get to share with you a little bit about our journey. And also just to echo some of the things that Samantha was talking about, sort of lessons that we hope as families that you as clinicians can carry into your practice to make care better for all families. Like I said, been a pediatric nurse for 2 decades now, and I've worked in a lot of different arenas in a lot of different parts of the world, from critical care to pre and post-op maxillofacial surgical ward on board a ship off the coast of West Africa. And most recently, where I found myself for about the last 4 years or so in home health, sort of bridging the gap between community and hospital care. This is one of my patients, shared with permission from her mother, who knows that her kid is adorable and wants everyone to see her. Through all of this, for 2 decades now, I constantly and consistently said, there's one thing I could never do, and it's be the mom of a medically complex child. I would look at these parents whose kids I was caring for in the PICU or on the ship, up all hours, all night, days on end, caring for their children, advocating for their children, and I just said, I could never do that. Like, props to them, could never be me. So maybe I shouldn't have said that out loud, and maybe I shouldn't have said it so many times, because here we are. I've got my husband, my parents are in the back, they're part of our journey, my daughter's back there too, and we are living a story that we never thought we were going to be a part of. It's from this place of being both a provider and as a family that I want to talk to you guys today, because, and this is, I think Samantha put it so well, it's not just a case. So behind every chart, behind every MR number and every test result and every echo that you see those images, it's a family. It's a kid who's getting transported via ambulance to the next state over for what turns out to be a common cold. But because he has heterotaxy, it hit him that much harder. It's a kid whose heart has seen the light of day 5 times now, and we don't know how many more times we're going to have to open his chest in his life. It's siblings, it's families, it's so much more than just those discrete moments that you see in clinic or in a post-op ward or in a pre-op visit. This is our entire lives. Diagnosis day is a day. We say it in all capitals in the heterotaxy community. It's bolded in bold font, diagnosis day. It's a watershed for every single family. Everything changes. Everything is distilled and repackaged into before and after when you hear that diagnosis. For many of us, it is prenatally, and I think the lucky ones of us, it is prenatally. Like we heard before, that really can help guide postnatal care and having the right team in place. Some families, though, are waiting days, weeks, months, and even years. We have adults here at the conference, who I hope you'll get a chance to connect to, who were diagnosed in adulthood with heterotaxy. And so they've maybe been searching for answers their entire lives. So our journey to diagnosis can look different as families. For us, it's an absolute blindside. I sat in an ultrasound room with my sister. My husband was overseas still. He had no idea about any of this until much later in that day. So my sister was my support person. It's the one and only ultrasound she has ever been to. And I think I understand why for her. 25 weeks pregnant. I just come back for maternity leave. And we were so excited, we were gonna figure out if this was a boy or a girl. And instead, and it's the same as, it's so interesting how many similarities there are. It just went silent. And she's scanning his heart and scanning his heart. Now, I'm not an ultrasound tech, but I knew enough about what I was looking at. And I was like, I kind of whispered to my sister, I said, wow, they're really looking at his heart for a long time. Not a word from the ultrasound tech. Okay, she was silent. I do not think that she spoke more than one sentence in the entire, that should have been my first thing. And I said, I kind of whispered to sister, I said, if she goes and says she has to get the doctor, like there's something really wrong. And sure enough, before I knew it, the doctor had come back in, and it was a lot of the same, and we were brought over, and we were told that this baby was likely incompatible with life. He had the fetal bradycardia. He had severe, we thought it was right atrial isomerism, but there's a question mark there. I mean, I have to give really big credit to the initial team that diagnosed him. It was at a much smaller center, but they got almost everything right on this page. This is the first drawing that we ever got of his heart. It was incredibly complex, and there were a lot of questions about whether he was going to survive to birth, whether he was going to survive the surgeries afterwards. And so in a single moment, everything that we thought we knew about our future had changed. And it was a shift and a shock, just being thrown into a completely new paradigm with no preparation. That's something that pretty much any heterotaxy family can relate to, even if the details are different. And in our case, maybe they were a little more different than most. So my daughter's in the back hanging her head there. This is one of my favorite pictures of her from her time as ship's baby. This is her first lifeboat drill. For almost 6 years, my husband and I and our daughter Zoe, we had been living and working on board the world's largest NGO hospital ship, the Africa Mercy, off the coast of West Africa, like I said. My husband was an electrician. I was the head nurse for maxillofacial reconstructive surgery. I was the ICU coordinator. We were right where we were supposed to be. You know, everything made sense. We had a clear purpose, a clear goal. We were serving the underserved. And then I came home for maternity leave, and that entire life path changed. Instead of heading back up the gangway after maternity leave, we found ourselves navigating a maze of hospital hallways and medical appointments and health insurance. And maybe that paradigm shift isn't quite so drastic from sea to land for every heterotaxy family, but every family undergoes the experience of having their entire life reshaped by a diagnosis. You as clinicians, you're diagnosticians a lot, like you're giving diagnoses, and that's a moment in your day. It is an entire reshaping of a life for the families that are on the receiving end of that diagnosis. And we don't need it to reshape your entire lives, but just the awareness of how drastic that change is going to be for our families is really, really important. Trying to learn this new medical language, trying to manage complex care, trying to rebuild a future from these pieces that are just shattered beyond anything that you can really recognize. So I'm gonna preach at you real quick, and I'm gonna give you 4 things to hang on to, and I wanna see you taking notes, and I wanna see you taking this back to your practice, okay? Class is in session. What are some things that our families wish that you understand? And we want you to spread this far and wide. First is communication, okay? We're all taught it, right? We're all taught therapeutic communication in medical school, in nursing school, whatever. I came into this whole journey way ahead of the curve. I already had the terms. The first patient I was ever the primary nurse for as a PICU nurse was a kid with heterotaxy. I didn't realize it until years later because none of us called it heterotaxy then. It's a very full circle moment. So I already had a good amount of fluency in all of this medical language, but not every family gets a head start like that. So many are starting completely from scratch. Their baseline is nothing. They've been to well checks. They've been, to visits that are very, very standard and without any of the higher level. So this learning curve is steep and it is unforgiving. and it is hard for families. So avoiding jargon is really, really important. It's very hard for doctors, and I know it. Find a nurse who can help you translate. It's my little plug for us. That's one thing that I love to do, is take medical jargon and translate it into a way that our families can understand. But if you sit down across from it, like you saw the list of, DORV, pulmonary stenosis, right isomerism. If I hadn't seen those terms before, in the worst moment of my life, I would have had no idea what any of that meant, and it would have gone right over. Like, the room would have gone black. It went in and out for me. So speak plainly, explain options clearly, check for understanding. Make people repeat back to you what they're hearing and what they understand about a plan. Medicine is a new language for our families, and we're learning it under enormous stress at often the worst time of our lives. The way you communicate is either going to build trust or it's going to shut it down. And you need that trust, because you are building a partnership with the families that you are caring for. Like I said, alongside being a parent, I'm also a home health nurse now, and I frequently have students that I help train, nursing students. And the first thing, day one, when they come under my tutelage, that I teach them is, you don't know this kid better than their parents. I don't care how long you've been studying, I don't care how long you've been in practice. Your parent is your first line partner in the care of this child. They know the nuances. They will recognize, they'll pick up on changes before you will. So please take them seriously when they bring issues to you. Families like us, we're not passive recipients of care. We are active partners in the care of our children, and we are to be encouraged in that role, because it's better for everyone. We carry this knowledge of our kids that's never going to be found in a textbook. I can think of 47 different quirks of Ethan right now that really have never been written down in any textbook. If you come to a family and say, hey, we're noticing this, what have you seen? What have you seen day to day? Because you're living with this kid every day, not just seeing them at one discrete point in an office. That's not you giving up your authority. That's not you ceding any authority in this relationship. It's building stronger care. It's building better care together. Because this care, the goal is that this care goes for a lifetime. We heard early on that our kids weren't going to make it, that we should terminate, that they were incompatible with life. But we've also heard this morning already, the statistics are better than that. Our kids are surviving, our kids are thriving in their lives. And so this relationship, we're planning on it being forever. We're planning on aging out of pediatric care and going to the adult world. Like, that's what we're looking forward to right now. So that continuity of care is really important. We are the keepers of our children's history. And so if you're able to see us as families, as this keepers, not just I feel like I'm repeating myself, but it's so important. We're not just a case. We're not just a medical record number. We are a family who's navigating an incredibly complex journey. And just having that in perspective of this is what's happening on the other side of that bed is really going to help build that trust. My son's cardiologist comes in with new spider facts for him every time that she sees him. She says, oh, well, I learned this about a spider. It gets him right away. Like, he opens right up. Oh yeah, she knows about spiders and she knows about me, And the last one is compassion. Compassion doesn't have to be big, grand gestures and letting a family sob on your shoulder for 45 minutes while you're trying to get to your next appointment. It's just checking in, like Samantha said. Checking in, how are you, not just as a caregiver, how's your life as a person? How is your mental health? Just seeing the humanity and not just the science and not just the medicine, but the humanity in the families like ours. it really makes a huge difference between a family leaving an appointment feeling invisible and a family feeling seen and empowered to advocate for their child and to go on and to really be the best caregivers possible. So you take one thing, well, I gave you 4, but one thing from this talk, let it be this. Listening to families and treating us as equal partners in the care of our children isn't going above and beyond. It's just good medicine. It's good practice. It leads to better care, better compliance, and better outcomes. We all want better outcomes. Thank you so much, all of you, for the work that you do, for the passion that you pour into research and advancing clinical outcomes. Our families benefit from this. Go find my pink-haired kid at the break or at lunch and say hi to him and see what it looks like when you have a team that works with you, because that's the kind of life we're trying to build together.
Thank you both very much. I tell my fellows whenever they're sharing news with a family that's kind of hard to communicate, I always tell them the most important thing you can do in this meeting is to listen to the family. I quite frankly don't want to hear you. I want you to hear them. And so once we know what the family knows and what their concerns are, then we can have a much more fruitful conversation. I promised you all we'd have time for questions, but I also promised you you'd have a little break. So the break wins here. And so save your questions for the next session. There'll be plenty of time to ask questions throughout the day today and tomorrow. We're going to take a 10-minute break and start back at 10 minutes after the hour, 10:10? Yeah, in 10 minutes, 10:20.
Dan, I'm just going to unplug this real quick so I can do a little noodling here. Hi, how are you? I am well. Do you, do you have your Mac with you? Why don't we do that? Yeah, you'll probably get better fidelity. Yeah. Okay, great. So who do I? So, yours is at the start of the session at the lunch. Perfect. Thank you so much. And you're going to maybe like 10, 15 minutes before we start. Plug it in, we'll test it.
Did you take the train up today?
No, I am. Yes.
Oh, that's great.
We have an adapter as well.
Oh, I don't need it. I have an HDMI in my port on the laptop.
Okay.
So that should make it easy.
Yep, the MacBook Pro. And do we have any audio with your presentation?
Any what?
Audio? Audio in your videos require
Oh,
audio?
yeah. I have videos. What is
Do
idea?
they have any sound to
No,
them?
no sound. No audio. Oh, see, sorry.
It's so nice to meet you.
I'll go verify that. See how my
You see it? Okay.
Yeah, I'll show it to you real quick.
Okay. Okay, I'm going to just flip through these, make sure the videos play. It's working. I'm good. I'm good. So, do you need to?
Yeah, you can leave it 5 minutes. If you're the first person to come back. Do you have enough power?
I'll leave my back.
right, I think we, in an effort to keep us on time, want to introduce our next session, which is pulmonary disease and ciliopathies. And I'm very pleased to invite our first speaker, Dr. Lowe. She's a developmental geneticist with a long-standing interest in genetic and developmental etiology of congenital heart disease, pursues an integration of developmental and genetic insights with clinical outcome data to elucidate the mechanistic basis for various comorbidities associated with congenital heart disease. And she's interested in pursuing the development of potential therapies to reduce the risk of perioperative respiratory complications, heart failure risk, and adverse neurodevelopmental outcomes from patients with congenital heart disease. So I'd like to welcome you to the podium. Thank you.
Thank you for the invitation to participate in this really interesting meeting. I'm not a clinician, I'm a developmental biologist, but I've had the help of a lot of clinicians I've collaborated with over the years, and we've actually also have pursued some clinical studies that I will show you, but it's really through the work with my collaborators. So as you know, heterotaxy is a birth defect that involves disturbance of left-right patterning. And what I want to show here is that the heart is the most left-right asymmetric structure in your body. And that left-right asymmetry is absolutely critical for oxygenation of blood. So when you have disturbance of left-right patterning, such as with heterotaxy, you end up with very complex congenital disease that will give you high morbidity mortality. And so with this in mind then, I'm going to make my comments regarding ciliopathy focused on heterotaxy and congenital disease associated with that disturbance of laterality. So as you know, patients with heterotaxy suffer very high morbidity mortality, disproportionately higher than you might expect. And this is known to be associated with more respiratory complications. And that was a puzzle for a while, but now we understand that this reflects the requirement of motile cilia, both for airway clearance as well as for left-right patterning. And just by way of very brief overview, cilium is a highly conserved microtubule-based organelle. It is organized around 9 microtubule doublets that protrudes from the cell surface in a ciliary axone. And it can be motile or non-motile. In a motile cilia, you also have a central pair with radial spokes and motor dyneins around the periphery that connects all of the microtubule doublets together, and that it's involved in powering the flexing of that cilia, which provides motility. So cilia is very broadly expressed. Primary cilia are found in almost every cell in the body that's not actively dividing. And motile cilia are found in specialized cell types. So for example, in the airway, where they involve mucociliary clearance, but also in other tissues, including sperm, and also, most importantly, in terms of left-right patterning, in the early embryonic node of the embryo. This is a mouse embryo. So just to show you what this looks like, there's a video. So this is a scanning EM that shows the embryonic node. This is a video microscopy showing the rotary movement of this whole field of cells of the node. And this is just a single, zooming in a single cilia. And you can see it's got this rotary motion. This is found, this small group of cells, about 50 to 100, is found at the distal tip of the 8.5-day mouse embryo. And so that motility is important for setting up left-right patterning. I should just go back quickly to also mention that in addition to the motile cilia in this node, there are also cilia at the edge of the node that are not motile, primary cilia, that's very important in transducing signal that comes from, sorry about that, that comes from the embryonic node, from the motile cilia, the embryonic node. And this is the work, of course, from Martina Bruckner's laboratory that show that, in fact, signaling function of that primary cilia is very important, as well as the motile cilia for breaking symmetry and setting up the left-right body axis. So, so motile cilia, in this case, is involved in airway clearance. On the left is the cilia. I don't know why this is acting strangely, but let me see if I can get it to play. Okay, so the human nasal epithelium actually are ciliated, as well as the rest of the airway. And also, this is supposed to be a mouse airway. Yeah, trachea, and you can see ciliary motion, the profile view So when you have disturbance of cilia, you can have airway clearance defect. So what I'm going to show you here is the ciliary motion. On top is the normal wild type. On the bottom is that from a mutant with a mutation DNH5. As you heard earlier, it's one of the most common gene mutated in patients with PCD. And so on the bottom are videos playing from the airway. I don't know, is it playing? Yes, it is. It's barely moving. So it's very dyskinetic. This is profile view. This is a top-down view. And then on the right is the cilia from the embryonic node. On the top is the wild type. And on the bottom, it's the, I can't tell if it's playing or not. So on the bottom is actually from a DNH5 mutant. So you can see the pixel shifts, but the cilia are like toothpicks. They're immotile. So PCD, as you know, is a sinopulmonary disease that's associated with I don't know why this is acting up, but PCD is a sinopulmonary disease associated with mucociliary clearance defects. And it's because the airway cilia are dysfunctional, usually immotile or barely moving. And the PCD patients, as you know, can have sinus anomalies, such as in Cartaginous syndrome, where you have sinus inversus totalis, or heterotaxy, where you have randomized sinus. And it is a monogenic recessive disorder, and this should be corrected, as you heard earlier. There are more than 60 genes associated with PCD, although, as you know, 20% of them are patients actually have mutation in a single gene, DNH5. So the question, of course, arises if heterotaxy patients can have undiagnosed PCD. And so that was a question we were interested in addressing. I guess it's only letting me do it this way, that we were interested in addressing many years back when I was first looking into this problem together in collaboration with Linda Leatherberry at Children's National Medical Center. So we went about recruiting patients with congenital disease associated with heterotaxy and then examined them with 4 diagnostic criteria for PCD, including conducting nasal scrape, doing ciliary motion video microscopy to look at the airway cilia, and then measuring nasal nitric oxide, which is very low, usually in patients with PCD. And it's thought that ciliary motility somehow is some way linked to NO production. And then also cilia EM ultrastructural analysis to look for ultrastructural defects, because many of the genes that encode proteins that cause PCD, in fact, affect cilia ultrastructure, hence motility of the cilia. And then, of course, doing the genetics, doing sequencing analysis to see if we can find mutations causing PCD. And, of course, you would expect it to be either homozygous, which would be rare, but more likely compound heterozygous mutation because it is a recessive disorder. So going about with this analysis, we first started with doing video microscopy, conducting nasal scrape using a rhino probe, and then getting the nasal epithelial tissue and doing high video microscopy, high resolution video microscopy. And so on the left is the normal I showed you earlier. On the right is a patient with heterotaxy that shows what we call a wavy motion. And then on the lower left, asynchronous. So you can see that the cilia are not beating together. And on the right, very stiff dyskinetic stroke. So that this is what the range of phenotypes that we see in heterotaxy patient with what we call ciliary dysfunction or ciliary dyskinesia. And it's very different from most patients with PCD, who generally have very little movement. It's dyskinetic and very, very stiff. So I would say the last subject that you saw is closer to what you might see in a PCD patient. We also measure nasal NO using an NO analyzer. And typically, as I said, is very low. And airway motile ciliary function is somehow linked to NO production. And I don't think that that's understood, although maybe there's someone in this audience who might have better insight to that now. And so we went about measuring nasal NO in infants and young children with heterotaxy that are seen in cardiology and in cardiac surgery, and measure NO. And what we found was that the patients did indeed have low NO, many of them, not all of them, but that their NO levels were usually above the PCD cutoff value. So they're grouped into 3 age groups because PCD level rises. So infants are born with relatively low NO levels, but then that rises and reaches about adult level at 5 to 6 years of age. Sorry about that. And so this is basically looking at the newborn, then looking at the children 6 years or under, and the last one is above 6 years of age. And the PCD cutoff is shown by this dotted line. And you can see that we call variant ciliary dyskinesia A and B for severity. And you can see that the level of NO is above PCD values, but nevertheless is much lower than the normal value. And my apologies, my computer is having some problems with the trackpad. So anyway, so they do indeed have lower NO, but not PCD level low. So we see that there's a high prevalence of ciliary dysfunction. About 42% of the congenital disease heterotaxy patients have this ciliary dysfunction based on video microscopy. And what we noted is that the fraction of patients that have ciliary dysfunction was a lot higher on those individuals that have both cardiac and abdominal laterality defects compared to those that only have cardiac. So it's 52% versus 28%. And right here, I should just stop and mention how we define heterotaxy, because I know that that's really of important concern to cardiologists and cardiac surgeons. And our definition is really a developmental biologist definition. So it's probably much broader than what you would consider heterotaxy. So we define the patients as having heterotaxy if they have disturbance of laterality of any organ in the body. It doesn't necessarily have to be in the chest cavity. Now, obviously, because these patients are coming through the cardiology, generally they do have some kind of cardiac laterality issue, cardiac or lung laterality issue. But our definition is much broader than what you might normally expect from a cardiologist standpoint. From overall, we believe that from looking at the 4 parameters, and I only talked to you about motility NO, we also did cilia EM ultrastructure, and we did not really find any identifiable ultrastructural defect. We also did sequencing. We were not able to find any patient with compound heterozygote or homozygous mutation. So they really don't conform to what you considered as the diagnostic values for classic PCD. So we think that these heterotaxy CHD patients do have a ciliary dysfunction, but it's a little different from PCD. Now, one thing I do want to mention right here is that the genetics of heterotaxy, as we've already heard, is complicated. And it's likely to be, in some cases, oligogenic with modifier effects that influence phenotype. But I also want to point out that there is another level of complexity, that it is confounded by the ambiguity of phenotype-genotype correlation. So normally you expect, as a geneticist, you have a phenotype and you have a genotype. And you find the genotype by looking for the phenotype. But in fact, with heterotaxy, that's not so easy, depending on the category of gene we're talking about. So we did a large-scale mouse mutagenesis screen and recovered many mutations that cause congenital heart disease. And of course, not surprisingly, we did recover a lot of laterality mutants because, in fact, as you know, heart is the most left-right asymmetric structure in the body. So we recover over 60 different mutant lines that has congenital disease associated with left-right patterning defects. Looking through all of those different genes and mutant lines, we began to appreciate there are 2 major classes of genes that can cause laterality defect. In the class 1 laterality genes, you can have one single gene, so one single mutation can give you 3 phenotypic outcomes. You can have situs solaris, situs inversus, or heterotaxy. They all have the same genotype. And of course, you shouldn't be surprised at that because you already know PCD patients can have situs solaris, situs inversus, and heterotaxy. And so when you're thinking about the genetics and what are your controls, what are you comparing with, it's really difficult because, in fact, individuals that look completely normal could have a mutation that actually can cause heterotaxy. Now, this is seen not only with multicilia genes that we know from PCD. So many of the multicilia genes that generate these 3 phenotypes, in fact, are PCD genes. But there are also genes that encode proteins in the primary cilia, and even non-cilia genes can give you these 3 phenotypic outcomes. So I think it's, in thinking about the genetics of heterotaxy, we have to keep this in mind. The other really interesting thing that we learned from this is that you only see congenital heart defects with heterotaxy. So you can have 3 phenotypic outcomes. But the mutants have cytosolic status inversus usually do not have congenital heart defect. They might have a VSD or some ASC, some very mild phenotype, usually nothing at all. And so it really says that the disturbance of laterality is very central to how congenital heart defect arise in the context of heterotaxy. And then we also have another class of laterality genes that I call class 2. In this case, mutations in these genes always cause heterotaxy, 100%. So it doesn't matter which animal you look at, they all have disturbance of laterality. And of course, in these mutants, every single animal have complex congenital heart disease. And so I think that realizing that there are these different categories of laterality genes is really important in thinking about the genetics of heterotaxy, and therefore in terms of future diagnosis and working through the genetics. So there was also, I think Adam Shapiro mentioned whether there may be other birth defects associated with cilia mutations that may cause PCD and other kinds of cilia phenotypes. I do want to point out that in the course of our screen, we're looking for congenital heart disease, but we actually recovered many, many cilia genes, including many cilia genes that are known to cause all kinds of ciliopathies, as shown here, like, for example, of course, PCD, Joubert syndrome, Becker-Gruber syndrome, and others. And so many of these known ciliopathy genes actually, in fact, can cause congenital defect, as well as lateral defects, and importantly, spectrum of other birth defects. So I think we should keep in mind, I think, what Adam pointed out, that in thinking about heterotaxy patients and patients that might have some cilia involvement in their phenotype, whether in fact we should consider other possible birth defects, including actually abnormal neurodevelopment. So I want to now briefly comment about a little bit that we've learned about clinical impact of having ciliary dysfunction. So in work done at Children's National Medical Center, we looked at that small cohort that I showed you earlier in terms of looking at ciliary motion and NO, and we found that there's about 40% of the patients have what we call ciliary dysfunction. So then looking at outcome of that same population, we see that there's ciliary complications, sorry about that, ciliary complications as defined here, is seen in significantly more of the subjects that have ciliary dysfunction, 0.001. And that those have, my trackpad. Those that have ciliary dysfunction also show much higher incidence of use of inhaled beta agonists, again, suggesting that they have respiratory issues. So it does suggest that patients with ciliary dysfunction have adverse respiratory outcome. We also see that, and again, the sample sizes were very small, that there is prolonged ventilatory support associated with those with ciliary dysfunction. And so expanding the study, after I moved to Children's Hospital of Pittsburgh, we looked at a much larger collection of patients and then looked at post-op outcomes. And here we separated those with abnormal ciliary motion and looking at how that affect outcome versus those with low NO. And the reason we did that is that as we grew the study, we realized that not every patient will have abnormal ciliary motion and low NO. Some have only one or the other, and some have both. So in this analysis, we recruited congenital disease patients, and we looked at abnormal ciliary motion separately from NO. And so what we observed is that, in fact, when you have abnormal ciliary motion, you see much higher use of positive pressure ventilation. I'm not going to touch the trackpad to move the arrow because it's going to do weird things. But you can see I put in red boxes that use of positive pressure ventilation is up when you have ciliary dysfunction, respiratory medication use, albuterol use, and also, interestingly, respiratory viral infection. I think that you probably noted that there's a lot of data now suggesting cilia as the entry point for respiratory viruses, including actually COVID. So maybe one should not be totally surprised that in fact abnormal ciliary motion indicating that there's some motile cilia defect might in fact affect viral infection. So there's a higher incidence of respiratory viral infection. Looking at low NO, the only correlation that we see regarding things that are respiratory interest is respiratory bacterial infection. So interestingly, instead of viral infection, we see that bacterial infection is significantly associated. In fact, if you look at the odds ratio, it's nearly 5 times higher odds of having bacterial infection if you have low NO. The other interesting thing, I put an asterisk on the left, you can see that there are various different parameters that are associated with low NO to suggest that these patients also have very poor cardiac function. And so we did a follow-up study, because we saw that there was some effect on cardiac function. We looked at how low NO affected long-term these patients, looking at patients that require heart transplant or died waiting for heart transplant. And it turns out that among single ventricle patients, we see a very significant correlation between low NO and incidence of death or requirement for heart transplant, as shown in this Kaplan-Meier curve. Proportional hazards modeling show an odds ratio nearly 3 times higher for those that have low NO in terms of requiring heart transplant or dying waiting for one. And so in this study, we recruited not just patients with single ventricle, but all congenital heart disease patients. And what this shows is that, in fact, it's the single ventricle patients with low NO that are at risk, and specifically those with systemic right ventricle. So, for example, patients with hypoplastic left heart syndrome. And so, but the other thing is we looked at various other outcomes besides transplant. You can see the only thing that's significantly associated with low NO is the need for heart transplantation. So suggests low NO may have some value in terms of predicting long-term cardiac outcome. And so supporting this idea that this might have something to do with cardiac function, we make iPS cells from HLHS patients, 10 patients that have different outcome. 6 of them survived to 4 years of age without requirement for heart transplant, and 4 that either died or require heart transplant within the first year of life. So we call the second group 2 that has the worst outcome, and the other one group 1. And looking at the cardiomyocytes from those patients as compared to healthy control subjects, we can see in this plot here, hopefully this is not going to move, you can see in the black bar that the NO level is very low as observed through staining with DAF, which is a compound that reports back on indirectly on NO activity. And you can see that in those that require a heart transplant, NO level is much, much lower than compared to control, and those that have that survive to 4 years of age without transplant, so with better outcome, they have intermediate level, but nevertheless lower than that of control. So consistent with the notion that low NO is somehow associated with poor outcome. And remember, this is now not NO in the respiratory system, but NO in cardiomyocytes. So, and then thinking about clinical impact of ciliary dysfunction, what we can say is that congenital disease patients that have ciliary dysfunction have more respiratory complications. Those with abnormal ciliary motion can have respiratory viral infection at a higher incidence, more respiratory medication use, and need for positive pressure ventilation. And those with low nasal NO have higher incidence of respiratory bacterial infection, poor cardiac function, and possibly heart failure risk. And so in conclusion, then patients with congenital disease with heterotaxy can have ciliary dyskinesia that's somewhat distinct from PCD, and the incidence of ciliary dysfunction increases with laterality defects involving both the chest and abdominal organs, so that if you have a more complex patients, there's likely to be a higher incidence of ciliary dysfunction, and that may be worth following up. Increased risk for respiratory and other complications are observed with abnormal ciliary motion and low NO. And of course, as I showed you, there's some differences between what those complications are, depending whether you have abnormal NO or low NO or abnormal ciliary motion. And then finally, just want to end with a thought about whether possibly we could use ciliary motion and detection of NNO levels to identify patients who might benefit from intervention with perioperative therapies that could possibly improve their post-surgical outcome. So with that, I'd like to acknowledge I think someone said earlier about how it takes a village. Well, it takes a village to do the kind of studies we've pursued, and a lot of the work actually was carried out by various different fellows, cardiology fellows, pulmonary fellows, anesthesiology fellows. All the names in yellow here are various fellows that have done the work that I presented, and also many, obviously, clinician collaborators. And Cindy Hsu actually is a postdoc who actually did the work on the iPS cells. So with that, I'd like to end, and I do want to acknowledge my longtime collaborators from UNC, Mike Knowles, McGee Lee, as well as, of course, Adam Shapiro, who got me started in this field many years back. Thank you very much for your attention.
So our next speaker in the session is Dr. Rivera Sanchez. She's going to be speaking in her, told me that in her professional life, she's a pediatric pulmonologist with an interest in PCD, currently leading the PCD Center at UT Southwestern. Her main goal as a pulmonologist is to help close the health equity gap in pediatric lung disease, and she remains very active, involved in health equity initiatives at the local and the national level. And she strongly believes that the workforce shortages in pediatric pulmonology would be far less pressing if more trainees had the chance to maybe to come to this conference, right? Or to step into a day in the life of a pediatric pulmonologist to see not only the impact of our work, but also the challenges, the vibrant and supportive environment in which we practice. So she's going to be speaking to us about primary ciliary dyskinesia and heterotaxy-related respiratory ciliary function.
All right, good morning, everyone. Thank you to the organizers for the opportunity to speak about primary ciliary dyskinesia and heterotaxy-associated ciliary dysfunction. I have no disclosures. I hope that in the next 20 minutes or so, we can discuss the association between PCD and heterotaxy, review data supporting heterotaxy-associated ciliary dysfunction, and I will refer to that as HACD, discuss other non-ciliary respiratory complications, and review the respiratory evaluation and management in heterotaxy. And so I'd like to start with a clinical presentation from our center. This is a 17-month-old X33-weeker with right atrial isomerism and complex congenital heart disease. He is status post PDA stent and stage 1 biventricular repair at 6 months of age and stage 2 repair 2 weeks prior to consult. He was extubated at 48 hours post-op, and the course was complicated by chylous effusion and hypoxemia. An ultrasound of the chest revealed reduced motion of the right diaphragm, but the left was normal. His respiratory support at the time was heated high-flow nasal cannula at 15 liters per minute, 0.8 FiO2, and 20 parts per million of INO. The reason for the consult was persistent hypoxemia and the request for a flexible bronchoscopy for surveillance cultures. Airway clearance had been started by the primary team 1 day prior to the consult. On exam, his SATs were in the mid-90s. He was tachypneic. He did not have significantly increased work of breathing, and lung auscultation revealed coarse bilaterally and somewhat diminished lung sounds at the basis. Some relevant clinical data on the left, it's his x-ray at the time. You cannot appreciate the lung fields very good from there, but he had some bilateral atelectasis and his right diaphragm is elevated. The primary team had obtained a genetic congenital heart defects and heterotaxy panel that showed one heterozygous variant of unknown significance on the BRAF gene. We obtained a commercial PCD genetic testing, which at the time had 42 genes and came back negative. His ultrastructural defect was in the form of partial loss of outer dynein arms in less than 50% of the cilia, which would be a class 2 defect. His CT findings showed right lower lobe airspace opacity, a small residual pneumothorax, left-dependent atelectasis, and a note that he did not have bronchiectasis. His BAL grew Rautellia ornithinolytica, which is an encapsulated gram-negative rod from the family of Enterobacteria closely related to Klebsiella. So with this clinical presentation in mind, I like to give 3 overviews, and Dr. Lowe has referred to some of these. Ciliary dysfunction and heterotaxy converge in decreased mucociliary clearance, increased operative risk, and increased morbidity of lung complications. 2, the link between PCD and heterotaxy, although has been suspected for a long time, it wasn't actually made until 2007 via systematic studies. And the last one, there is PCD. There are patients with heterotaxy that do have PCD, but not all ciliary dysfunction in heterotaxy is due to PCD. And so just another overview of primary ciliary dyskinesia, inheritance pattern of mostly autosomal recessive. Demographics now known to be close to 1 in 7,500, so perhaps not as rare as once thought. The phenotype is that of daily wet cough starting in early childhood, neonatal respiratory distress, chronic otosino-pulmonary disease, subfertility, and bronchiectasis. And we now, hot off the press, have the new guidelines, which are joined between the European Respiratory Society and the American Thoracic Society, and were published this past September in the European Respiratory Journal. And they suggest that we use symptom-based tools to try to identify these patients who have a strong genotype and that should be evaluated for PCD. And these include the primary ciliary dyskinesia rule, better known as the Picadar score, the American Thoracic Society clinical criteria, which suggests 2 out of 4 signs and symptoms, and the ERS adult bronchiectasis guidelines. They prioritize genetic testing and ciliary ultrastructured for confirmed PCD, but give us ancillary tests like nasal nitric oxide, high-speed video microscopy, and immunofluorescence to use in the newly PCD highly likely categories, which we are very excited about. And so for these patients who have a strong clinical phenotype and whose genetic testing or ciliary ultrastructure is non-conclusive, but have one of these adjunct tests, could be classified into this category. They also provide suspected PCD, PCD unlikely, and PCD highly unlikely guidelines. And so let's look at PCD and heterotaxy. This is a study by Andrew Barber, Adam Shapiro, and others. It's a multi-center prospective study that looked at 559 participants with confirmed PCD. They stratified them based on their ultrastructural defects as well as their genotype. In this particular cohort, 50% of the patients had situs solitus, 39% had situs inversus totalis, and 10% had situs ambiguus. They defined heterotaxy in this group as patients with situs ambiguus with complex congenital heart disease, and found that in that 10% of situs ambiguous patients, 2.5% had heterotaxy. Laterality defects were more commonly found in the outer dynein arm defects, and 4.5% of patients within that group had heterotaxy, whereas none in the inner dynein arm microtubular defect group had heterotaxy. And so how do these patients with situs ambiguous fare out clinically? And so this was the purpose of this multi-center cross-sectional analysis of 397 patients who were 21 years of age or younger with confirmed primary ciliary dyskinesia. They divided the groups between situs ambiguous with or without heterotaxy and no situs ambiguous. And they found that for the situs ambiguous group, these patients had less or decreased pulmonary function, worse nutrition, and increased hospitalization and need for IV antibiotics for respiratory illnesses. And so Dr. Lowe talked about this, so I'm going to quickly review it. And so this is how did these patients with heterotaxy did in their post-op state. And so the patients with heterotaxy compared to those with congenital heart disease and no heterotaxy did worse for the post-surgical events of post-surgical death, ECMO requirement, tracheostomy, and prolonged ventilatory course. Why is that? And so the answer to that is not fully understood, but this study sheds light into it. She also talked about it, so I'm not going to repeat it, but essentially these patients with heterotaxy had a good percentage of them had ciliary dysfunction as demonstrated by low nasal nitric oxide as well as abnormal motile ciliary function. There are multiple other cohorts that have demonstrated similar findings of significantly increased ciliary dysfunction and low levels of nasal nitric oxide, but only a subset of these patients had met PCD criteria for diagnosis. And this suggests that there are alternative mechanisms for ciliary dysmotility or dysfunction in patients with heterotaxy other than PCD. We must remind ourselves that in heterotaxy, there are multiple other respiratory issues that are not primary ciliary dyskinesia or HACD. And these include recurrent respiratory infections secondary to immunosuppression or prolonged ventilatory state, sleep disorder breathing, bronchiectasis, which could be the result of immunodeficiency and or aspiration. Also, these patients can have lung diseases that are associated with their cardiac pathophysiology. Like for instance, in patients with Fontan physiology, these patients have a high incidence of plastic bronchitis and pulmonary edema. Patients with chronic pulmonary vasculopathy can have pulmonary hypertension and pulmonary embolism. Furthermore, airway anomalies are common in patients with heterotaxy. Up to 30% of patients with heterotaxy were found to have airway anomalies. The most commonly identified ones, depending on who you look at or which study you look at, are lower airway stenosis and tracheobronchomalacia, but others include subglottic stenosis and tracheal bronchus. In addition, these patients can have lung disease that is post-surgical and includes iatrogenic vocal cord dysfunction leading to chronic aspiration, ventilator-related lung injury, diaphragmatic paresis, etc. And so when should we be thinking about heterotaxy-associated ciliary dysfunction? And so these patients are going to have a similar phenotype than that of patients with PCD, perhaps milder and sometimes with some atypical features. But some of the symptoms to think about will be chronic wet cough, chronic nasal congestion, recurrent otosino-pulmonary infections, neonatal respiratory distress without a causative cardiac lesion. And I put a question mark in there because, at least for me clinically, that's very difficult to tease out what's what. Is it the heart? Is it the lungs? And we all here know that that's a common point of discussion. Cerebral ventriculomegaly and hydrocephalus could be atypical presentations that we also see in primary ciliary dyskinesia. Unexpected prolonged post-op respiratory complications. And so when all these patients with a phenotype of PCD should be evaluated for PCD, and if the workup is negative, understanding that we're still learning about PCD, then we can make the suggestion or the working diagnosis that this is heterotaxy-associated ciliary dysfunction. And so how do we evaluate these patients? Hopefully there's been enough evidence here today to demonstrate that every patient with heterotaxy should be evaluated by a pulmonologist. When able, we should be getting lung function testing. And these patients with respiratory symptoms that meet the phenotype PCD criteria should be evaluated. Some would argue that all patients with heterotaxy and respiratory symptoms should be evaluated. And that's what we do in our center. Nasal nitric oxide measurement for patients that are 5 or older, and nasal nitric oxide measurement using tidal breathing for those that are 2 years of age or older, and of course PCD genetic testing and or ciliary ultrastructure evaluation. Knowing this, however, we are not doing great. This is a study that we did looking at how patients with laterality defects were being referred and evaluated in our center. Now, this was from 2009 to 2021, so it's a little bit old, so hopefully we're doing better now. But we found that for all the patients had laterality defects, and that should be a red flag for evaluating these patients, right? And so taking that into consideration, we looked at the other criteria for these patients and found that for those patients that had 4 of the criteria, the referrals were pretty good. We will still not evaluating all the patients, but very good. But if we look at the 2 or 3 criteria columns, we can see that we are missing a lot of referrals to pulmonary. And sadly, even when those patients are being referred, we're not always evaluating them. So the next step for this would be to educate the people who refer patients to us, like cardiologists and NICU doctors and general pediatricians, and also educate our pulmonary group into ensuring that these patients get appropriately evaluated. For other patients, the evaluation is going to be based on their clinical presentation. Of course, for patients with PCD, HACD, and bronchiectasis, we want to obtain cultures regularly, but also when there are concerns for active infection. Flexible bronchoscopy when there are concerns for airway anomalies, as well as for surveillance cultures. When there's concerns for structural lung disease and or bronchiectasis, we recommend getting a high-resolution chest CT with inspiratory and expiratory views. Swallow study or FEES for signs and symptoms of dysphagia, and an ultrasound of the chest for diaphragmatic movement disorders. All pulmonologists screen or should screen for sleep disorder breathing, and when the screening is positive, these patients should get a sleep study. And so the management is going to be based on the respiratory symptoms. And for patients who are diagnosed with PCD, we want to follow the PCD Foundation guidelines. But for the other patients that have HACD or bronchiectasis, we want to be thoughtful about initiating airway clearance, but we also want to do this in concordance with the other teams and services that evaluate these patients, like cardiologists, neonatologists, the cardiac ICU. Every center will do this a little bit differently. And so in our center, when CPT is not contraindicated, we'll usually use the best short-acting beta agonists and mucolytics. For the perioperative period and during acute respiratory illnesses, you want to have a low threshold for initiating airway clearance strategies, as well as antibiotics. Longitudinal follow-up for the patients will depend on the respiratory clinical presentation, but for PCD, HACD, and bronchiectasis, we recommend every 3 to 4 months evaluation. So clearly, much research is still needed for us to try to understand how to best treat these patients from the respiratory standpoint. On a good front, primary ciliary dyskinesia is in a dynamic phase of discovery with better techniques for genetics, better disease characterization, and this will undoubtedly help the heterotaxy population. But we still don't know what the timing of the interventions should be like, which respiratory interventions are most effective, genotype-phenotype therapy correlation, and the long-term outcomes in lung function and quality of life in treated versus untreated heterotaxy patients with ciliary dysfunction. And so back to our patient, he was discharged 2 months post-op, followed up in the PCD clinic at 22 months of age. He presented with daily cough and nasal congestion, had a cold at the visit, but had otherwise been doing well. Exercise intolerance per cardiology was secondary to his cardiac pathophysiology. He had not had any ear infections, and his swallow study was negative for dysphagia. We obtained a CF throat culture that showed lactose fermenting gram-negative rods and continued airway clearance twice a day, with plans to measure nasal nitric oxide at his next appointment and a follow-up in 3 to 4 months. In terms of what his pulmonary diagnosis is, so we are between PCD suspected, PCD highly likely, and HACD. And so hopefully we'll measure nasal nitric oxide and be able to place him in one of these diagnosis, and in the meantime, we will keep treating him with airway clearance as well as a low threshold for the use of antibiotics. And in conclusion, patients with heterotaxy have particularly high rates of ciliary dysfunction. Ciliary defects are implicated in both laterality defects and impaired mucociliary clearance. Heterotaxy patients show more severe respiratory complications compared to other congenital heart disease populations. The clinical implication is obtain a pulmonary consult for all patients with heterotaxy and consider airway clearance therapy and close monitoring for infections in patients with heterotaxy. And Steve Sperging wanted me to add here the link to our now live page for the heterotaxy program, which is up and running. I don't know if it'll do its thing, but there you go. All right. And with that, I thank you for your time.
Okay, so at this point in the program, Dr. Shapiro probably needs no further introduction, but so he is Associate Professor of, I'm sorry, not respiratory medicine. It is respiratory medicine, but you're a respirologist. Okay. A medical director of the PCD Foundation Clinical and Research Center Network, and he's been researching heterotaxy and organ laterality defects in motile ciliopathies for over 15 years.
I always think of what my wife and kids would say when they hear my name thrown around at conferences, and they'd just be like, "You? Like, this is crazy. Why are people talking about you?" So I'm very honored, but I think it's a case of being in the right place at the right time, honestly. I'll let you, because I've got it on presentation mode.
Yep. I didn't see a handshake.
But my wife and kids would expect me to break the computer, so that's perfect.
Yeah, I just did that right now. Okay. Let's protected view.
Okay, great. Thank you so much. So here are the objectives. I'm going to be a little bit of a Debbie Downer in this talk because I'm going to show you that a lot of the stuff we do has a lot of limitations, and I'm not 100% sure that heterotaxy-associated ciliary dysfunction exists. I think it exists clinically. I just don't know that we have the right test to look for it thus far. So I've already talked about PCD. One of the things I want you to know is PCD is actually a lot more common than we used to think. We used to think it was 1 in 30,000. When we look at just 29 genes and look at the prevalence of those variants in those 29 genes, and again, there's over 60, that puts the prevalence based on a lot of different genetic databases about 1 in 7,600. So it's about as third as common as cystic fibrosis. So if you think of your cystic fibrosis population as your hospital, and there are 300-400 kids, you've probably got about 150 PCD running around. And again, we know that laterality defects, situs ambiguous heterotaxy, whatever you want to call it, actually occurs in up to a quarter of those kids in the right populations. And really, the key to picking out a kid with PCD is to look first at the 4 key clinical symptoms. Neonatal respiratory distress with oxygen or CPAP need in a term infant. In many kids with heterotaxy with heart defects, that's a given. Okay. Early onset, year-round wet cough. It never, ever, ever goes away, even on the best day in the middle of summer. Early onset, year-round nasal congestion. Never, ever, ever goes away. It's present before daycare. It's present at age 12. It's always there. And then any organ laterality defect, which is where heterotaxy falls into this. If you have 2 or more of those symptoms, you're 80% likely to have PCD. But if you have all 4 of those, you're 99% specific, and so you probably have PCD right there. And it's those kids with 2 or more symptoms that, like Yadira talked about, that need to be sent to pulmonary medicine. The problem is many kids with heterotaxy, you're getting asked about them in the neonatal period, and they haven't had time to establish this phenotype yet. And once you then know this is a kid we want to work up for PCD, the problem is our tests don't detect it all. About 20% of the kids, despite all your testing, will have inconclusive diagnostic tests. The 2 gold standard tests per the new ERS ATS guideline are a genetic mutation, at least a biallelic variant, a known PCD gene that is autosomal recessive. There's a few non-recessives, or electron microscopy defects. And then a screening test is nasal nitric oxide, which can be done in kids over 5 years of age, and we now can do it down to 2 years of age. But about 10% of those will be completely normal in PCD. And then you've heard a lot of talk about high-speed video microscopy, or measuring the beat pattern, looking for ciliary dysfunction, and then lastly immunofluorescence. I'm not going to talk much about that. But I need people to recognize the limitations of high-speed video microscopy. In some European centers, and it's mainly 3 centers in the UK, it was their previous gold standard for PCD diagnosis. And you basically can scrape cells out of the nose right there in clinic, and you can look under a special high-speed video microscope and record it and look at playback later. And if you have normal beat, we all saw what normal looks like. If you have an outer dining arm defect, often you'll have totally immotile cilia, some flickering, but not a lot. The problem becomes there's variants where inner dining arm defects with microtubule disorganization, and some others will have a slightly decreased amplitude, or like Dr. Lowe said, a wavy appearance, and then central apparatus radial spokes will look normal from the side, but from the top you'll see whirling, so you have to look at it in different phases of view. And the big problem with this is there's absolutely no standardization to how you interpret this, okay? There's a lot of subjectivity. In how it's done, how it's prepared, how it's read, and even normal controls vary between many different labs. And so if you haven't done 500 to 1,000 of these, you're not doing them correctly, and you are misdiagnosing left and right. It is a very, very, very hard test to do. The other problem is secondary ciliary dyskinesia can be caused by a virus, smoking, meds in the nose, recent instrumentation, recent surgery, recent anesthetics that were inhaled. We just don't know what all of those things do. And so the European recommendation is actually to do this after air-liquid interface and regrowth of the cells for 6 weeks, which is pretty difficult to do in a clinical circumstance. Or you have to bring the patient back 3 times and do 3 different readings, 3 different samples, 3 different readings, and hope they're the same. Well, that's easy to do when your country's the size of Belgium. It's much harder to do when you have patients coming from hours and hours away. So nasal nitric oxide is another screening test that we use, and for some reason the values are incredibly low in PCD, often 1/10 of what it is in a normal person. Values less than 77 nanoliters per minute in an older kid that can blow into a resistor are incredibly sensitive and specific for PCD. Once you get below age 2, like Dr. Lowe told us, the normal levels of NO increase with age, probably due to sinus growth. It's very, very important you have to do this with proper validated machines. Chemiluminescence analyzers, which cost over $100,000, and an appropriate protocol must be used, or else the values just aren't reliable, okay? And you have to repeat this, because as I'll show you, it can be low from many, many different causes. And an isolated nasal node on one occasion doesn't mean much, okay? It's got to be repeated. And of course, these special devices are not FDA approved. But you can see it's a pretty easy test to do. These are my 2 children when they were young, acting as my research subjects. I signed consents to put them in the articles, it's fine. But they're blowing into resistors, the little sponges in the nose, no deeper than a finger. They all laugh when I tell them that. It's gently sucking out nitric oxide, and it's measuring it in real time when you get to a plateau, a steady state, which you can see on the graph that comes from the computer software. And we've actually looked at this in many, many different types of heterotaxy, which was called situs ambiguous at the time because that's what reviewers made us use. But we looked at people with what no one in this room would bat an eye backlash at calling this heterotaxy. We looked at kids with simple cardiovascular defects and other laterality defects. We looked at kids without heart defects, but just organs that were malformed and flipped, and some that just had like an interrupted IVC or an isolated right aortic arch. And when they had PCD, the nasal nitric oxide was incredibly low. You can see the value here is well below 100 in all these patients. But it can be low with other diseases. It can be low in about a third of cystic fibrosis, so you have to have ruled that out. It can be incredibly low with a viral infection, and it will stay low for weeks with a viral infection. And the problem is you're doing this in 2-year-olds who are in daycare and always viral. So I've had kids fool me for years, and I've said, come back when you're 4 years of age in the middle of summer and we'll try it then, and they've gotten normal. If you had any recent nasal instrumentation, they can't just come from ENT clinic where they got scoped, it will be low. If they've had bleeding, blood is a sponge for NO. It will soak up NO and give you low values. If you use non-standardized protocols or devices, you'll have low values. So it is fraught with things that will make it insensitive and unspecific. Electron microscopy was the gold standard for PCD for many years. You scrape some cells out of the back of the nose, or you scrape some cells from the lower airway, and you look under the electron microscope. On the left, you can see that that's a normal ciliary EM with the nice hooked comma-like outer dining arms in the 9+2 configuration. Then in figure B, you see you're missing the hook, the comma of the outer dining arms. In the next one, you're missing the outer and inner dining arms. And in the third one, you have microtubule disorganization with absent of the inner dining arms. And again, incredibly difficult to do. We only have one single lab in all of Canada that does this. We have 2 PCD Foundation accredited labs in the US, and I don't have faith in many even great pathology labs that think they can do this. You will have 20% of the samples fail to get even readable cilia at the best centers in the world, okay? And you have to do this when the kid is not viral. You have to do this when the kid hasn't just had surgery. Any insults to that nasal pharynx when the kid's got an NG tube in and being suctioned by the ICU nurse all the time will mess up your EM. And we know that even with proven PCD through genetics, 30% will have completely normal EM. So what about genetics? There's been an explosion. We're over 60 genes since I started doing this in 2007. And to put it in kind of perspective, look at all these genes lined up. Look at all the exons you have to cover. Some are massive. And then you see that nice little pink gene for CFTR. That's the CF gene that I grew up with. And it took us about 40 years to understand it. And it's about a third the size of some of our common PCD genes. Think of all the variants of uncertain significance you get when you order these. You need a really experienced geneticist to understand it. It's not just autosomal recessive. We have X-linked causes. We have autosomal dominant causes. It's a real mess, honestly. And when someone says to me, okay, what is the pickup of PCD genetic testing? Well, it depends where you are. If you've got predominantly white Northern Europeans, then it'll pick up about 82% because those were the initial populations we studied and learned about this. But if you are in South Asia, it's a completely different gene that's driving almost 40% of this, and that's different from the Middle East, and that's different from Japan, and we have no idea what South America and Africa have. And if you look in the north of Canada at our Inuit population, 100% of them have it due to founder effects in DNAH11. So if the gene that's affecting your population is not on the panel, you're not going to pick it up. And this is why people are moving more towards exome sequencing. But actually, you have a much better pickup chance in patients with heterotaxy than you do in a patient without heterotaxy. And the reason is all of the genes in blue that we've recently been discovered to cause PCD, they do not result in laterality defects because they don't affect they don't affect the dining arms. They affect the central apparatus of the radial spokes. And so the embryonic nodal cilia don't need those things to work, and they move normal. And the other thing is many early discoveries of PCD genes were done in people with laterality defects. So we have done a pretty good phenotyping and genotyping job in these people, but it's not perfect because often you won't get 2 hits in the same gene, and that's what you need. 2 pathogenic or likely pathogenic variants within the exact same PCD causing gene, and then that can explain your PCD and your heterotaxy. And they've got to make sure they both come from each parent, one from each parent. They've got to be in trans if you have parents you can test. There's still no digenic causes because often you will get back panel results with 5 different hits and 5 different genes, but they're all heterozygous, and you can't diagnose a kid with PCD based on that. Most of the genetic panels that people are using cover 40 to 50 known genes. If you order a heterotaxy panel, the good news is most of those dining arm genes will be included in there. at least the ones known to cause laterality defects, but not all of them. Whole exome sequencing is more accurate. It'll pick up more, especially with large deletions, duplications. And whole genome sequencing, we now know, will add about a 6% increase in diagnostics from the kids where you have single hits. If you then test the whole genome, they'll have intronic variants that increase or give you a positive diagnosis. So what do? We've all talked about it. That kid sitting in front of you that you're fairly certain they don't have PCD. Maybe their cough is not every day. Maybe their nasal congestion gets better in the summer, but they've got something. Okay, and so as Dr. Lowe pointed out really, really nicely, if you scrape cells out of these kids' nose, they beat funny very frequently, probably about a third to a half of cases. And if you test nasal NO, you can see kind of intermediate levels. And we saw that where I was a fellow. We have a huge cohort that I never published that showed they have intermediate levels. They're not low like PCD, but they're right, near 100 to 130 nanoliters per minute. And we know that they have worse surgical outcomes, as she showed very nicely. But we also know that not everything correlates. Sometimes there's lower NO, sometimes that correlates with the ciliary dysfunction, sometimes they have increased respiratory symptoms, sometimes they don't, and sometimes we find the same thing in non-heterotaxy heart disease. That kids, about 30% of kids, if you do these tests with non-heterotaxy congenital heart disease, will have this as well. And importantly, we haven't really done a great job of doing nasal NO repeatedly in these kids to see what happens over time, or high-speed video microscopy longitudinally. And so that's what's missing from this. And so we have to ask ourselves, why are these people getting more ciliary dysfunction? Is it due to congenital heart disease in general? Does that impart the risk? Is it abnormal nasal NO levels? Is it a heterotaxy status? Or are we just using imperfect tools to diagnose this? And I think it's probably that. We're not using perfect tools. The tools we're using could be subjective and could be secondarily affected. What we really need is in vivo studies, taking live people and looking at how their cilia work inside of them. Okay, and we need to do that in people with and without heart disease, in people with just laterality defects and not heart disease, in people with just VSDs. We need to do this to see if it's all around heart disease, and we need to do it in healthy controls. Okay, and we need non-subjective, standardized, reproducible tests when patients are in their baseline state of health, and that's key. Anyone that does a test on a kid and you're trying to convince me that they have secondary or some type of ciliary dysfunction, you got to tell me they don't have a virus on PCR at the same time, okay? Because kids are just full of viruses. And so we actually have a test for that. It's called mucociliary clearance testing, and the most common methodology is using a radio-labeled isotope of technetium-99. And you can inhale that into the lungs, and you can watch with a gamma camera scanning people. It's minimal amounts of radiation over 1 hour, 2 hour, 24 hours, and you can see in the above images here, at 24 hours, they've cleared all the tracer out. And then you can see in an abnormal person that tracer's collecting in the large airways and not forming boluses discretely that move up into the trachea and are swallowed in the esophagus. And we actually have international recognized protocols for this from the Cystic Fibrosis Foundation. There's about 6 to 10 centers across the US that do this well. And we have a European standard out of Copenhagen, Denmark that does this well. And we're using this as outcome markers in PCD restorative therapy trials as we speak. So we have the tools to do this. And this is basically what you can do. You can put a patient with PCD or heterotaxy with PCD in front of a gamma camera, and you'll see they have absolutely no mucociliary clearance until you tell them to cough. And then they'll start moving stuff. And you can compare that against children with cystic fibrosis who have some mucociliary clearance, but it's not robust, and normal patients who clear about 30% of their inhaled isotopes by 1 hour. And this has actually been done in PCD patients, where Sharon Dell in Toronto took almost 60 patients with presumed PCD, but she couldn't prove it in all of them. And she used a reference standard of abnormal genes, abnormal EM, or repeatedly low nasal nitric oxide. And if you did a mucociliary clearance test with 2 hours worth of scanning, you could actually confirm that they had abnormal mucociliary clearance in 95% of the cases compared to the gold standard, and it was incredibly sensitive and specific. And it could rule out ciliary dysfunction with 100% sensitivity, basically, with 100. You could rule it. Spin, snout, sensitivity rules out. Yes, you could rule it out with 100%. So that's what we need to do in this population. I'm convinced there's a signal. I'm convinced Dr. Lowe has shown us there's a signal. I'm convinced there's something there. We need to prove it, though. and we need to prove it with good in vivo testing. So I want to thank, these are my PCD folks, mad props to the PCD folks, including Michelle Mannion, who is our version in the PCD world of Nisha Sabin here, and has really driven all of the work we've done in PCD along with our researchers. Thank you guys so much.
And our final speaker for this session is Dr. Brown. He has 3 daughters who occupy all of his time when he's outside of work, so you're free today? Okay. He dislikes mirrors and clocks, anything that measures the passing of time, and he'd like nothing more than to resolve the structure of LRO cilia. So, Dr. Brown.
Okay. Hello, everyone. I'd like to thank Ken for the invitation to speak today. I am a basic scientist, so this conference has been a lot more emotional than I'm used to, but I would like to thank particularly the speakers in the morning session for reminding me why I do basic science. Okay. So, as you're all aware, heterotaxy is caused by impaired genetic and developmental pathways that lead to left-right asymmetry of the body organs in early embryogenesis. And a key part of this process is the development in early embryogenesis of the embryonic node, also known as the left-right organizer, or LRO. And in humans, this happens about 17 to 19 days post-fertilization. And the embryonic node is a ciliated embryonic tissue. And these cilia beat in a clockwise fashion, and this generates a leftward fluid flow. And this fluid flow is detected through a hotly debated mechanism by immotile cilia that are at the node periphery. And this initiates a signaling cascade that leads to differential gene expression, which ultimately establishes organ laterality. Now, to understand nodal cilia, how they function in health and disease, and why they rotate, what we would ideally like is structural information, either at the molecular or even the atomic level. However, there are many reasons why obtaining this structural information is almost near impossible. Firstly, the embryonic node is a very transient tissue. It's present only for about 4 to 5 days in embryogenesis. Secondly, it's also very small. There's only about 200 to 300 cells. Each cell only has a single cilium, and if my maths is right, this means there's only about 200 to 300 cilia per node. And so there really aren't that many to study. And also, as I've already mentioned, the embryonic node has different types of cilia. So at the periphery, there is the immotile cilia, but within the embryonic node, there's also some evidence that there are different types of motile cilia. And finally, there's no really well-established cell culture-based system for studying the embryonic node or nodal cilia, which means that most studies require access to embryos. Despite these challenges, we do actually have some structural information in the form of thin section transmission electron microscopy, or TEM, which we've already covered a lot in this conference. But I just want to remind you of how you create these kind of images. What you need to do is extract the embryonic node, and then you need to fix it with chemicals like glutaraldehyde or formaldehyde, and then you stain it with heavy metals like uranyl acetate, then you dehydrate it, and then you embed it in a resin, and then you finally slice the resin into thin slices, which you put under the electron microscope. And so it's not surprising with all these manipulations that you ultimately end up with very low resolution images that suffer from a lot of artifacts. And as Adam mentioned, it's very difficult to actually do this. But we do have some thin section TEM images from nodal cilia. And what they show is this ring of 9 doublet microtubules, sometimes surrounding nothing, and sometimes surrounding this amorphous electron-dense material in the middle. And this ring of 9 doublet microtubules is a common feature, kind of universal to all types of cilia. And we have good TEM data from respiratory cilia, which shows a very similar organization of doublet microtubules, except that this time these doublet microtubules encircle a well-defined central pair of singlet microtubules, which is known as the central apparatus. And studying respiratory cilia is a lot less challenging than studying nodal cilia. They're a lot more abundant, and they persist throughout your lifespan, and they can also regenerate after injury. And if you do some back of the envelope calculations, there's about 0.2 meters squared of respiratory ciliated epithelium in the adult body. And these samples are very easy to access and to obtain for research. You can obtain them from a nasal scrape, for example, or a biopsy, or a donation of the trachea. And there are good systems for studying these in cell culture. For example, there are organoids where you can take nasal scrapes and you can grow something that resembles respiratory epithelium that becomes ciliated. And there are good methods for isolating, imaging, and analyzing the respiratory cilia. But there is one downfall of using respiratory cilia as a model for nodal cilia, in that they have very different waveforms. So nodal cilia will rotate in this clockwise fashion, whereas respiratory cilia have more of a planar waveform that can be described maybe as a breaststroke. There's a large effective stroke which pushes the mucus, and then a kind of shallower, gentler stroke to recover the initial position without disturbing the mucus. But putting aside this difference in motility, can we learn something about nodal cilia structure from studying respiratory cilia? So as I mentioned, respiratory cilia are easier to work with, and so we have good TEM images. And these show this canonical 9+2 organization of the ultrastructure, which is also known as the axoneme. And associated with each of these doublet microtubules are different types of dynein motor that power motility. So we have the outer dynein arm in red and the inner dynein arm in yellow. And bound amongst these are regulatory complexes. So we have the nexin-dynein regulatory complex in green that kind of connects neighboring doublet microtubules. And we have the radial spokes in blue, which point inwards towards this central apparatus. We also have thin section TEM images showing a longitudinal section through respiratory cilia, which shows that this ultrastructural, this axoneme, is actually built up of 96 nanometer repeat units. And these repeat units can allow cilia to form micron scale structures. And so TEM has provided a lot of information about cilia, but at low resolution. And so we wanted to go further. We wanted to see if we could obtain a higher resolution structure of respiratory cilia. And to do this, we've used a different technique called cryo-electron microscopy. And essentially, this approach abolishes all those manipulations needed for the thin section TEM. Instead of fixing, staining, dehydrating, and bedding, you just take cilia, gently disrupt it slightly, and then freeze that into vitreous ice. And then you can place that immediately under the electron microscope. And we get our samples of respiratory cilia from individuals, including patients with PCD. We take a nasal scrape, we grow these organoids, we isolate the cilia, and then we put these cilia under the electron microscope. And the images that we get back look fairly unremarkable. But if you collect thousands of these and you select out this 96 nanometer repeat unit, what you can do is combine these in silico to generate from these two-dimensional images a three-dimensional structure of the 96 nanometer repeat of the doublet microtubule. And if you do this with enough images that have been collected at high resolution, you can actually see in this density map individual amino acids. And by looking at the pattern of amino acids, we can work out which protein they correspond to. And so we can go from the micrographs on the left to actually being able to identify the proteins in the structure. And so we've been able to do this for a number of different cilia types. And from these density maps, we've now been able to build atomic models showing the organization of all the different proteins that bind to the doublet microtubules and form this complex. Now, this is incredibly complicated, but we can subdivide or group these proteins into their individual subcomplexes. I've already mentioned the altodynin arms. There's 3 different radial spokes. There's 7 different innodynin arms, numbered A to G, with innodynin arm F shown in bright yellow being unique amongst those innodynin arms. What we can also do is to take this model of a single 96 nanometer repeat and in the computer just generate the ring of 9 doublet microtubules. And you'll notice here there's a hollow kind of space in the center. That's where the central apparatus appears. And we now have structures of the central apparatus, again from a couple of different organisms, including mammals. And what we can do is we can then take that structure, just dock that in silico into this ring of doublet microtubules to build a model of the near complete model of the repeat unit of an axoneme from respiratory cilia. And what this structure shows us is that there's about 171 different proteins that form this structure in humans, in human respiratory cilia. And we can subdivide those proteins into 7 groups. I've talked about some of these subcomplexes like the altodynin arms, the innodynin arms, the radial spokes, the NDRC, and the central apparatus. But there's a couple more I need to mention. There's the microtubule inner proteins. These are the proteins that bind inside microtubules. And there's the MAPs. These are the proteins that bind outside and provide like a coordinate system telling the other axonemal complexes where to bind. And so we can subdivide this complicated structure into these 7 groups. And as we'll see later, these groups make it easier to compare across different structures. So now that we have this structure of the axoneme from respiratory cilia, how can we use that information to better understand nodal cilia? Well, one thing that we can do is to better annotate these TEM images of nodal cilia. For example, we can now very confidently say that they have altodynin arms. They also have density that is likely to be the innodynin arms, but there's clearly no well-formed central apparatus. So we can annotate the TEM images, but we can also annotate single-cell RNA sequencing data. And there's really, as far as I could find, there's only been one study that's been able to do single-cell RNA sequencing, which came from Stephanie Waugh's lab from a couple of years ago. And they were able to isolate embryonic nodes or left-right organizers from free mice embryos. They were able to perform single-cell RNA sequencing at the 0 to 1 somite stage, which is when you start to see the fluid flow in the node. And then they were able to perform the single-cell sequencing. They obtain about 22,000 cells, and by looking at the gene expression within these cells, they can generate 16 clusters using unsupervised clustering. And then if you look for the expression of genes that are known to be expressed in the left-right organizers, like DAN5 and FOXJ1 and nodal, they were able to identify which cluster of cells corresponds to the ciliated cells of the embryonic node. Although it's fair to say that the population of cells is very small. There's only 238 cells in this population. And then they look to see which genes are specifically enriched in this population of LRO cells. And they found 196 that were both specific, enriched, and fulfilled very strict criteria. And then they used crude gene ontology analysis to look for what pathways these genes might be involved in. And not surprisingly, among the very top hits are genes involved in axoneme assembly or cilium movement. But now that we have this structural information and a better understanding of which proteins actually make the axoneme, we can do a more fine-grained analysis. What we can do is take this set of 196 genes, and we can find out that about 82 of them encode known components of the axoneme. And we actually find proteins or genes associated with every single one of the axoneme subcomplexes. The MIPs, the MAPs, the ODAs, the outer-dyne arms, the inner-dyne arms, and, interestingly, the central apparatus. Now, this was just examining 196 genes that the authors said were enriched and fulfilled these strict criteria. But if we now look at all the genes expressed in this cluster, we can find a total of 2,250 genes, and of those, 127 correspond to axonemal proteins, so about 2/3 or maybe 3/4 of the expected number that you would expect to see in an axoneme. So again, we see every single subcomplex is represented, suggesting that all these axonemal genes are expressed in nodal cilia exactly as they are expressed in respiratory cilia. What we don't know is whether the genes that we're not seeing expressed are really not expressed, or whether they're just not detected in the single-cell RNA sequencing because of the very small cell population. For example, we didn't see the genes DNAH2 and DNAH10, which are the kind of core motor proteins of inner-dyne arm F. So this momentarily excited me because inner-dyne arm F is a critical motor in the axoneme. So maybe its absence could explain this difference in motility. But then when you look through the literature, there are reports suggesting that both DNAH2 and DNAH10 variants in those genes do lead to laterality abnormalities, suggesting that they are expressed in the node and have just not been picked up by the single-cell RNA sequencing. I mean, one of the most surprising kind of discoveries from doing this analysis is that 16 of the 27 known central apparatus proteins are expressed in the node, and yet the TEM images show no evidence for the central apparatus being assembled. So are the components that aren't being detected, are they really not expressed? And are these components essential for forming the ciliary central apparatus? Or is there a different mechanism that is preventing the ciliary apparatus forming? Does this electron-dense kind of amorphous blob in the middle of some of the nodal cilia, does that represent a failed assembly of a central apparatus? We really don't know, but it's very puzzling that the central apparatus proteins are expressed, but the central apparatus is not formed. And so just to conclude, cryo-EM has enabled the determination of near-complete atomic models of respiratory ciliary axonemes. We've been able to integrate these cryo-EM structures with single-cell RNA sequencing data to provide insights into the molecular composition of nodal cilia, and we find that most axonemal proteins are expressed within the embryonic node. And the absence of the components that we haven't detected may reflect true lack of expression, but they may equally represent limitations of the small population size. What we really need are bigger studies from single-cell RNA sequencing, from humans and from other organisms. And really, disappointingly, this question of why nodal cilia rotate and respiratory cilia waft remains unanswered. And I'd just like to thank my team, particularly Travis Walton and Miao Gui, who did most of the work on the mammalian axoneme, and our collaborators, facilities, and funding. And thank you for listening.
Maybe I'll bring the panel up and open it up for, see if there are any questions from this session. So maybe I'll just start with that presentation. How should we be thinking about the ciliary function that we're seeing or we think may be impaired in these children with heterotaxy? Is there something we can learn from kind of work you're doing?
I think so. I think a better knowledge. Oh, yeah. Okay, great. I think with a better knowledge of the genes and the proteins involved in generating motility across different types of cilia, that will help improve the genetic diagnosis. It will make the genetic analysis easier. We'll know which genes to look at when we have patients with, heterotaxy with maybe ciliary dysfunction or recurrent respiratory disease. And so I think there is a link between what we're doing and better analysis and diagnosis of the patients with heterotaxy.
Yeah, I think cryo-EM is regular EM on steroids. It's just hard to get from a clinical standpoint. We will commonly have patients with partial outer dining arm absence. It's shortened in, 50%. It's not there in 50%, but there's certain cross-sections that are normal, and the genes will show one variant in DNAH5, but we don't have the second variant. And cryo-EM could be a wonderful diagnostic tool if we could find a way to kind of speed it up and get it diagnostically. Right now it's a lab tool, but it could easily show you're actually missing 3/4 of your dining arm proteins, and it could be used diagnostically.
But I would say I think we're many, many years away from it being a clinical
Yes.
tool.
Oh, yes.
Question?
Hi, thank you for a series of just fantastic talks. My question is for Dr. Lowe. And you mentioned the type 2 heterotaxy genes that always cause heterotaxy in animal models, and one of them was MMP21. Where is that gene expressed? Is that a ciliary gene, or is this one thing I'm interested in is how the downstream things post-nodal events occur? Is that what's going on with the extracellular matrix or what?
Yeah, as you know, MMP21 is a metalloprotease, right? So it's involved in remodeling the matrix. It is expressed in the node, but whether the function is strictly just in the node or how signal is transmitted from the node to the lateral plate mesoderm, for example, it's not known. So not much work has been done on it. We have not really pursued it. There was a group in Jackson Labs that were trying to do some work on it, but I think that I don't know where it is with that. So sorry, I don't have more insight.
That's okay, thank you.
Okay, hi. So I have about 10 questions, but I'm going to choose one. All right, so here's the thing. The diagnostic tools we have been using in clinical practice for 15 years for PCD really just aren't going to work for heterotaxy-associated ciliary dysfunction, if that truly exists, okay? But is there a possibility that some of those tools might have value, like nitric oxide, for example? We saw in many of those studies, nitric oxide levels in heterotaxy patients are not PCD level, but they're not normal either. Is there any value in saying that nitric oxide can have a quantitative assessment of how the cilia actually function, or is it black or white? It's either normal nitric oxide or not normal nitric oxide.
I can start. I mean, we all want a yes or a no, and we're not going to get that here, short of mucociliary clearance testing. And even that might not give us yes or no. I think longitudinal data is what's missing, right? No, we haven't taken these kids with heterotaxy and done nasal NO on them 4 times a year for 2 years or 4 years or 5 years to see where it goes. And I think that would be very interesting because it's a crude tool. It can be influenced by so many different things. So I think that's the first thing. We need longitudinally to show what happens over time with it. All of the other things are great when they're positive and they're hard when they're negative. And so this is why I really think mucociliary clearance scanning could, one, tell us if it's real or not, if it's done in a lab that knows how to do it. And then two, it can be done clinically. You could have a network of mucociliary clearance tests and you could piggyback on top of cystic fibrosis centers that know how to do it and actually test these patients. And it might take a test twice, you know, to make, when you're sure they don't have a virus and you're sure they haven't recently had surgery and things like that. But to me, that's going to be the ultimate goal in showing which patients have ciliary dysfunction or not. And then you got to correlate that with clinical outcomes. Are these the kids having more pneumonias? Because the problem is these patients are just so complex. It gets hard for me to blame everything on cilia when we all know there's so much going on in these kids. And we haven't even gotten to the immunodeficiency part and the heart part yet, which is coming in the upcoming sessions.
So I just want to comment that we have actually followed some of these heterotaxy patients and done multiple NO measurements because in Children's Hospital of Pittsburgh, patients come back. So there's very good long-term demographics. And so we do see that the low NO stays as low NO even as they grow older. I can't say that we've done it with all patients, but a small number of patients we have done multiple measurements. So I believe that low NO is real and could be diagnostic. But also regarding the mucociliary clearance scan, I think that's a wonderful tool, but I'm not 100% sold that that's really going to help us in all cases, only because we know heterotaxy patients generally don't have a lot of respiratory problems outside of having undergone their congenital cardiac surgeries. It's really during the cardiac surgeries that all these problems surface in an intense way that's actually clinically important. And what I'm saying is that I think that they have abnormal cilia that's very sensitive to the detrimental effects of cardiopulmonary bypass, a very low temperature, the anesthesia. So if you just do a mucociliary clearance scan on a heterotaxy patient outside of these surgical conditions, I'm not convinced that you're going to see very dramatic change in airway clearance. I could be wrong, and there could be a subset where you will see that. But the thing is that we know that most of these heterotaxy patients don't have severe respiratory problems or even otitis media. I mean, some of them do, but many of them don't. So I think that the abnormal cilia is making some change that makes them very susceptible, maybe the lower temperature. And I guess this is something that Alan could comment on, right? So co-sensitive mutations change the folding of proteins, so that it could be that in some of these kids, they have mutations that change the cilia in some way that you can detect it in terms of motion. but that when you bring it to low temperature, they just might not move. So I just want to say that I think that the mucoclearance scan is wonderful. It's very quantitative, but I don't know that it will help identify every patient that actually might be suffering abnormal motion that could actually be a problem in terms of their respiratory outcome.
And I 100% agree with you. I think it'll be the tip of the iceberg. I think one day we'll have forms of primary ciliary dyskinesia that are actually due to ciliary repair issues. You're fine till you get hit with the right organism, then you can't repair them. We're just not smart enough to see that yet. But I 100% agree with you on that.
One assay that hasn't been discussed is the ciliary transport assay, where you take your nasal scrape, you grow the organoids, and then you add like fluorescently labeled beads and watch the transport of those. And there's some people in the field, like Hema or Ram, who believe that this is a lot more sensitive than the high-speed video microscopy, and is picking out mutations that were considered normal in the high-speed video microscopy. So that's another clinical tool that could be useful.
It should be said, we're just starting to recognize atypical forms of PCD that, for instance, do not affect the ears. Hyman Omran's group published a small group, probably 10 patients with new central apparatus gene defects that basically did not have any ear disease. So we don't know the whole phenotype. We're scratching at the tip of the iceberg.
Yes, please.
Sorry, I hope it's not too forward. So I'm going to ask my simple country cardiologist question here. So if I'm understanding, there's a pretty decent amount of overlap in terms of the genetic underpinnings of congenital heart disease with heterotaxy and congenital heart disease without heterotaxy. From what I understand, there's a relatively substantial proportion of patients with congenital heart disease, non-heterotaxy, that have abnormal cilia function tests, however you want to assess that. So my question is, are we, maybe in the cardiology realm anyway, underappreciating the connection between cilia and congenital heart disease in general? And should we be looking for cilia dysfunction more broadly among our patients with congenital heart disease?
So David, I agree with you completely. And actually, some of the studies that I presented really were studies of all congenital disease patients. And the paper we published, Andrea Garrard is the first author. We included, it's like maybe 300-400 patients that were ones with and without heterotaxy. And so it was the second paper we were publishing. The first one was just all heterotaxy. And the reviewers made us take out all of the heterotaxy patients. And so that paper is really almost entirely non-heterotaxy, several hundred. And so ciliary dysfunction is actually quite prevalent in non-heterotaxy congenital disease patients. And so I also want to refer to the mouse work that we did. You know, we did this large-scale screen looking for genes causing congenital heart disease. And we recovered over 100 genes that cause congenital heart disease. And surprisingly, over 60% of them are cilia-related. Now, they're not all multicilia genes, but I would say maybe around 20%, 30% were multicilia related. So cilia perturbation is very central, I believe, to congenital heart disease, some of which, of course, will affect multicilia function that could affect the airway.
I agree with that as well. I mean, we see commonly heart defects in people with a known ciliopathy, PCD, that do not meet a cardiologist criteria for PCD. And we see kids with normal hearts. And so we have struggled with publishing. Back in 2014, when we were putting our big chest paper in on different laterality defects around that happen in PCD, that's why we couldn't use the term heterotaxy. They made a change it to situs ambiguous because they disagreed so wholeheartedly with our assertion that heart disease was related to cilia in all cases. And even when you have a known ciliopathy with a genetic diagnosis, and you have a kid with tetralogy of Fallot, which no self-respecting cardiologist is going to call a cardiac ciliopathy, they had it. And so did it just creep in? Maybe. Or was it related to the cilia? We had VSDs. We had small ASDs. We had all sorts of things that would not fit the definition of heterotaxy. It's one thing this group has really done well. In the nice review paper that came out in the OrphanNet Journal, we just defined it all as heterotaxy, and we're not calling it different things to leave people out. And I think that's really, really important. And I think they all can have a degree of cilia dysfunction throughout the body. The other thing is, motile cilia and non-motile cilia overlap. Motile cilia can sense, and non-motile cilia can do, in certain cases, things that are more prone to motile cilia. So I don't think we really understand the whole spectrum of disorders that can come from a motile versus a non-motile ciliopathy. We've seen large amounts of bronchiectasis in patients with autosomal dominant polycystic kidney disease, which is a non-motile ciliopathy. Yet when you look on the respiratory cilia, the AD, PKD1 and PKD2 channels are there. They're on respiratory cilia. So there's an overlap we can't even begin to understand.
So how should we think about screening these patients? Is there a clinical way to start thinking about screening?
Yeah, I actually want to make a quick comment
sorry.
before we go
Yes.
into that.
Yeah.
There is a lab in University of Washington in St. Louis, or WashU in St. Louis, where they have actually collected a lot of evidence that suggests that primary cilia can be motile. And so they've done a lot of video microscopy in vivo as well as in vitro with cultured cells, and also show the expression of many of these genes associated with motile cilia in cells that are not associated with motility. And we've actually seen data like that in our own RNA-seq data over the years, and we just assume it's noise. So we've seen DNH5, for example, in the heart, and you don't expect that it's really going to be doing anything. But the long story short is that you wonder whether, in fact, there's a lot of overlap between cilia and between motile cilia and non-motile cilia in terms of function. And anyway, this lab in WashU suggests that motile cilia plays an important role in insulin signaling in the pancreas. She's an endocrinologist, but she's collected data like that for all kinds of tissues and cell types. So she had a paper that was, I think, published in Science Advances, and it was a PNAS paper. But I think this is an evolving story, and I know it's very controversial, but I just wanted to bring that up so that people are aware of this literature.
Said better than I could. That's what I was trying to say.
Well, maybe we should. Oh, we have one more question.
I imagine you could. The problem would be normal controls. So you have to have healthy controls in the lab, and I don't think any researcher has healthy controls for newborns. We've got them for older children, mainly adults too, but yeah, I don't think so.
Yeah, we've actually done them in newborns, but we don't have controls. Like you said, we don't have controls. But we've done it on patients that are undergoing congenital cardiac surgery. And of course, you see that very severe depression of airway clearance, as you would expect. But we don't have controls, and that is a problem.
Yes. Yes.
On the other hand, what we really need to know, coming from just being the cardiologist and the ICU perspective, is we need to know if patients, when they come back from the OR, we need to get them excited about. And so our testing modalities are pretty limited. And when you presented that, I was like, whoa, this could be great. That we touched on before.
So Tina, I mean, the thing is, you can do these scans pre-op, right? So we've done pre-op and post-op scans. And what you see pre-op can tell you a lot about what you might predict post-op. When you do post-op scans, what we found within the first 24 to 48 hours, nobody has airway clearance, okay? So we were quite shocked by that, absolutely zero. Right, so which is what you would have, I guess we should have expected that, but it's nice to see it quantitatively.
Very nice.
So, but pre-op is, I think, the way to go. and that may give you some idea to predict how the patients would, what kind of care they're going to need post-op that could come from airway clearance issues.
From a practical perspective, what we find is testing modalities that lead to turnover in 0 to 5 days
Yeah.
postnatally, and that will give us some predictive information on who needs to be in and how. Because if you think about it, the worst thing you can do for a PCD patient is stick a tube down their
Yes.
throat, because they can't, their only method of airway clearance.
Right now, it's a rapid genome. That's what you got. And the ones that are positive will help, and the ones that are negative, I think it brings up a larger point. The lungs get neglected. I have a kid in my ICU right now with a double outlet right that is misbehaving. He's been intubated for 2 months. He's not doing well. He had a whole genome or whole exome done prenatally on an amnio. I have no idea if they really looked for all the PCD genes on that. I've now resent a PCD gene panel to start just to see if I can pick something up. He's growing Pseudomonas and Stenotrophomonas in his airways, which is highly suspect for PCD. He is, every time they go down on his airway clearance and stop the hypertonic saline because a new ICU dock comes off, he crashes and was re-intubated. My colleagues in pulmonary are saying it's all due to his tracheobronchomalacia, which every kid has when you stick a scope in. And it's not a pancake malacia like I can't see. It's winking at me a little. And I'm telling these junior colleagues, I think you're full of BS. I think this kid has PCD or respiratory cilia dysfunction. And I've basically said to the ICU, if you ever go to less than BID hypertonic and chest PT, I am going to come up here and explode on you. Do not do it. This kid is leaving with a clinical diagnosis of PCD, and if I'm wrong, we'll know when he's 5 and has never had an ear infection and isn't coughing on a daily basis, and that's it. I think we need to put our foot down and be like, airway clearance is good in every case. Cecilia just said that. They don't have clearance post-op, and just do the damn airway clearance and treat with antibiotics more aggressively and culture the mucus every now and then to see what's growing. Treat them as presumed PCD, and outcomes will be better for everyone. This is how I approach it.
With regards to that, we've been a little bit more proactive in trying to identify these patients when they come in pre-op and getting also, so we send the genetics at the same time that we do ciliary ultrastructure testing. And those come back relatively quickly, especially if you push the pathologist, like I need this. And I think, although I think we could treat everyone with better airway clearance, I think it convinces everyone of the need of using airway clearance and the adherence from the medical standpoint once you have a diagnosis. So we have been seeing, as pulmonologists, we've been very busy seeing these kids in the cardiology units.
Yeah, I really would like to echo and support what Adam said about, with the MCC scan, you get the results the same day. So there's really no lag time. And it's non-invasive. You can load the radioactivity in a non-invasive manner. So you'll get the answer very quickly. I mean, the only drawback, of course, as I said before, you don't know in case if it's normal, whether you won't still have a problem because, as I said, it could be a reaction to the anesthesia or the cold temperature or whatever. So, but still, it's the least invasive. It's completely non-invasive. It's quick. You get the answer the same day. If you do see that there's a problem with mucociliary clearance from that test, then you know what to do. I mean, if it's a negative, you still don't know. But at least it's a quick and simple test that I think should be engaged.
I'm sorry to break. Just to stay on schedule, we're going to give everyone a break. If you guys want to stay here for a little bit, if there are more questions, and they should reconvene at 1 o'clock. Great. Well, thank you very much. So, if you're interested, planning on having a track of speakers, August 19th. I've got your info. And time to go around is on the planning.
Okay, cool. Yeah,
It's a
we're
lot.
collaborating now.
It's a lot of people. Can you bring the daughters? Absolutely. But they'll love Montreal. It's a great time. Hey.
Hi, I had
For me, for him, for
both
everyone.
of you maybe. ciliary structure question. So I know like late in ciliary development, you have some like post-translational modifications like acetylation and things like that that are probably nothing to do with this. But do we know anything about PCV patients, how they sort of build those late stage modifications, and if we could use those diagnostically?
We don't know jack. I can tell you clinically, we don't know jack squat about that. We have monogenic disorders, and when we can find them, we're thankful. And we don't know anything about modifiers, methylation, folding, nothing. And we still have 20% of our population where we can't find their genotype, even on whole genome now. So, yes, it's quite possible.
I would say it's understudied. There's definitely modifications that happen early in exosome assembly, and there's those that happen later. And lots of these modifications also happen in primary cilia. There's recently a study showing that acetylation, if you don't hit the acetylation of the tubulin, you see a reduction in the ciliary microtubules and increase in the microtubules in the cell body.
Right.
So it's clearly very important, but we don't really
Because we can stain for those so easily, so I'm wondering if that's
Tub 4B, have you heard of this one yet?
Yeah.
So
Because
Tub
like
4B
when I stain for these, I use
undergoes
the tube.
heterodimerization, and with the same variant you can get a ciliopathy that is motile, a ciliopathy that is non-motile, or heterotaxy with the exact same gene. So that's probably some type of methylation defect. So Pleasantine Mill from the UK has been looking at that and basically shows that. It's kind of blown all our minds. I mean, it's kind of science that he understands. I don't even understand it, but I'm like, so now the same gene can give me completely divergent diseases, not just phenotypic overlap, 100% divergent diseases. Yeah. And it's a tubulin marker.
Right,
It's a
right.
tubulin marker, so.
Okay, and one more question for you, and then I'll stop. It's incredibly hard to get genes at UW.
I can't
So
understand.
should
I love it when
advocate for
Harvard's
that?
like, oh, we can get one in
Just
5
grab
days.
a
I'm like,
genome.
yeah, at Harvard you can get one in
Yeah, I can get one in critically
I
ill
can
patients.
barely get an
That's
exome.
an idea.
I have an exome that's a panel disguised as or exome disguised as a panel that they call a developmental disorders panel because my government won't pay for an exome. But even then, it's more of a Mendelian panel. It's not going to discover new stuff very well.
Overwhelming at times.
The problem the insurance.
So much information.
Yeah, I can get it in dime, but
So a lot of
but
NICUs
that's
have
it.
the whole genome within 24 to 48 hours.
Get it, yeah.
But that's research funds, and it's going to dry up. Like you'll use it now, but 2 years from now, it won't be there. Yeah, we're all stuck with it.
So I can keep advocating, but I'm not getting less.
I mean, I can show you that the exome picks up of the 42 genes that are in your panel, you've got another 18 already that the exome
Yeah.
picks up. It'll pick up new ones, and genome will pick up an extra 6%. It's published out there.
So I do know a lot of parents. Thank you guys.
Sure.
Oh, good.
Yeah.
Okay,
So,
that's great.
Corbett from UT Southwestern. I'm a liver person, but I am doing some cilia imaging, primary cilia non-mortality. I was just curious if you have any experience with bowel tomography, or anyway, that's my
Yes,
so it's like a micro CT.
Do
I just
try it?
organelle? Yeah, so I'm gonna try it. Anyway, we're getting one.
Sounds cool.
Yeah.
Tell us if it works when you sell motile.
And then second question, so,
If you have
for biliary
any,
atresia, I mean,
you know,
there's a lot of
Dan will
evidence showing
tell
like
you
the
exactly.
cilia structures.
Is HDMI
like
best
they
connection for a
long or
Mac?
short or bent, and is there any evidence that the cilia structure
That makes life easier.
Yeah, absolutely. Not in PKD, but in CCD we have that. So we have 4 or 5 different genes that either give oligociliary
I can move this thing out.
decreased cilia number or a hair
It's
transplant.
just because
Any
there's so
K-tap
many
or something like that.
things that,
So absolutely we'll see
because
cilia
Mac tries to be
length
so,
things. It's all there.
you
It's
know
all
what.
there. They've been hard to find because they don't have laterality defects often. And so it's coming. So there's one FOXJ1 that causes laterality defects and can cause, not always, an oligociliary defect. And we don't really understand why that happens, except that FOXJ1
do you need me to go to mirroring?
And that's the one that
whatever you prefer.
Yeah.
Yeah, no, to go to extend.
But it's unclear. It's unclear if it's a true oligociliary defect. So that's what it was published as. But then we published 2 cases where they had abundant normal cilia, all of the basal bodies all lined up. And they have hydrocephalus. That's the other thing. They all FOXJ1s get hydrocephalus, and you very few other.
Do you want me to go
genes
on
actually have
presenting?
hydrocephalus. In humans, obesity. Mice, they all get it, but for some reason.
Okay,
Cardiac
you see it?
and then GI.
Very cool. I feel like we're on
Okay, great. I just want to check
We are on
one
the cutting
thing.
edge here.
My daughter is very
It's nice to meet you. I'm gonna definitely talk to Huey about you too.
but she has
See if we
required
can't
core
find
bowel
a way to get you
resection
Montreal
for
because
bowel
we
moving,
really
for
have
stomach surgery,
a
for spinal surgery. We've done 5 rounds of sepsis. Like,
Generating
we've done it all. Aside from that.
We actually have them. It's just, it's
From
not.
mice?
From mice.
Are you Martina?
Five.
Hi.
Adam Shapiro.
All 5 of them.
And it's a pleasure to hear you talk about that because clinically,
So interesting. So she went years without us.
Oh, it's huge. But
Okay,
it's
is it
nice to meet you. I
playing?
know, I was talking with Petra Pennekamp
Yeah.
recently.
We've been like
She's
well over.
planning the first ever global PCD conference in Montreal this August.
And
You're on a short list of people to have the conference. So,
Okay.
I hope you like French food.
I love French food.
There you go.
Food is good, more food is better. Okay.
I was just talking to Allie before about
Yeah, obviously now. She's been on my cell for 7 years now, so she's probably been on almost
so
the
she
very
went
beginning.
to
She came out for a board retreat and fell in love with it. And I was like, I'm gonna get you to do that. And she's like, I'm a Jersey girl.
You're talking, okay, because he's, did you already talk about this? Did you already talk about
Oh,
this?
you should.
Yeah.
Oh, bountiful.
Yeah, this whole Utah thing happened.
Yeah, so it was so funny because Allie just kept telling me, no, I'm not moving out there. I love it, but I'm a Jersey girl. And I'm like, okay, all right. And then like she called me one day and she's like, so perhaps I might have an opportunity to move out there for my husband's job for 2 years. What do you feel about medical care out there? Which doctor should I be talking to? Who do I need to get connected to? And then it was so funny because he was coming out to build a data center out there. But they wouldn't tell us where it was. They couldn't say anything about where it was until they made the announcement. So Allie's like sending me all these different cities and she's like, what do we think about this city? I'm like, Allie, where's the job? I don't know. I'm like, well, before we set on our minds on a city, let's figure it out. So she called me one day. She's like, it's gonna be Eagle Mountain. I'm like, that is where I live, Allie. And she's like,
Oh,
so she ended up moving 2 miles down the road.
oh my
And
gosh.
she was supposed to be there for 2 years, and she's been there for 7 now. So.
So it was funny because the 3 of the kids came in and the oldest one started like being a teen.
Oh yeah.
And asked us for funding to go to Duncan. And I was looking at the kid, I'm like, this kid doesn't sound like they're from Utah. Like, they don't seem like they're from Utah. And I'm like, looking at her, I'm like, what, Utah? She's like, oh, they're from Utah.
Yeah.
I'm like, okay, how does
They're
that work?
from Jersey, but Zoe actually spent her toddler, like, when she learned to talk, it was on the North Sea ships. So yeah, she's got a little bit, and plus,
It was more like the attitude towards
plus,
street kids, kind of.
yeah,
Maybe,
but they
maybe,
also have
maybe
the
it's tomorrow.
they also have the Canadian ties. So, as some of the words Allie will say, I'm like, oh yeah, you can tell your mom's Canadian. Yep. So, but yeah, so it's just phenomenal just to see this many people in one room that are all interested. Our first little conference in 2015, I think we had a total of maybe like 22.
So you used those for that room.
Family ones. So we've done 3 family ones.
Wow, that's fantastic.
Yeah.
So this started in 2014. We kids were born in 2011. And I didn't look. And you weren't around, which is good, because I don't feel as bad.
I was say there was another
But I didn't look.
heterotaxy group around, but there really wasn't a lot, and you probably would have.
I was just like this.
That's when so you're drowning.
And then 2014 we were in debacle. So, and it was very, but even so, I didn't even know the word heterotaxy. I just never, I wasn't looking.
Well, back then,
I
everybody
Googled a lot
was
of
just like
feeding
heterotaxy is a heart defect, right? Like they just treated it as a heart defect. And I had to push really hard because they know this is more than a heart defect. You have to consider it a separate thing that causes heart defects. But yeah, you weren't missing much in 2011. That was the area of the.
You waited to have kids.
I know.
Yeah, I know.
Yeah,
I waited as long as I could. I just couldn't wait any longer.
Yeah, that was the era where if you didn't take your kids to Boston, we had a couple of parents that were so adamant on it that they would tell you you were killing your child.
I kind of feel that way.
And I'm like, I get it, but at the same time, I'm like, you can't tell this poor parent that just has, you know, gotten slammed with this information that if you don't get your child to Boston, you're in trouble.
But how many people can afford to fly their kid to Boston before they fly to San Francisco?
Yeah, I'm like, it's not always financially
It's a
feasible.
big trip. And
not
who knows
always-
how long you're going to be out here.
Yeah, there's so many factors that go into it. But like we were in Chicago at the time, and so Hallie had, was when she had her stomach surgery. So horrifically wrong. Like they opened her up, her liver has grown, it's midline, it's grown into every space where all of her other organs should be. It's just massive. So to get to her stomach, she literally pulled her liver in half, which sent her into liver failure. Then she went into, she got VRE, so she went into kidney failure. And that's when she lost her spleens. It was like horrible. And I had just posted on her Facebook, but I'm like, she just got diagnosed with this VRE. I don't even really know. So this mom starts calling, like trying to message me, text me, all of this to tell me I have to get her from Chicago to Boston right then. I'm like, I didn't want to. Like she was not stable enough to transfer. She starts calling my mom on Facebook Messenger.
Oh, wow. She was very motivated.
Siblings. I'm like,
Did she know about VRE? Is that why she?
yeah, she thought she knew it, but then when I finally
very
messaged
motivating.
her back, we were doing everything that she was recommending we're doing. I'm like, so we have really tried to steer away from that and more just be like, you know what, we'll work with you and where your family is at, and yes, we recommend second opinions, and yes, we recommend, there's a couple of centers that we really recommend, but you can't know.
Yeah. You're just not going to die if they don't go to Boston.
Yeah, I'm like,
So do you spend a lot of effort and energy sort of steering families in the right direction, like at specific clinicians and
so we
lining
have,
them up based on their individual diagnoses?
yeah, so we have definitely ones that we recommend going to. Boston's always our top choice, right? Like, their heterotaxy program's been around for, 8, 9 years now. But we have centers opening up in Kansas City, one in Dallas, Colorado, and then I have Cincinnati coming on board, and then one in Russia.
One in Russia? Wow. You must be the only person doing dealings with Russia right now.
I'm like, I don't really want to go to Russia.
You've been really doing
No, I
anything.
pawned him off on Dave Shitlow. I'm like, Dave, here you go. He's like, oh, he's in town. I'll go talk to him. I'm like, great.
Oh, the guy came? He's here?
No, he was here a couple weeks ago, though. So Dave went and talked to him, and he was like, this is how you do it. Let's get you set it up.
Well, yeah. But that's amazing that they found you.
Yeah.
That's great.
So it's really cool to see. I mean, as you know, there was one in 2005. There was nothing. There really was nothing. And just trying to, I couldn't even get people to take me seriously because we didn't live in the cardiac world, right? Like most cardiologists would have been like, you should go and get this looked at and that looked at. And they wouldn't take me serious. And I'm like, she has spleens that don't work. And they're like, yeah, she's got multiple spleens. That's great. I'm like, no, that's only great if they work.
This is while you were in Chicago. She was born in Chicago.
So we lived in Utah when she was born and then moved to Reno, Nevada when she was 2. And then she brought her to Chicago when she was 5. She wasn't going to survive. Like I had to get her out of there. I had to get her to a better center, a bigger center that handled things like this more. And they changed things around. Our first 6 months there, we got more diagnoses than I knew what to do with. And they just kept flying, and I just kept thinking, she has the worst luck in the world. Like, she has every birth defect known to mankind. I mean, she has, like, every organ but her gallbladder is affected. That one is quite lovely. That's just kind of her, though.
Is she here? Where is she?
Yeah,
She's 19, you said.
yeah, she's at home working. She struggled a lot with PTSD. She describes waking up in the middle of a bowel resection with people's hands inside
Oh
of her.
my God.
So, a lot of trauma.
That's
so interesting, actually. We never, because our son was only 5 when he died, so it's hard to know what they think.
Yeah.
It's really interesting.
Yeah, I didn't really start to realize how bad. She started about 5 is when I first started to be like, we've got some issues going on. But it really wasn't until she was about 11 that she really started to process things on a higher level. And then she just went downhill. So we dealt with some pretty severe PTSD for a number of years. She's in a much better spot, a much, much better spot. But she told me, she's like, Mom, I worked really hard to get my mental health to a better place. And she said, I worry if I go and I interact with all those people that are still in the thick of it, it's just going to fall right back down into it. I'm like,
Did she come to any of the other ones?
yeah, she's been to every other one.
So it was really hard for her to be part of them.
Yeah, I mean, she loves it. She loves being with the kids that have heterotaxy. They all look up to her and all of that.
Is she the oldest in the crowd?
Yeah. I mean, we have an adult here with heterotaxy, but yeah, she's been. I mean, all of them know her just because that's my story.
Right.
So yeah, she called me yesterday. She's like, "How's it going?" I can tell she's just like, "Oh, I should be there, but I'm glad I didn't." And yeah, I miss her, but at the same time, she's got a larger personality.
That's an understatement. She's going to steal your thunder.
No, she just, yeah. Poor Nick, we've been married 5 years, and he came in, and I tried to warn him. I really did try to warn him about her. And
Just kidding. No, you did.
You married
I
into
just
it.
was naive.
he was just very naive until the
Like, I
first.
got this. And then I'm like, no, I don't got this. I was like, there it is.
Yeah, until the first time that I show up from work and she's was on TPN at the time and was learning to manage her own port and all of that. And I get a text, Mom, I got air in my line. And I'm like, okay, just put a syringe on it and, pull back. And she's like, she sends me a picture of there's like 6 or 7 syringes that are now like got blood in them.
Oh,
and I'm like,
oh my God.
stop, don't touch it, don't do a dang thing else. I'm on my way
It's amazing that she was doing that. I guess you have to at that age.
Yeah,
But that's, it's like, giving, it's like the kids going to Dunkin' Donuts and getting the money on the credit card and having a certain responsibility to walk on the street in a city they're not familiar with. It's like, do that to yourself on your own with nobody home. And send me photos, how you're doing. Wow.
So yeah, I showed up Nick's like, heck, she didn't even tell me she was doing this. I'm like, yeah.
She wanted to be independent.
Oh, she was definitely my independent soul. So.
Very
Like, I might not have been able
Yeah.
to fix
You guys,
it.
did you guys eat lunch?
Yeah, I'm gonna go grab
Did we get some?
Dave, are you going to use your computer, or do you want to put it on mine? Okay.
No, it's good. It's just that I had to put the two drivers together.
Yeah. Oh, yeah.
And then it was
Yeah, you're doing double duty. Feel free to break it up however you want.
a half a gigabyte.
If you open up PC shortcut here.
There you go.
Um,
I can go and put them up with the hotel if they're okay with that. So whatever you prefer.
I guess I'd rather not pull people out.
That's me. I'm like, I
Yeah.
don't want to pull people out.
Yeah.
So either I can just go do it.
I think that's fine. I mean,
As long as people-
I hate to make you go out
Yeah.
and,
So, but I think we only have 2 posters back in the boardroom.
okay,
So if anybody has any others, I would need for them.
okay. Let me send that out in the WhatsApp. I know you should have one from us.
We have yours.
Okay, all right.
And I have one from Tom.
Okay. Steve may have one too, but let me, so I should say if anyone has any posters to find you. Okay.
Yes.
And then,
I will make sure they get them.
got it. And has Ellie rung the bell already?
I gave it to Nick,
Okay, all right.
and I like literally just handed it to him.
Okay.
Told him he had 4 minutes, and then
Okay.
because apparently he does a lot louder.
Oh, okay.
So
Yeah,
I'll put
all
him
right.
in charge.
So I'm going to try and start right at 1.
Yes, that's.
Then I have microphone
Yes.
and at the top. Lizzie, do you have audio at all in yours? Okay. Good afternoon. In the interest of time, we'll get started and let people trickle in. Just a brief note. If you have a question, please come up to the microphone and speak directly into the microphone. We do have some family members who are attending online. Okay, so thanks for a terrific morning thus far. I certainly learned a lot. We will move forward with session 3, which is cardiac. And our first speaker today is Dr. Martina Bruckner, who has been on the faculty at Yale since 1991, where she is currently professor of pediatrics and genetics. She provides clinical pediatric cardiology care and founded the Yale Pediatric Cardiac Genetics Clinic. Her laboratory studies the mechanism by which cilia establish organismal left-right asymmetry, identified cilia genes that are central to mouse left-right development, and demonstrated that cilia are required to generate and sense flow at the left-right organizer. As part of the Pediatric Cardiac Genomics Consortium, the lab investigates the molecular and genetic causes of human congenital heart disease, with a special focus on the role of cilia in human heart development and disease. Please welcome Dr. Martina Bruckner.
First of all, thank you very much for having me. I think I've learned more this morning than I feel like I'm going to be able to disseminate. Oh, I went to sleep? Okay. It's time to wake up. Let's see here. So I need to go to the presentation, right? But I don't need to be online. What's it doing? Is that better? There we go. Okay, so I'm going to talk about genetics, cilia, and the link to congenital heart disease. And after all the talks this morning, some of this stuff is probably somewhat redundant, so I'm going to kind of move through it a little more quickly. But first of all, what causes heterotaxy and heterotaxy-associated congenital heart disease? The thought is that a significant percentage of it is genetic, but what is the real evidence for that? So first of all, there is increased recurrence of heterotaxy in siblings of other heterotaxy patients. And amongst the subtypes of congenital heart disease, the recurrence risk in heterotaxy is amongst the highest. There's also a notable increase in heterotaxy patients amongst consanguineous populations. So when a group of congenital heart disease patients from Turkey, where there's a higher incidence of consanguinity due to social acceptance of consanguinity, heterotaxy was one of the types of heart disease that came up at a much higher level than in, for instance, the US population. And beyond that, there's intense genetic heterogeneity, and that's already been hinted at. There are multiple different inheritance patterns: autosomal recessive, X-linked, and dominant. You can have de novo mechanisms. There is some evidence for maternal effects, and I'm not going to be talking about those specifically. Maternal early gestational diabetes has been linked to heterotaxy, and heterotaxy is one of the heart diseases that might be most contributed to by maternal diabetes. X-linked, as has already been alluded to in El Geddes' talk. Single gene recessive is probably the most common genetic mechanism. And then a combinatorial effect of defects in multiple members of a single biological pathway is likely a significant contributor that we have, as of today, not been able to assay particularly well. So the first evidence was the existence of extensive pedigrees of heterotaxy segregating in Mendelian manner. For instance, this is a large X-linked pedigree. The gene was not identified. This, I think, was published in the 1980s. But it shows multiple generations with multiple people affected by heterotaxy. And the other thing I want you to take home from all these pedigrees is that the heart disease within one pedigree is incredibly variable. And there are individuals in the pedigree who are obligate genetic carriers who are entirely normal. They have no situs abnormality, no respiratory abnormality, no cardiac abnormality. Here is a recessive pedigree. This one was the X-linked. The recessive pedigree is the older one from 1983. But just like the X-linked pedigree, it shows the significant variability in the cardiac phenotype, along with obligate carriers that are completely normal. There's also dominant pedigrees. This is the activin receptor 2B gene, and clearly here it is dominantly inherited. And again, there is variability of the final phenotype. So what this suggests is even within a single genetic defect, there is tremendous phenotypic heterogeneity, which makes it more difficult to really accurately dissect the genetic contribution to heterotaxy and the associated congenital heart diseases. And the first place where we really kind of noticed this is when we started studying mice with heterotaxy, and this is really what started my whole business in heterotaxy, congenital heart disease, et cetera, is to look at a mouse that can't tell its left side from its right side, seen on the left side of this screen. And if you look at the cardiac abnormalities of the mice, which have a variant in DNAH11, one of the dynein heavy chains, you can see that some of them have atrial septal defects, ventricular septal defects, pulmonary stenosis, transposition. And this is from, again, the 80s and 90s. And when you look at human heterotaxy patients, they pretty much mirror what we saw in the mice, the tremendous variability in the phenotype. And the way these mice with a single gene mutation are maintained, and they're still in our mouse room to date, is that about 3 out of 10 are completely normal. And those completely normal mice have no heart disease, no problems whatsoever. They breed and maintain the line. Everybody else dies. And in mice, congenital heart disease is not well tolerated for reasons that are not totally understood. The mice with heart disease are usually lost mid to late gestation and never born, or picked up by the mom shortly postnatally and dealt with. So the key thing from all of this is there are multiple different ways you can inherit laterality type defects. The phenotype amongst any given gene is incredibly variable. And now what compounds it, if you start looking at some of these pedigrees more carefully, is that isolated congenital heart disease, things that we've never thought of as part of the heterotaxy spectrum, for instance, detransposition of the great arteries, is found within these pedigrees, both in the human pedigrees and in the mice. So I think what this has made us think about for the larger genetic studies is maybe we shouldn't just be looking at the patients that are classified as dextrocardia, right atrial isomerism, left atrial isomerism, but patients across a broader spectrum and call it laterality-associated congenital heart disease, which for the purpose of the genetic studies I'm going to talk about going forward is defined as detransposition, isolated L-transposition, clear-cut heterotaxy, and even some forms of atrioventricular canal defect. When you look at the genetics across large human cohorts, it's amongst this larger population of laterality-associated congenital heart defects that you start picking up threads of specific genes causing the problem. So genes that contribute to laterality spectrum congenital heart disease are required for left-right asymmetry determination because those are the events that establish your left-right axis. And in humans happens around 17 to 19 days of gestation, so it's very, very, very early during the pregnancy. Most women at that point don't even know they're pregnant, and this event is already happening. In mice, it's day 7.75, as I've learned the hard way, occurs somewhere around midnight in the mouse room. It's very evanescent. And the structure that does all this, the left-right organizer, lives for about 12 hours and does its most important things for about 3 or 4 hours during that time span, making work on it a little more challenging. So this is a very diagrammatic version of a left-right organizer that you've already seen before, but basically it is a teardrop-shaped structure at the anterior end of the primitive streak at the end of gastrulation. And it is far separate from the heart. So if you're thinking about the left-right organizer and the heart, the left-right organizer would be here, and the developing heart would be way up here. So you make a signal at the left-right organizer that requires cilia motility, so these guys drawn in green, they're moving. By moving, they then make a mechanical contact with another cilium, which is thought to be the ones that are on the edge here, on the yellow cells. But it's also possible that some of these ones in here are able to both sense and create a signal at the same time. That signal is then converted into some molecular changes, including degradation of an RNA called DAN5. And that is really the part of this process that we are 100% sure about. You need cilia, they need to move in a normal direction, and there need to be sensing cilia that can receive that signal. Then what happens after you degrade DAN5 is a little unclear, but you do need a pathway called nodal signaling, which spreads whatever information is generated by the left-right organizer across the embryo, which is then received by the heart to allow the heart to say, hey, I'm going this way or this way. And some work by Siegel and Mayak strongly suggests that some of those early signals are in the atrium and in the outflow tract, coming back to our question about detransposition of the great arteries being a part of this spectrum. So what else do we know for sure about these early steps is that moving and the cilia and sensing that cilia signal is absolutely determinative of heart looping direction. So there's a guy who's now here in Boston who was in my lab to start out with, who did a really unique experiment where he was able to develop an optical tweezer system that grabbed a cilium in a zebrafish left-right organizer. And basically, the thing is not moving because it's paralyzed. Then he grabs it with the optical tweezers and wiggles it. You wiggle it for a certain amount of time, then you wait and see what happens to the heart. And if the cilium you wiggle is on the left side, the heart will always loop normally. Now remember, these guys have paralyzed cilia, so now what we're going to do is we're going to do the same experiment on the right side. Take a cilium on the right side, wiggle it, and you guessed it, heart's going the other way. So this part of the pathway we are 100% sure about. You move the cilium, you determine the direction of the heart loop. But how that's propagated, we don't know. Cilia move, and there are these sensory cilia that can sense the extracellular environment, transmit a signal to the cell, and which manifests as degradation of DAN5 mRNA. But beyond that, there's a lot of questions about how the signal is propagated and what leads to these early molecular asymmetries. But there's a lot of genes required to do those first steps. And not surprisingly, those are the genes that we've identified in a lot of laterality spectrum congenital heart disease. Genes required for making the left-right organizer, genes required for ciliary motility, like the dynein heavy chains, the dynein assembly factors, a lot of the genes that were described at the sessions earlier this morning. And when you look at a large number of patients, and this is 5,400 congenital heart disease patients investigated by exome sequencing, and look at genes that are required for cilia function, they are much, much enriched in heterotaxy patients, as seen here in the red circle. However, they're also enriched in the overall congenital heart disease population. And these aren't just heterotaxy patients, the ones in the red circle, that's my broad laterality spectrum abnormalities. So cilia genes, left-right organizer genes required for at least some percentage of patients with heart laterality abnormalities. Interestingly, we've recently found that a subset of those cilia genes are also required for early valve development. So this was a postdoc and a student in the lab who studied cilia within the heart. So now we've moved from the left-right organizer to the heart itself. And what you see here is a zebrafish heart beating. The little green dots are cilia. They're in the heart. They're found in the forming atrioventricular cushion in a very temporally and spatially dynamic manner. And when you get rid of them, you can't cellularize the AV cushions, which for a lot of the cardiologists here should make you think really hard, because quite a few of these patients have AV valve abnormalities. And so the question we're raising is that there's an overlap between left-right development and AV valve development that is not necessarily just due to the abnormal position of the AV valve, but due to the actual developmental structural abnormalities that are mediated by not having cilia. If you then look at all congenital heart disease, you find that recessive congenital heart disease, which is over here, is very enriched in abnormalities in cilia genes. And this is, again, not looking just at heterotaxy, but all comers, but that cluster is likely very enriched for patients with these laterality-associated defects. So I think the key thing here when we think about all this is that this is more complicated than we initially thought. It's not a linear trajectory from one to the other. And many phenotypes that you see in your cardiology care are maybe related to heterotaxy in a mechanistic manner. So what's next? Next, you have to signal that from your left-right organizer to the heart. And the pathway that's been most clearly implicated there is nodal signaling. And the cool thing about nodal signaling is that it's able to take a really small signal and auto-amplify it very, very quickly. And this whole process between having a left-right organizer and having a heart actually start to loop is also only about 2 to 3 hours. You have a primitive heart tube in the mouse at about 4 or 5 somites, and by 7 somites, that heart has started to loop, and the process has really been initiated and pushed in its irreversible direction. Each somite is about 1.5 hours of mouse development. So now let's look at nodal signaling. When we again look at this large cohort, and this is 2,300 laterality spectrum congenital heart disease patients, of which 900 were clear heterotaxies, and the others fall into my more broad definition. And we're looking at mutations in the nodal signaling pathway. There's quite a few of them. So these numbers, there's 32 nodal mutations, 29 SMAD mutations, 24 GDF1, and that's really just sort of starting to look at it. But what I also found interesting when I took this apart is the nodal signaling pathway is outlined on the left. And you would think that if you mess up nodal and its obligate partner, GDF1, you would get a similar cardiac and laterality phenotype. And the answer was really not, it wasn't as perfect as I thought it was going to be. And then if you look at nodal and its downstream signaling components, SMAD2 and 4, the phenotypes again were significantly different. And the most striking things was that nodal mutations seem to be most strongly associated with cardiac effects and not abdominal and other situs abnormalities. So a lot of the nodal patients were isolated L-loop, so the corrected transposition patients. And if you compare that, the blue is cilia defects, and you can see that they are quite different. The cilia defects were not as enriched in the detransposition, and they were remarkably enriched in the atrioventricular canal defects, which suggests to me that there might be something going on with the AV valves, which is something that from a cardiology perspective becomes very important, that we figure out which genetic defect has which cardiac effect, which may predispose the patients to certain types of outcomes. But this was kind of work that I did for the last week preparing for this conference, so this is really not ready for prime time, and we're growing the numbers of patients. This is only looking at single nucleotide variants. This is not yet looking at splice site variants, structural variants, so this is going to be a much more granular data set as it gets ground out over the next couple of months. So what are the clinical implications? And those have already been hinted at. The genetics impacts the outcomes. So again, when you look at a large cohort and you look at whether they have cilia gene defects, other gene defects, and you start associating them with particular phenotypes, the greatest odds ratio for affecting outcomes was having a combination of a heterotaxic heart, a cilia defect, and those two together increased your risk of postoperative mortality and increased your risk most significantly for prolonged ventilatory requirement postoperatively which based on this morning's presentations is not totally shocking because if they can't clear airways and you put an endotracheal tube in, you are buying yourself some problems. So these are damaging variants with increase of rest and damaging variants in cilia genes, increased risk of greater than 7 days of postoperative ventilation. So the clinical implications extend beyond the immediate surgical effects, but also that cilia are in lots of organ systems. They're in your kidney, they're in your brain. They're used to build limbs during development. So I don't like to think of all of this as a birth defect because that implies, first of all, a defective person. And it implies a fixed thing that may or may not be able to be fixed. I see these genetic variants as a disease that a patient has that can manifest as a structural heart defect, which we've actually gotten, as mentioned earlier, phenomenally better at fixing. We've become better plumbers over time. But what we're left with is patients that have lifelong morbidities. And these lifelong morbidities are turning out to have really huge impacts on their quality of life. So identifying what the genetic cause of the problem is may help us modify the pulmonary disease, renal dysfunction. There may be association with obesity. Cilia are in your brain, and they're required to regulate appetite. So I think we should start looking. Some cilia variants are associated with visual defects, hearing problems. So these are all lifelong morbidities that as primary caretakers, we need to be aware of to work with the patient and their family and take care of not just the heart, but the whole patient. So I like to think of this as cilia-associated heart disease as opposed to some sort of congenital heart defect. So the clinical implications beyond that are obviously family counseling. These variants have a significant familial recurrence rate. That depends on exactly what the variant is. The phenotypes are incredibly variable, and there's a lower rate of parent-offspring transmission in heterotaxy and laterality-associated disease than in other congenital heart disease because a lot of these are recessive as opposed to dominant. And I think I'd like to acknowledge a lot of the people that helped with all of this work, specifically all the patients and families that contributed to the genetic study that now encompasses 17,000 congenital heart disease patients, of which over 2,000 have some sort of a laterality-associated disease. And we are going to be able to follow them longitudinally if the NIH blesses it, and see how the genetic variants translate into outcome risks, hopefully some of which are modifiable. And then a whole lot of the people that worked with us on both the consortium and the mouse work. Thank you.
All right, thank you so much. I don't think my thinking about transposition and atrioventricular canal defect has changed so quickly before, so very enlightening. Thank you. So our next speaker that I'm pleased to welcome is Dr. David Hoganson. He is a pediatric cardiac surgeon and co-director of the Boston Children's Hospital Heterotaxy Program. He also directs the hospital's computational 3D visualization program. He's on the faculty of surgery at Harvard Medical School. His work combines surgery and engineering using patient-specific 3D modeling and flow simulation to improve surgical planning and outcomes for children with complex congenital heart disease. We share many patients together. Terrific surgeon, terrific colleague, David Hoganson. Just sit up here. Is there any audio embedded with you? No. No. Okay.
presenter mode here, and maybe that'll.
Oh, I need to make an adjustment here.
As you wish.
You see it? No? Okay. Okay, I see a handshake. Good?
All right. Great. Well, thank you, David Shidlow, for the introduction. It's really a privilege to be here. This conference has been fascinating for me as a surgeon. I don't spend as much time in some of the nitty-gritty details that I've heard today, and it's been really enlightening to see how interconnected all of this is, and and going through all the ciliary implications of all the congenital heart disease that we treat, both within the heterotaxy spectrum and outside the heterotaxy spectrum. It's phenomenal to see how much work has been done, and so interesting to think of how much work can be done to sort of link all of these elements together. So it's been really terrific. So I'm going to sort of do two talks back to back, essentially. One talking about our efforts in really single ventricle heart disease and how we're using 3D modeling and simulation to really make our Fontan patients as good as they can be for as long as they can be. And then I'm going to talk about our efforts in biventricular repair, particularly in heterotaxy patients. We have a phenomenal biventricular repair program at Boston Children's headed by Ram Amani, who's in Denmark this week giving a talk. So I'm going to cover those elements, but several of us work in both the complex single ventricle patients and the complex biventricular patients, and so much great work is being done in that area. Just some disclosures. We get some software help from many companies, and we'll talk a lot about off-label use. So for the last 8 years, we've built at Boston Children's a three-dimensional modeling program that is focused on building patient-specific 3D models for preoperative planning and intraoperative guidance. These models are made from CT scans or MRIs. We make them in a way that you can take the different elements of the heart apart, and our individual clinicians can do this on a web-based viewer. So you can look inside the heart, outside the heart, any combination of views, and it's totally transformed how we approach these complex patients, and it's really enabled us to take huge steps forwards, which you'll see in how we prepare, plan for, and execute these complex operations. The goal is to make things very repeatable, very predictable, and have really quality outcomes for all of these complex patients. I'll share with you how we do this. In addition to seeing these beautiful and exquisite 3D models, we use them as a platform for virtual surgery, and I'll show you several examples of that, where we plan everything we're going to do in silico, and then take those plans in the operating room, and we also use flow simulation, which has been a total game changer. If I step away from the mic and you can't hear me, please wave. So I'm going to start with sort of the complex end and work backwards. We're going to talk about the use of computer flow simulation to help inform how we manage these complex Fontan patients. And this is, computer flow simulation is a standard engineering technique that's used in airplane and automotive industry. It is used very, very widely, and it's been used for decades there. So we have really taken that exact same software, that exact same approach, and applied it to these patients with congenital heart disease. A few centers have done it over the years, and we have really scaled up to a tremendous degree. So we use this in complex Fontan patients to understand the best surgical option. And with the flow simulation, we can predict both the overall flow balance to the lungs, as well as specifically the liver flow balance, the hepatic venous return to both lungs. We can also estimate the energy loss across the Fontan pathway, all elements that are really important to being a good Fontan. And so we're going to talk about our effort to not only develop but also validate this approach. As engineers, you want to be able to say what you were going to, say what happened actually happened. And so we've taken great lengths to show that this is really accurate in predicting what's going to happen in our patients. So essentially what we do is we take the 3D model. On the computer, we plan the different surgical options.
We use the cath and MRI data to really create a mathematical model of the patient, their flows, their pulmonary vascular resistance, all of the elements. And then we do a simulation on the computer where we're saying this is exactly what we expect is going to be post-op. Not a maybe, but based upon their physiology, we're trying to make very clear predictions. And then we do post-op MRI to understand how accurate we were. We use these models every day in the operating room for intraoperative guidance. We have the models up on a screen next to the surgeon. For those of you with children, you will recognize that's a Nintendo Switch controller, which we've reprogrammed to use as a mouse. And we use it to really guide the surgery and allow us as surgeons to do the operation exactly as we had planned. And so we've been doing this computational fluid dynamics now for 7 or 8 years. And we recently presented earlier this year the MRI validation of these CFD predicted flows. And the most direct measurement we can do from MRI is the overall flow balance, so the predicted flow to the right lung and the left lung. And in our cohort, the flow simulation, the computational fluid dynamics predicted 49 plus or minus 8%. The MRI measured 47.5%. And the percentage based on each patient was 7% plus or minus 4.5%. So with 93% accuracy, we're able to predict the flow balance in these patients after surgery. So this has really been wonderful validation of this approach. We can also predict the hepatic flow variation. This cannot be directly measured by MRI post-op, but we've done simulations on the post-op MRI and show about a 16% variation from what we predicted. In the world of simulation, anything better than 20% is considered excellent, and so we're really thrilled with these results. One of the things we've learned as we've tackled many of these complex patients, particularly many with heterotaxy, is that patients with systemic venous abnormalities undergoing a Fontan operation represent the highest risk cohort of having imbalance of both total flow and, importantly, hepatic venous return. This includes patients with bilateral SVCs, patients with interrupted IVC and azygous continuation. Some heterotaxy patients have an SVC on one side and IVC on the other side, and all of these are very high risk for Fontan completion. And what we've shown is that essentially if you have any systemic venous abnormality, you have, in our series, a 71% chance of having really disparate hepatic venous return, less than 15% to one lung, in many patients 0% to one lung, and everything else to the other lung. And of course that sets you up for pulmonary arterial venous malformations that result in progressive hypoxia and early death if untreated. So with CFD, we've been able to reverse this and in all patients achieve an acceptable balance, on average 36% to one lung. So this has been really phenomenal. I'll show you some examples of this. So this is a patient who has complex anatomy, interrupted IVC, azygous continuation, is a heterotaxy patient and needs to have a Fontan completion. And shown in the top panel of 4 images is the standard Fontan that we would have done had we not had this technology. And you can see here in the normal physiology, normal resting physiology, this child would have had 90% of their hepatic venous return to one lung and been at a high risk for developing AVMs in the left lung. But with flow simulation and various surgical plans, both simulated and evaluated, we were able to come up with a surgical strategy where we had 56% to the right lung and 44% to the left lung, and that child underwent that operation. And the post-op MRI showed that we were almost exactly on point. Here's another example of a patient who has a Fontan, and you can see in this upper panel their hepatic venous return is 100% to the right lung. They have clinical AVMs in the left lung and low saturations, and we're able to devise a plan, another heterotaxy patient with interrupted IVC, to reroute the blood from the liver back to the azygous vein, achieve really nice distribution of hepatic venous return, and did that in that patient, and they did very well, and their saturations have come up. And so, so this is a really challenging cohort of patients where just based upon clinical experience and intuition is not accurate enough, and really we found you really need to use this flow simulation. So one of the other things we've focused on recently is how do we use this to better understand how to manage Fontan patients as they get older. And what we recently showed is that when you get your Fontan and you're 2.5 or 3 or 4 years of age, your superior vena cava flow is twice your inferior vena cava flow. At the time you're 8, those flows are relatively equal, and when you're 15, your inferior vena cava flow is twice your SVC flow. And so you're going through a transition where when you put the Fontan in, it's relatively 4 times higher flow when you're a teenager. And in many patients, the current size of conduit we use or the changes in that conduit or if you're a lateral tunnel, that doesn't always keep up. And what we're seeing is increased energy loss in these patients as they get older, particularly in that 8 to 15 year and older time frame. And so we're trying to understand how do we use flow simulation, how do we use mathematical modeling in addition to our clinical tools to understand who's going to benefit from a Fontan upsizing. So we're seeing many patients who present with early liver disease and other evidence of Fontan failure, and lots of evidence that their Fontan conduit is not big enough. And so we're using flow simulation to really model what size of conduit brings that energy loss down in the Fontan pathway. And there's a sweet spot. If you make the conduit too big, you get more energy loss from sort of disrupted flow, but there's definitely a sweet spot. So we can use the same tool to show that. And we've seen this in a number of patients where we're seeing a sometimes dramatic energy loss reduction from upsizing the conduit. And often it's to 22 or 24 millimeters, which is way, way bigger, as you know, the cardiologists in the room know you would ever put in a child when they get their Fontan completion. And so I think there's a lot of learning that we have to do as a community about where that sweet spot is and how that needs to change over time. But I think we're going to be upsizing more Fontan conduits than we have in the past. And so in summary, we're using a clinical workflow with computational fluid dynamics in both primary Fontans and Fontan revisions. And we've shown excellent correlation between the predicted and post-op MRI measurements of the total flow to the lungs. And these flow simulations help predict how and when to do Fontan revisions to minimize late complications. And this computational fluid dynamics is really becoming an important tool, I would say an essential tool in these patients with really complex anatomy to plan their Fontan or their Fontan completion. And so we've done this by really growing a team of engineers at Boston Children's Hospital. So this effort started quite some time ago in 2016, and we got our first funding in 2017. And over time, we've added team member after team member, engineer after engineer to tackle all of these things. We have a huge clinical service that makes these prospective 3D models for our patients. We're going to do 600 this year, and many of those patients have flow simulation or some degree of patch planning. So it's really enabled us to tackle these super complex cases and get really consistent results. And here's just a graph of how the 3D modeling program has grown over time. So it's really been a joy to apply these to these complex heterotaxy patients and really try to achieve a very predictable outcome. So going to shift from single ventricle to 2 ventricle repair, and this has really been a huge focus for our center for a very long time. And Pedro Del Nido and Ramamani started this effort 15 or more years ago, and for heterotaxy and non-heterotaxy patients. But really the rationale for doing this is that Fontans are fraught with challenges, right? So there's a number of complications that come from being a Fontan, and if it can be avoided, it's terrific to do so. So atrial arrhythmias are a common complication. Thromboembolism can happen from the conduit and the risk of a thrombus either in the lungs or going to the body. Protein losing enteropathy is another complication that we see in these patients with elevated pulmonary vascular resistance and other entities. You can have plastic bronchitis, which is super challenging and cilia-related complication. And then there's a decline in exercise capacity and an ongoing late mortality. And the overall survival of these patients still remains a challenge. And what we know is that some patients are less ideal Fontan candidates than others, and for those patients, we are really for all patients, but particularly for those patients, if you're a poor Fontan candidate and there's any way to achieve something other than a Fontan circulation, our motivation has been to do so. And risk factors that we see is, certainly single lung physiology and pulmonary hypertension are really challenging in a single ventricle circulation. Airway disease can be the same. Certainly some of these single ventricle patients or borderline patients have ventricular dysfunction, valvular dysfunction. Pulmonary vein stenosis is a huge challenge. Arrhythmias, heart block, and of course syndromes. Heterotaxy patients have historically been a much higher risk cohort for the Fontan operation and the Fontan circulation. And so a lot of motivation to do biventricular repairs to avoid some of these complications. Obviously not everybody can get a BIV repair, but those who can, we do. So really the way we think about it is some patients have an adequate systemic ventricle, a left ventricle for the systemic work, and things like the left ventricular size, the aortic valve size, the mitral valve size within the normal range, Z-score of -2 or better, normal systolic function and normal diastolic function. And of course on the other end of the spectrum are patients who the left ventricle is just too small, the aortic mitral valve are too small, there's ventricular dysfunction or other lesions. But really the focus of our efforts are those patients in the middle, right? There's a huge number of patients in the middle where we can take steps to encourage growth of all of those necessary features, the left ventricle, the mitral valve, the aortic valve, and achieve a biventricular repair. And that's really what we focused on. So we think about this as sort of a borderline left heart or borderline systemic ventricle, and the options historically being single ventricle palliation or primary biventricular repair. But I think really the way we think about this is many of these patients are not candidates for a biventricular repair right away as one step, but they can be recruited to be ready for a biventricular repair through a series of steps. And I think that's where we really tried to approach this in a very systematic way to be able to apply this for those patients, particularly that I outlined are high risk for the single ventricle circulation. So it's really a heterogeneous mix of who are these patients in this sort of borderline biventricular repair category. Certainly patients with hypoplastic left heart syndrome and variations of that, small left-sided structures in general, known as the Schoen's complex, but a common group in the heterotaxy population are unbalanced AV canal defects in those patients. And so we really have applied strategies to each of these patients, sometimes differently, to achieve a biventricular repair. And so this is an example of an echo of a patient. I don't really have a pointer here. I'm gonna see if I can do this without disrupting the slides. Oh, it's not showing up. Nevertheless, on your left in the lower portion of the echo, there's a small left ventricle that after staged recruitment and really forcing more blood flow through the mitral valve and into the left ventricle, we've seen growth of this left ventricle and now a candidate for a biventricular repair. And this is the paradigm which we work under for these patients. You can take steps to really recruit or grow a small left ventricle and really achieve a BIV repair. And the question that we wrestle with every day, and Dr. Shidlow and I wrestle with all the time, and including this last week, is are you ready for that BIV repair, or do you need further recruitment to do so? So one of the predictors that we have found is the left ventricular end diastolic volume. How big is that left ventricle in diastole? And that's been a strong predictor for patients who will tolerate that left ventricle being a systemic ventricle. If you're less than 30, that is a more challenging group than if it's higher than 30, and in other patients less than 45 is way more challenging than being over 45. And so that is one of the very important predictors that we use right now to understand, are you ready for a biventricular repair, or do you need some additional recruitment to get your left-sided volume to that level? Left ventricular end diastolic pressure, which we get by catheterization, is a very important predictor that we have shown. The cutoff that we found was about 13 millimeters mercury. It's a complex number that really speaks to both how thick the heart is. Sometimes there's a scar tissue lining of the heart called EFE, and all these add up to really being an important predictor of not only do you have volume, but does the heart relax enough to be able to handle the cardiac output on the left side. So left ventricular end diastolic pressure is one of the really important things that we look at for patients for bivalve repair. And another important factor is this scar tissue you can get inside the ventricle, this EFE, which really typically forms when your aortic valve is small and the pressure inside the left ventricle is elevated, either in the womb or in the womb and after. And we now have approaches that we can actually surgically remove that scar tissue, sometimes more than once in patients, and that can really improve how well the heart relaxes. But those patients we've shown are a clear higher risk for biventricular conversion. So we have to take that into account and be careful about when we push those patients to biventricular repair, because they've been shown to be an important patient group that has definitely higher risk. So the unbalanced AV canal defects are really common, and it's a place where we've really been able to achieve a lot of growth of that smaller left side when that's the case. And so this is an echo example of a patient. The very skinny to the right structure in there is the left ventricle. You can see that's a long, skinny structure that is in no way ready to be a systemic ventricle. But what we've been able to do is take surgical strategies to both encourage blood flow through that left-sided AV valve and into the left ventricle, and also do some work sometimes on the valve to encourage the left ventricle to grow. We think about these patients: what is your volume of your left ventricle, and what is the architecture, particularly of your papillary muscles? If you have two well-spaced papillary muscles, that's encouraging. If you have a single papillary muscle, what we call a parachute valve, that's a higher risk group and often will need further recruitment. And so for many of these patients, we do take a step of closing the atrium, the atrial septal defect with a patch, and encourage that flow to the left ventricle. And our program, led by Ron Monty, recently created a video. Hopefully this is playing for you. Yep. So just sort of a highlight some of the steps. So, and this is an unbalanced AV canal patient who initially gets a stage 1 procedure or a Norwood procedure to get through the neonatal period. Then as an infant, typically in the 4 to 6 month range, we can close that atrial septum and leave the VSD open, and that will encourage blood flow into the left ventricle, encourage growth of the mitral valve, encourage growth of the left ventricle, and then over time, then can go back and do the full biventricular repair, which includes closure of the VSD with a patch, and then reconnecting the great vessels in normal fashion. The rest of the video is on the next page. So, so here's I got arrows on this one. So here's just an arrow showing the small left ventricle up there, and then after recruitment, you can see the same arrow on the left ventricle shows a much bigger left ventricle, and this is what we have seen over and over in these unbalanced canals. And here's the rest of the video. So this is the biventricular repair, where we reconnect the great vessels to their respective ventricles and then add a patch to close the VSD. So completely septate the heart into normal left and right sides, and then we have normal, essentially normal physiology of the heart. So this is really a huge focus for our group. And what we've seen is that we've been able to achieve growth in the left ventricle end diastolic volume, the left ventricle end systolic volume, and the LV stroke volume with these recruitment procedures. So patients who otherwise previously would have all gone down a single ventricle pathway, we now can recruit the left side, grow the left ventricle, grow the mitral valve, and achieve an adequate physiology for a biventricular circulation. What we've looked at recently is how how well do these stage biventricular pair patients do compared to those who have adequate size, maybe surgical complexity, but adequate size out of the gate for a primary biventricular repair. They don't need that extra step to grow the left side, and what we've shown is the overall survival is the same. And so we've been able to really achieve the same final outcome in these patients. Yes, they have more operations, for sure they do. They need operations in the middle, sometimes 2 recruitment operations. And so it's an enormous commitment of the family to say we're going to go down this path and take these extra steps, which always incur, essentially more upfront risk, sometimes more upfront surgery, but to achieve a biventricular circulation rather than a Fontan circulation. And this is one of the challenges that we face both as clinicians and the families face commonly when we look at these kind of scenarios. We looked at our patients in comparing patients who've had a biventricular repair versus single ventricle palliation, and obviously these are very heterogeneous patients. It's tough to line them up in exact groups, but overall, as we all would have expected, the biventricular repair patients do better in the long term than the single ventricle palliation patients. So I think our motivation continues to be to recruit these patients for biventricular repair when it's feasible. And just some more data. This has actually been submitted for publication. This is really a matched, as well matched of a group as we can, which shows lower risk of liver dysfunction and better overall outcomes for biventricular repair patients. So we'll continue to push that. I'm going to share with you now just a couple ways that we're using 3D modeling and virtual surgery to really plan and conduct how we do these complex biventricular repairs. I apologize, I had to step out this morning of the session because Dr. Shidlow and I have a patient we're doing this coming week, and we're actually in the middle of planning 2 elements, both of which I'll show you, not this patient, but this has really become an important thrust of our program and the 3D modeling and engineering team that I run. So this is a patient with heterotaxy who needs both an atrial level switch and also needs to baffle the left ventricle over to the aorta to achieve a biventricular repair. They have a double outlet right ventricle and they need an atrial level switch. And so if we look inside the heart, the teal is the right atrium, soon to be the left atrium. Inside the orange is the left ventricle. And as this video runs, I'll let it play through again. You're sort of looking up from the end of the heart in the left ventricle, and you can see the pathway to get the left ventricle flow over to the aorta in the red. You can see that pathway that exists there, but you need a patch that will redirect that blood flow from the left ventricle over to the aorta. That patch has to run right above the tricuspid valve, right below the pulmonary valve, and where the flow goes up to the pulmonary valve. And it has to not injure the conduction system, which Lizzie DeWitt will talk about soon, how we do that, and also can't injure the aortic valve. It just has to be perfect. And so what we're able to do now is to plan these patches beforehand. And one of the challenges in these patients is you don't always have the best visualization. You can't just open the whole thing up like it looks here and see everything perfectly. And so sometimes making those intraoperative judgments about, I should trim the patch a little bit, I should make it a little bit bigger, those can be really hard in some of these patients. And so you can see here in this green patch, we're able to plan where that patch goes and position it so it's going to be just the right size and attached in just the right spot and do all that before we go into the operating room. You can see how that is positioned to just avoid all the critical things. And then we faced as engineers, okay, we can plan this beautiful patch. It looks like a Pringle. How do we get that into the surgeon's hands, right? And so, it's one thing to visualize it and say, oh, this is where the patch should go. It's another thing to have that to the millimeter. And so one of the challenges is all of our patch materials are flat and all of the patches are curved. And so in order to get that correctly done, there's a complex mathematical algorithm to achieve the flat patch equivalent, if you will. So when you trace it out on that flat patch and sew it in and it pressurizes, it'll achieve that curvature that you need. Otherwise, if you do it wrong, it'll buckle, it'll kink. And everybody who takes care of congenital heart patients have dealt with those issues in the past, and it's just physics, right? But if you take into account the material properties of the patch and of the heart, you can achieve that. And so Our engineering team has developed all these algorithms to do that. We use some aerospace software to get it done. And now we have another aerospace trick. We have a laser system that's used in aircraft manufacturing that's now in our operating room. And so we can take the patch design and we upload the design to the laser. The laser projects the design onto the sterile patch material. It's like the world's most expensive laser pointer. And you trace it out and cut it out. And we show that we have less than 2% error between the patch design on the computer and the cutout patch in the patch material. And so it doesn't matter what patch material you want to use, the laser will project onto anything. You trace it out and you cut it out and sew it in. So it's really, as you can imagine, totally transformed how we've done these complex repairs. And so there's no more, I want to make this up in the OR, I hope it goes okay, I think I can get it there, I think it's going to be fine. We try to eliminate all that we know we're going to have a plan, we know it's going to work, and we know it's going to be the right shape and size. And so this is another common challenge that we face in heterotaxy patients is their systemic venous connections, their pulmonary venous connections, and their atria are all mixed up. And you heard it all morning how there's so much heterogeneity in these patients in their atrial anatomy. And yet when we're trying to achieve the biventricular repair, we got to get the atrial flow to the right ventricle. And sometimes it's really quite challenging. And so what we've learned is we can also plan these things out. Just like we plan the VSD patches out, and that's what I was doing this morning, is planning a complex mustard in a heterotaxy patient. And so this is really an effort to be able to baffle any venous structure from one side to the other. And sometimes we have to do a formal atrial switch, like a standard SLL, L transposition. But in these heterotaxy patients, it's usually, it's a whole mix of things, and sometimes you're baffling just the SBC or just the IVC or both are various things, and the atrial structure is very, very different. So what we've learned is just a very patient-specific patch planning workflow is the only way to do this. And so this patient has a left superior vena cava, and I don't have a pointer, but shown here on the right side of your screen is the superior vena cava going on top of the pink left atrium, and we essentially have to baffle that over to the right atria. And now what we're able to do is to plan, both plan that pathway, as you can see, and plan that exact size of that baffle, and then plan the patch structure on the inside. We take that plan in the operating room, put up to laser, project it down on the curved patch material, trace it out, cut it out, sew it in. We've done this down to 4.5 kilo patients, which in the past we never, ever, ever would have tackled. We always waited till they were 7, 8, 9 kilos. And now with this, we have confidence that we can do it in smaller patients. And really, it's been a game changer. So, and one last really super impactful area that we've tackled, these complex AV valves. You heard how common valve disease is in our heterotaxy patients. In many of our patients, they have complex AV canals and present either as single ventricle patients or biventricular repair patients, and repairing the valves is an essential component of achieving a biventricular repair or achieving an adequate Fontan circulation. And so we have a program now, we can make exquisite 3D models of these AV valves, spearheaded by a cardiologist, Rena Ghosh, who's on our team. And we've used this both to understand the structure of the valve and then also to plan the exact interventions. And you can see we're able to model both the leaflets as well as the chordal structures, as well as the papillary muscles, and we're able to put dimensions on all of that. So I'm sure you can appreciate it, as an engineer, I want to go in the OR with a plan, right? A plan to the millimeter, and we're able to now do that with these 3D models. So it's really been super impactful for some of our most complex patients, and something we're looking to expand a lot in the future. So just a little taste of what we're doing from the surgical standpoint for heterotaxy patients, but it's been a joy to partner with Dave Shidlow and the expansion of the program, and really try to, add some more consistency to how we approach these patients surgically, and look forward to taking any questions later in the session.
That was terrific, thank you. I'm not sure that I could hit that 2% margin of error with that laser patch, but that's why you're a surgeon and I am not. So our next speaker that I'm delighted to welcome is Dr. Elizabeth DeWitt. She is an electrophysiologist at Boston Children's Hospital and an assistant professor of pediatrics at Harvard Medical School. She is the medical director of the Surgical Electrophysiology Service and an associate program director of the Cardiology Fellowship. She is also a core member of the heterotaxy team, lending her much-needed electrophysiology expertise to our complex group of patients. Dr. DeWitt.
Right, well, thank you so much to the organizers for having me. It's such a delight to be here with you all, and I am sorry that I missed this morning. I am on service for the EP service, so I had to round and all that sort of thing. I don't think we have any patients with heterotaxy right now in our service, but so I'll be talking about two topics today. I'm going to start with some of the electrophysiology that we see in patients with heterotaxy, and then move on to the intraoperative mapping that Dr. Hoganson alluded to, part of the work that we've been doing. So kind of two separate things that tie together, and I don't know how many electrophysiologists are in the room, but I tried to keep this relatively minimal on the intracardiac tracings because it is, you know, sort of coffee o'clock, but we'll try to keep it as entertaining as possible. So just to anchor us a little bit in some clinical care, I wanted to start with a couple different examples of patients with heterotaxy that have sort of different sides of the EP coin, you might say. One is this patient who is a 7-year-old. He came to our hospital for a consideration for a biventricular repair, actually. He had been palliated down to a Fontan, which had not gone well from a circulation standpoint and had to be taken down. And he came to us with a history of SVT that had been difficult to manage and had at times postoperatively contributed to his poor status. We knew that he had heterotaxy with an asplenia subtype, and we had suspicions that this might have been an AVNRT type or a twin node tachycardia type presentation. We brought him to the lab, where in fact we did confirm that there were 2 nodes that we could map out. One is in that yellow cluster down below. That was where we thought the dominant conduction was going through. But then the cluster in the center of the sort of rainbow is where we mapped out the retrograde conduction of this tachycardia. And what was interesting and is so typically humbling of taking care of patients with heterotaxy, especially when you bring them to the EP lab, is that we found one circuit that we called AVNRT number 1, and whenever you have a number in front of the or behind the tachycardia, it tends to suggest that there's excitement to come, and indeed we had one, then we had another one, then we had another one, and then we had a 4th one. So he certainly did have a history of SVT, and all of it was really very easy to induce, and we'll go into a little bit why you could have so many different things that are all kind of related later on. And because of the burden of the SVT that he had, and sort of how impactful that had been postoperatively, we ended up ablating the sort of weaker of the 2 AV nodes for fear that this would be another issue postoperatively. And unfortunately, in the operating room, the other node was damaged, and so he ended up with a pacemaker. So we'll talk about how that informs kind of how we approach these patients as we go forward here today. On the other side of the spectrum, this is now a 14-year-old young man who has heterotaxy with a polysplenia or left atrial isomerism variant, who had a partial AV canal defect that was repaired in infancy, and then also has even more sort of clinically relevant for him right after birth was that he had both congenital AV block and sinus node dysfunction, to the point that he needed a pacemaker implanted in the neonatal period, and then subsequently had his repair done at that time as well. And he came into us earlier this year having had one of his epicardial leads break, and then was transitioned over to a transvenous system. One of the things that was interesting about him is in EP in general right now, when we try to put transvenous systems in, we're always trying for a conduction system type pacing setup, where we're trying to get into the conduction system to facilitate what we think will be the most efficient way of pacing these hearts.
and I spent a long time trying to get into the correct location for the conduction system and wasn't able to, which is why the ECG still looks a little bit wide. But I think this raises more questions about kind of how we can best serve these patients who are on kind of that other side and more prone to the bradycardia than the tachycardia. So let's look at the arrhythmias that we sort of anticipate or know can exist in this group of patients overall. So this is a report from Texas Children's that was published in 2018 with their single center data of patients with heterotaxy. And you can see that a substantial portion of patients do have either bradycardia that's clinically relevant or tachycardia, and some also have both. And it's relevant to note that they also found in this study that the presence of having had a history of tachyarrhythmia increased your risk of needing a transplant, which may be an indicator of other things, but certainly suggests the sort of importance of this clinical significance of that. I'm going to start now by sort of going through the various anatomical abnormalities or differences that we can see in patients with heterotaxy and their various subtypes, sort of marching through the conduction system. The sinus node, I think, arguably is probably the clinically tends to be a little bit less relevant than the AV nodal conduction abnormalities. The main thing that we'll see is while we normally, in a normal heart, we expect to see the sinus node in the upper part of the right atrium near the SVC. In mirror image, we often will just have that flipped, as you might expect. In right atrial isomerism, we often will be able to see, if not clinically, but pathologically, when you look in the pathology lab, you can often identify two sinus nodes that, if they're a bilateral vena cava, sit near the entrance into the atria of each of those. And then in left atrial isomerism or polysplenia, we often don't see a sinus node. Again, if you look when anatomists or cardiac pathologists look at those hearts, they often can identify sort of hypoplastic structures that are inferiorly displaced to where we expect, but are often not producing much of a P wave. From the AV node, the two sort of main subtypes that we think about, asplenia subtype and polysplenia subtype, have differing susceptibilities to different types of AV nodal abnormalities. We associate right atrial isomerism with twin AV nodes, as I was alluding to earlier. And what we mean by that is that there are actually two structures that you can find, sometimes with pacing, sometimes with pathology, and sometimes by studying in the EP lab or in the operating room, where you can see that you can engage a His bundle or notice that there's some conduction that may go through these structures, and that His bundle signal is sort of a marker of an AV node. These can mediate twin node tachycardia, as we saw in that first example, and sometimes they're connected by a conduction sling that can contribute to the abnormalities that we see. And this image is from Dr. Jeremy Moore at UCLA, who compiled a multi-center study of patients who had gone to the lab for twin node tachycardia ablation, and it sort of displays where the different electrophysiologists had seen the nodes located. So you can see that even for it's kind of a dark figure, but even for the anterior or superior nodes, which are the ones that are kind of have the numbers in blue, and the inferior ones are the ones with the numbers in yellow, there's a marked sort of distribution. It's not all like where we found it and where it was thought to be in the EP lab isn't all septal, where we might ordinarily think things to be located. And some of that may have to do with just unbalanced canal and that sort of thing and how it got depicted in the diagram. Clinically, the way that shows up is a couple of different things that you might see in your patients. One is that there may be shifts in the axis just from beat to beat. You may see variability. Where here you see that your overall QRS axis shifts pretty dramatically as the tracing goes on. And this is an example from one of my colleagues, Dr. Ed Walsh, who kindly has this beautiful slide where we see, and this is all the same patient, the same leads, that the panel all the way to the left represents conduction mostly down one node. And you can see that there's a QS pattern, for example, in lead 1. And if you switch over and look at the panel all the way to the right, you'll see that it's an R wave followed by an S wave, so a totally different pattern of activation. And this is not, sometimes you're reading EKGs and you're like, oh, they put the leads on wrong, and you call down and you say, well, you do it again, but this is for real, and you can see that that shift, and that's a perfect key that for you that this happens. And this patient then went on to have the SVT that was using the first node as its primary driver, as its antegrade driver, and then coming back up the other node. So lots of interesting things that we can see in these patients. And forgive the a little bit not very fancy drawings, but we often the terminology is just sort of very specific here, and sometimes it can be hard to kind of visualize what's happening in twin node tachycardia, and people hear us talk about dual AV node physiology and twin node, and how are those different. And this upper drawing where it says AVNRT represents just your sort of typical teenager who might have SVT mediated by two pathways within the AV node. So one AV node as normal, but one pathway that's abnormal called the slow pathway, and then one that's the fast pathway, the one that you want. And the reentry happens where you go down the AV node, the slow pathway. You can do it both ways, but most of the time it's down the slow pathway, back up the fast. And when it's the same sort of idea in twin nodal tachycardia, where you go down you use one of the nodes in an antegrade direction, and the other node mediates the conduction in the retrograde. And then where it gets exciting is like that first patient, where you can have fast pathways and slow pathways within each of those nodes. And then you can start doing the math as to the permutations of how many different combinations of tachycardia you can get. So there's been data that has shown, as you might expect, that patients with right atrial isomerism are more likely to have twin nodal tachycardia compared to those with left atrial isomerism, just because of the presence of those two nodes. And on the flip side, those with, as we mentioned, with left atrial isomerism are more likely to have congenital AV block. Again, this is from the single center study out of Texas that we mentioned before. So this is a beautiful diagram from Cardiology in the Young in 2006 that has 35 specimens of hearts with heterotaxy, and the authors attempted to group them to kind of get a better sense of, beyond just the level of asplenia or polysplenia, what are the different ways in which these hearts can be connected electrically. And the sort of diagram of the atria and the venous connections are at the top in the pink color, and then you see the green is the various AV nodal patterns that we have below. And you see the circles are the compact nodes that they have, and then there's different branches. So the one is the right bundle, and then the sort of fan that you see. And I've stared at this so many times, trying to get my brain to sort of wrap around all the different patterns and how to group them when I think about patients who I might be sending to the operating room or thinking about going to the operating room. And as much as I try to sort of see all that nuance, I think it's really difficult for us as clinicians with a patient in front of us where we're using the echo and the MRI and the cath ahead of time to even just understand their plumbing, to kind of also overlay the complexity of the conduction system onto it. And just in the interest of time, I'm going to skip through that. But I think that's what informs kind of the next phase of my talk, which is going to be talking about how we've tried to kind of acknowledge all the variation that we see, and then implement the most effective technique in the operating room to try to avoid creating any AV block. Before I move on to that, I'll just quickly say that in our heterotaxy program, we have established for those asymptomatic patients who may not come to you with the symptoms of palpitations or bradycardia associated symptoms, just some sort of baseline suggested testing, including EKG, obviously, and then some longer term monitoring periodically. And I think that has been pretty helpful for us, keeping an eye on kind of what the heart rates are looking like when we might think that we need to intervene from a pacing standpoint, and also to pick up some subclinical changes that might indicate the need for intervention. All right, so luckily Dr. Hoganson has laid a lot of the groundwork for the sort of our center's philosophy on biventricular repair, which we're often pursuing in these patients. This is not from our center, but from another center in a report from 2015, which gathered together 20 heterotaxy patients at this center who underwent biventricular repair. And in this publication, 25% of those patients required a pacemaker afterwards for postoperative complete heart block, which is a pretty shocking number. At our own center, and around the same time period, this publication gathered almost 100 patients, and in that series, 14% of them required a pacemaker. So when we're doing these biventricular repairs. And what this sort of had led us to ask is, if we have all this data and these beautiful pathology studies showing us where this is and ways to predict, why are we still getting heart block? And I think this also goes to, this video goes to what Dr. Hoganson was saying earlier about how it can be hard to visualize where things are. And I give the surgeons all the credit because I don't know how they do it really. But, if you're asking them to kind of, you see that level of detail and intricacy in the diagram and you've got an error, an error bar of a couple millimeters, then you might be in the wrong spot. You really have not a lot of margin to not get know where the conduction is if you are going to perform these repairs. And I think the other piece is just the knowing how variable these hearts can be, taking a patient-specific approach and not relying on rules or a certain sort of standard or anticipated finding, but really trying to come up with a patient-specific and centered approach to this. And so we started trying to come up with solutions for this about 5 years ago. And it's a group of us from both EP and surgery and from the engineering group, supported by Dr. Hoganson and others of his colleagues. And we've worked to establish a pretty rigorous and consistent approach to patients both with heterotaxy and without who are coming for biventricular repair, where we look for the electrical signals in the lab. We use a commercially available catheter. That's not perfect, but does the job a lot of the time and sort of lets us play a game of battleship with the surgeons where we tell them where we see it and what the coordinates are. And then they sort of adjust accordingly to where they're interested in. And you can see that we get a lot of data in a hurry with that catheter, which is a 4x4 grid of electrodes. We see the atrial electrograms, the His bundle electrograms, and ventricular electrograms. I won't give you a test on this. And we're looking for the His. We're looking for that high frequency signal in between the two, the atrium and the ventricle. And so the surgeons mark this catheter because, again, it's used in electroanatomic mapping, that sort of, the way that we map in the lab, and we're using it in an open beating heart. They mark that so that we can reference which side it's on, and then we start looking at the signals and feeding back to them where we're seeing evidence of the conduction. Sometimes it's a little noisy. We wait for it to get clean, and then we can pretty rapidly take in that data and be able to help them look at places in the heart, both where conduction is, but also where conduction is not, because that can also be very helpful if you know that you need to put that VSC patch in, and you have conduction at the superior aspect. Perhaps you sort of adjust where that patch goes, and that can allow us to avoid that complication. This is a little bit out of date now, but this has really taken off and is something that pretty much I think it's fair to say that pretty much every patient with heterotaxy who now comes to our center and is having work done near the AV valves or in that region will get mapped. We published the first 150 patients that we mapped in JACC last year. And we were really thrilled to find, this is what we had been seeing clinically, but we were thrilled to find that when we compared them to a matched historical cohort of 200 patients who were unmapped, that we had reduced our center's incidence of heart block with these complex biventricular repairs in patients with heterotaxy specifically from 16% to 2% with mapping. And we've subsequently mapped another 350 or so. We're about at 500 patients that we've mapped. 95 of those patients have had heterotaxy syndrome, and only 3%, which is actually 3 patients, have had the complication of post-op heart block since we've instituted mapping. So it's been incredibly gratifying. It's always sort of a bummer because I don't get to meet the patients because they don't need a pacemaker, and so I don't need to talk to the family. But very happy to have it that way, and to intervene on the front side of things rather than being in the operating room, putting the pacemaker in with the surgeons afterwards. We look at this data in a lot of different ways, and we're hoping that, I won't go into all this just in the interest of time, but we're hoping that by continuing to gather data, by continuing to map it onto where these beautiful 3D models that Dr. Hoganson's team create, that we're going to continue to advance our understanding of the conduction system in heterotaxy. That beautiful work that we saw was 35 patients. We've already got 95. Each of them has a model that we've labeled over the time that we've been doing this, and we have a digital atlas that lets us enter data that aligns with our patients and then pull up examples of patients that we've mapped who've had similar anatomy and similar findings, so that maybe that will help the surgeons in their planning anticipate, maybe not take the place of doing the mapping itself, but at least anticipate in their thought process or in counseling families where we might find this, so that we have that going into our minds, or in our minds going in. So EP can definitely be a complex aspect of these already complex patients. I would highlight that the anatomy really is variable, and I think a patient-specific approach, whether you're doing that in the EP lab or in the operating room, is really the only way to go. And thank you to Dr. Shidlow for including me in the team. It's really been wonderful to participate, and thanks to all of you.
Thank you so much, Dr. DeWitt. For our final talk of this session, I'd like to welcome Dr. Ryan Butts. Dr. Butts is a pediatric heart failure and transplant cardiologist at Children's Medical Center, Dallas. He has served as the medical director of the heart failure and transplant program for the last 6 years. Welcome, Dr. Butts.
There we go. Thank you. And thank you for the opportunity to talk. After the last couple of presentations, I probably should change the title from heterotaxy and heart transplant to heterotaxy and the other biventricular repair, which is not as popular at times and less sexy, but we'll talk about it anyway. Heart transplant has been a palliative option for patients with heterotaxy. In the US, since we've taken data from the late 1980s on, 2 to 5% of all pediatric heart transplants have been in patients with heterotaxy syndrome. And so I started preparing this talk, and I thought to myself, man, maybe I have imposter syndrome. Maybe I shouldn't be up here. And so I looked back at our own data at CMCD and looked at over the past 5 years, when I look back, about 7% of our transplants were in heterotaxy patients. The amazing thing is that has actually occurred in the past 3 years. Shown here, this is the amount of transplants we've done in each year. Those in orange are congenital heart disease without heterotaxy. Blue is congenital heart disease with heterotaxy, and then the gray is cardiomyopathy. This is this sort of pattern of increasing amount of congenital heart disease going to heart transplant is common throughout the whole entire nation. It used to be that cardiomyopathy was the most common indication. No longer. It's congenital heart disease by far, single ventricle by far, and so not surprisingly, we're getting more heterotaxy patients to transplant. So it's important to know what are the outcomes for these patients and what can we do better. So how do heterotaxy patients compare to other patients with congenital heart disease? Well, they're more likely to have a sternotomy and more sternotomy. So not just have one, but 2, 3, 4, 5, 6, all those times that the surgeons go into the chest. They're more likely to have a total anomalous pulmonary venous return, which is really challenging for our surgeons. I hate, as a cardiologist, to be up here to speak this, but for a transplant, you usually take the back wall of the left atrium as a cuff and sew it into the donor's heart. And so when the veins come at really odd anatomy, it becomes really hard to figure out how you're going to baffle it over and make it fit into the anatomically correct heart. They're more likely to be single ventricle patients. So They're also more likely to be of younger age, so smaller hearts, harder kids to take care of, longer to be on longer cardiopulmonary bypass time, and longer ischemic time. So all these sort of things. So these patients, by all means, are more complex. And unfortunately, more complex does equal more problems. So how does that pan out in terms of outcomes? In this study, which is a combination of utilizing the UNOS database and FIS database, they looked at outcomes in terms of survival after transplant for those patients in red who have heterotaxy syndrome and congenital heart disease versus green with just congenital heart disease versus cardiomyopathy. And you can see that there is a survival disadvantage of having heterotaxy. Now, what they did show, luckily, is that this is really confined to the first year post-transplant. So if we have conditional 1-year survival, the outcomes are actually fairly the same, which really does speak to all the things I just talked about, that these are more complex surgeries to take care of, so they have a lot more problems post-operatively, and therefore are more likely to suffer from more post-operative morbidities, and then eventually mortality. There is good news in the PHTS analysis done a couple of years ago. The outcomes in the early area were significantly worse, but have improved and have gotten closer to those in congenital heart disease. So I think this has a lot to do with us in the transplant world, have spent a lot more time figuring out how to do better transplants in patients with congenital heart disease and how do we manage them. Specifically to the patients with heterotaxy, the risk of likely having mortality after transplant, there's 3 risk factors they found. Elevated bilirubin, which yes, could be from liver abnormalities, but honestly is more likely a sign of right heart failure, high central venous pressure, which leads to a lot of different comorbidities heading into transplant. Unfortunately, female gender, I don't really understand this. Usually females do a lot better than men, but this is the one time it panned out. And then polysplenia, and that probably is a marker for the total anomalous pulmonary venous return, but not 110% sure because the data wasn't able to actually pull that out. So those are the risk factors. What about residual lesions? So this is what happens, we do the transplant, but there's something left behind. This actually is really could only find one good study out there that was published out of Chicago, where they looked at all their transplants over an 11-year period. They had 15 patients that had heterotaxy syndrome, and 9 out of 15 had a residual lesion, so a good bit. And you can see the amount of residual lesions up here. As you can imagine, some patients actually had more than one residual lesion. So does it matter? Do we care? Well, when we looked at their Kaplan-Meier curve, which yes, looks more like a step scale than a Kaplan-Meier curve, but those in yellow are those with no residual lesions versus those with residual lesions you can see did significantly worse. While the p-value technically wasn't statistically significant, this obviously has a lot to do with the lack of power and small numbers, but I think this is an area, if we look at this multi-institutionally, it easily play out, and it's one of the most important things that we can think about is how we're going to take care of residual lesions. So, mentioned all the problems, I mentioned the ways that we, the things that we can encounter. Let's talk about a little bit how we can actually get better and move forward. These are the 4 areas that really and truly I think are what we can do to improve post-transplant outcomes in patients with heterotaxy. Candidate selection, pre-transplant planning, post-transplant management, and addressing some of the knowledge gaps. I've mentioned some of the knowledge that we have so far, but I think there's a lot that we still have to uncover to really start making management decisions. All right, candidate selection, early referral. This is, if anybody from Dallas has heard me speak over and over again, this is one of the biggest issues I see. There is an unnatural bias or natural bias of most cardiologists who are not transplant cardiologists to sort of look at transplant as a failure. Think about all the PHN studies that were done earlier, SCR trials, it was death or transplant. Transplant-free survival. Those are all incredibly important, I understand why they put it there, but it creates a little bit of a way of thinking that somehow transplant and death are the same thing. They're not. You know, most patients do live and do well. I think while transplant has a lot of inherent problems, so we do often will hold on to these patients way too long and then transfer them or bring them to transplant when they've accrued a lot of morbidity. So let's start identifying the patients who aren't going to do well with a single ventricle palliation or maybe a biventricular repair. So this is an old study, but this is a good hint of what sort of data I think we need to continue to accrue. This is published out of CHOP in 2006 when they were just looking at all of their, does prenatal diagnosis actually improve patients' outcomes after heterotaxy? But in their series of all the single ventricles that had complete heart block, not a single one survived. Not a single one went home. Now, it's old data. You could say that doesn't apply to any day. We're better at surgery than we used to be. But a more recent study done out of the MPC-QIC looked at the likelihood of what is the impact of heart block in patients with single ventricles. So this is all single ventricles, not just heterotaxy. What they found, first of all, is heterotaxy was a risk factor for developing heart block. Not a surprise to anybody in the room. But they also found that heart block was a significant risk factor for death before 12 months of age. So again, single ventricles with heart block may be people that you want to refer instead of waiting till they develop heart failure. In pre-transplant planning, I think this is incredibly important. Cross-sectional imaging. We just heard earlier some great talks by some people who are incredibly much more intelligent about cross-sectional imaging than I will ever be. However, I think that cross-sectional imaging and discussion at the time of transplant selection is incredibly important. So this is a great CT of taken actually one of our patients that we were just evaluating for transplant. And one of the things that we have done is actually have our cross-sectional imager show up. Because I cannot go over every single thing on this thing. I am not that good, not even close. But having a cross-sectional imager show up and discuss the anatomy, discuss with the surgeons, with the rest of the group listening, exactly what the plan is. The example I give is nobody in a cardiac unit would ever think about doing a Fontan or a complex biventricular repair without having presented in a surgical conference, without having the cross-sectional imaging displayed to everybody else. Why are we going to do this for transplant? Made no sense to me. So we started having our cross-sectional imaging show up. Another, I think, significant improvement that we have, or technology that we can utilize for improving heart transplant outcomes is ex vivo perfusion. So ex vivo perfusion is exactly what it sounds like. It is where they can actually, after recovering the heart, donor heart, they can place it on a pump that will allow it to pump, oxygenate the blood, and then it returns through a cannula, it returns oxygenated blood back into the coronary. So the heart is not stopped. This is great for the heterotaxy patients who have one of the most complex chip outs with multiple sternotomies, multiple repair that has to be done before the transplant occurs, and this can actually reduce the longer ischemic time that I mentioned earlier. So I think this is a great technology. The unfortunate thing in the US, you pretty much have to have a donor that is 30 to 35 kilograms or more. So really our younger patients are not benefited by this. There is a device that's utilized in Europe right now that can go down to 20 kilograms. And then a little bit more ethically challenging is the use of normothermic regional perfusion, which also could be another way to help reduce ischemic times. Post-transplant management, I mentioned, so moving along, that really and truly, to my mind, should have actually started before the transplant occurs. So the way that we sort of try to address this is we have what we call a flight plan and huddle. The flight plan is actually a living document that we create once we put a patient on the list, and it gets updated. As I was talking to some of you earlier during lunch, the time from you getting on the list to the time you get transplant could easily be 9 months for those infants in the hospital. For kids that are home, that could easily be years. So lots of things change. They go to the cath lab, they may get stuffed balloon, they may get stents, they may get anatomical problems addressed. So a lot of things change. So we need to have a living document because we can't just rely on what happened when we first discussed them in the selection committee to still apply. And then more importantly, because there's so much time from that selection committee to the time they actually go to the OR, we need to reconvene, get all the group of people back together and discuss the patient. So we call this the huddle. Unfortunately, transplants aren't planned. They aren't. You can't just do this on Monday conference or whenever your surgical conference is. So you sort of have to be willing to do this as an ad hoc basis. And thank God for Zoom because it makes it a lot easier. But that's where we will discuss things for instance, I mentioned earlier. There's a lot of patients who could have IVC stenosis or SVC stenosis or AP collaterals. and how we're going to look for those and address those earlier on. Because if we talk about the likelihood of them occurring, that they often can get recognized faster post-transplant and addressed faster. And then lastly, for any of the astute people in the audience, yes, there are two number 35s, and so ChatGPT is not a good football coach because this would be an illegal procedure. But it still worked. And then lastly, addressing some knowledge gaps. So what do we know? I mentioned a couple of studies about outcomes, but in that PHTS study specifically, they also realized that heterotaxy patients are at increased risk of hemodynamic compromised rejection. So that's obviously incredibly concerning. There is also a shorter time to first infection. So if you take these two things, you can't just give patients more immunosuppression because they're more likely to have an infection. You can't reduce the immunosuppression because they're more likely to have rejection. There is no difference in coronary vasculopathy or PTLD, at least in that study, but polysplenia is a risk factor for mortality. So this is what we know, but I think we need to start going into a little bit more deeper. We need to know what type of rejection. Is it more likely antibody-mediated rejection? Is it cellular rejection? Is it a mixed component? What was the immunosuppression regimen for those patients who had rejection versus those who didn't? Are there specific risk factors when they got transplanted? Did we cross donor-specific antibodies? Those things we actually don't know yet. We should know, but we need to continue to look into it. The shorter time to infection. What type of infections? There's been some early reports of encapsulated bacteria, but it just says overall infection. Were those patients on prophylaxis? Because the amazing thing in transplant, despite as much knowledge as we have, what happens in Boston versus what happens in Dallas and CHOP can be completely different regimens, and everybody claims that they know what they're doing best, but there is really not much standardization between units. And then polysplenia is a risk for mortality. Is this just a surrogate for TAPVR? And what is the cause of death in these patients? What are we missing? These are the things I think we need to further investigate in the transplant world in order to improve outcomes. So in summary, about 2 to 5% of pediatric heart transplants occur in patients with heterotaxy. The highest risk for mortality is in the first post-transplant year, which is but is overall improving in the most recent era. And areas for improvement I see for us is in early referral for selected subgroups, reduction in residual lesions or faster identification and intervention, and methods to mitigate infection and rejection. Thank you.
So we can welcome the speakers back up to the lectern here. And we have a few minutes for questions. So if anybody has any questions, please feel free to come up. Our one request is that you please speak into the microphone so that those who are attending virtually can hear.
So thank you guys very much. I don't mean to steer this back to PCD because you heard about this all morning, and I apologize. But we are often asked as the lung doctors, oh, you've diagnosed this single ventricle with PCD now. Should we not go ahead and do more surgery? To which we've all said, hell no, you need to go ahead. But should I be pushing for biventricular repairs versus univentricular? Because the 3 or 4 patients that had univentricular repairs for me with PCD died at age 4 to 5, and their lungs were really trashed by that point. And it's not usual for a PCD patient to die of respiratory failure until their 40s, 50s, 60s. So these kids were clearly outside of the bell curve.
Yeah, I mean, I think there were, in my mind, is the surgeon runs a complex single ventricle program in Boston. There were so many questions I had this morning, including that one of like, how should we risk stratify these patients differently? Like, makes me want to do inhaled nitric oxide on all of my single ventricle patients, right? And see what we're missing, because I do think the whole morning highlighted that there's a lot of risk stratification that we're not, at least from my perspective as a heart surgeon who's like taking these cases down one path or another. And I think you raise a very, very good point. And I think this all morning raised very, very good points that we have a long way to go to understand risk stratification. I would say our opinion is everyone should go down a biventricular pair pathway if their anatomy, and their heart function makes it feasible. So, but I do think, just as Ryan alluded to, it makes me think that we should totally change our threshold for transplantation in many of these patients, right? Because we play the same game that they play in Texas. We sometimes refer too late, and then we're behind the 8 ball where we shouldn't be. And I think that's a great example of a patient you could change
What we
their
really need
trajectory.
are some prospective statements to help us, because not every surgeon knows what you're doing at all of these centers, and I'm telling them there's no real precedent to withhold heart surgery from these kids due to PCD. I mean,
Right.
they're treating it as like a cancer diagnosis.
Right.
And I'm like, no, that's not the case. And Tom Saba's had these same arguments with people, and it's happening everywhere without some very strong statements, even as little evidence-based as they can be, to say they should not preclude heart correction, cardiac correction. We need those badly, because it's happening very haphazardly all over the place now.
Yeah, but I think Caitlin has spearheaded an entire respiratory clearance program formally for heterotaxy patients, and I do think it underlines the importance of all of those things. You can't just say we should just do what we always did and hope for the best. I think we need to take all the very proactive steps to make sure these patients really do well if you know this going in. So.
Yeah, thank you.
Yep.
Dr. Shapiro, you just set up a great question for tomorrow, where we'll be talking about our HRC3 toolkit, which addresses that very specific question. So, perfect.
Hi, everybody.
Sean.
I'm Sean Bali-Baligan from Cincinnati. This is all fascinating. One of the topics I specifically have as an interventional cardiologist been very interested in the size of the Fontaine conduits, as you said. We tasked it with one of my former fellows. Have you guys been using picographs at all, or have you thought about that? I'm sure you have.
Yeah.
Picographs, by the way, for everyone, is dilatable tissue, fabric, essentially.
Yeah, the picograph is terrific. It's basically standard PTFE, but the nodes are bigger, and so when you stretch it, it will grow to 200% in the lab in theory. Yes, we have used some picographs, probably a handful. None of those patients have been dilated post. We are generally speaking a lateral tunnel center. And that is probably the one way to get over the growth issue. And I didn't get into the details, but the lateral tunnel patients have less increase in energy loss than the extracardiacs. What we just published is the extracardiac conduits. We usually put in, everybody in the country usually puts in 18s. What we've shown is that they, both the plastic size tends to regress over time, and there's always the obligate lining of fibrinous material. So the effective diameter, unfortunately, is less than 18, sometimes substantially less than 18. So the jury is still out, and no threshold exists. But certainly, as you know better than I, you can, to some degree, balloon and stent these conduits in the lab. But we are seeing a lot of kids who the 18 put in infancy is correlated with early liver disease, and there's some 16s at our centers and other 16s that have come to us that definitely have early liver disease. So I think it's a huge opportunity in these single ventricle patients to be very proactive in a way that we haven't in the past.
Yep. And then one last question is, and this is probably pretty naive, but for Dr. Bruckner, would there be any, because as an interventional cardiologist, I do biopsy sampling all the time on heart transplant patients. So it may be a little bit, we'd have to think about the research ramifications of it, but do you think there'd be any utility in getting myocardial samples on heterotaxy patients to assess ciliary function? Is that something that we can consider doing?
Okay, thank you. Sorry, I was initially thinking post-transplant, which would be a whole entire symposium at ICLT. So, here, you want to answer that first? You probably do better. Okay, it's a great question. I think it's a really hard one to answer, as the field, I will be honest with you, in heart failure and heart transplant has gone away from biopsying as frequently due to the fact of, honestly, from my standpoint, I see a good bit of tricuspid valve injury, AV valve injury over time, and if in the wrong spot, if the AV node is injured or any other of the conduction system. So if we can reduce the harm that occurs during the procedure, then I think it's worth probably investigating further. But given the amount of data I can get now in terms of management from hemodynamics and MRI, I usually don't request a biopsy too often.
I just meant it more from a research standpoint. Is there any way to assess, say, in a non-transplant patient, right, when we routinely cath them?
You mean, are you
Yeah.
looking to see whether obtaining samples from either the cath lab or the OR for research purposes would help us understand the mechanisms?
Yeah, we just wanted to.
The answer to that
Picture
is
that.
absolutely yes, especially the transplant, explanted hearts. And I know the PCGC consortium has been collecting tissue samples at the time of surgery, and especially John and Cricket Seidman have been working on a single cell RNA-seq or single nuke RNA-seq on those samples to better understand the transcriptional effects from the underlying congenital heart disease coupled with surgical and cath
tissue sample,
and tissue intervention. Currently, we are not collecting samples because the program is not recruiting until we get the good word to resume. And we haven't specifically looked for cilia defects because a lot of the focus has been on hypoplastic left heart syndrome and tetralogy of Fallot, so that we could have two groups of tissues that were internally comparable. But I think as we move forward, I'd be particularly interested in valves that were explanted or resulting in transplant, because I think that's where we're going to see a lot of the cilia-related pathology.
I think a number of us who do imaging or care for these patients frequently observe a pattern of non-compaction in heterotaxy. And Dr. Bruckner, I've heard you comment on that previously, so I'm curious if you could offer some thoughts on that.
At the patient level, I don't have anything to date. At the research level, there is some suggestion that having no cilia early in development results in impairs the ability of the developing heart to form compact myocardium. So it's not quite surprising, but we don't have the numbers and the longitudinal follow-up to really look at that. Again, as you identify more patients and are able to follow them over time, especially their echo variables, that may allow some insight connecting genetics to things like non-compaction. Is theoretically quite possible. The answer is not there yet.
Any other questions? Oh, sure.
No.
Yes.
I was wondering whether have you seen either in the mouse models or in, for Dr. Bruckner, or in human hearts, have you seen, is there a significant level, a varying level of expressivity or sort of mosaicism at all that you see in within the hearts with heterotaxy in terms of the ciliary function, or do you see any of those changes at the sort of different levels of in the atrium, at the valve level, or is it kind of evenly distributed?
You mean you're looking at the normal hearts?
The patients with heterotaxy,
That we haven't been able to look at. We've started a single cell sequencing effort on mice with and without cilia to show some of the tissue level effects. And we've focused on valves so far, but there is clearly something in the myocardium also. But this is in early mouse hearts. We don't have the human samples, which in a way is a good thing, but I think that would be really helpful down the road.
Any other questions? All right, in that case, we'll conclude this session a few minutes early. We'll plan to return here at 3:20, or just a bit before. Oh. Okay, and if you have posters, please let me or Tom know, and we can direct you to the right location. All right, we'll see you at 3:20.
I like to give Nick Anderson a hard time. Like I said, it's either by V with or without immunosuppression.
That's right.
We should.
We make 3D models for all of us.
Huh?
We make 3D models.
Do you?
And
Yes.
It's so helpful.
Yes. Yeah.
So helpful. So
Yeah.
I echo your excellent.
Yes, because it just is one of those things. It's like, oh yeah, we and you're sitting there and while if they're having that conversation without us, they're not recognizing or they're not recognizing.
And if it doesn't work, yep. I just want to make sure that I'm not disrupting whatever your flow is to be. No, I think it's Google Slide, I think. Oh, okay. So you need to mirror your desktop. Oh, right. Yeah. Something your other desktop. Yeah. How do I do that? Right click on the desktop. No, there's a. That's it? Okay, wait, so let's, how about that again? You good? That's good? Yep. Okay, cool, so we'll do this. Yeah, I think that's probably the easiest. So I'll let you, this will be in the morning. Yep. What time do you get there? We get here, tomorrow we start at 8:15? Yes, that's. Probably about 7:15. Okay, so I'll come up for breakfast. Yeah, well, I'll go see me either here or breakfast. So, Daniel, okay. My pleasure.
Montreal do. First presenter?
Mm-hmm. Does that make it easier?
Yes.
Is it gonna be? Yeah.
So let's do extended desktop.
Extended screen or extended display?
Extended display. Now when you go into presentation mode, you should see slides over here. Yep.
Oh, yeah.
You're starting there, or do you want to start at the beginning?
No, the beginning. Yep. Well, that's perfect. Okay. Then you'll put it
I'll put it on screen when you start speaking.
Thank you so much.
Use her computer. The connector for the HDMI right there, and
Good afternoon, everyone. Really looking forward to this next session, session number for the day. This will be a little bit of a break from the heart and the lungs, and we'll branch out into some other organs that are affected by heterotaxy and learn about biology and surgery and things that we do to make the lives better for our patients. So to begin, I'd like to introduce Dr. Natasha Corbett. Dr. Corbett earned her MD at the University of Pittsburgh, where she also completed a PhD in cellular and molecular pathology. She then did a surgery residency at Vanderbilt and pediatric surgery at University of Michigan. And we are fortunate to have her now as an assistant professor of surgery at UT Southwestern. She's a talented physician scientist, and her lab focuses on some of the basic molecular roots of biliary atresia. And I could go on about her research, but I will let her take it from here. Thank you.
All right. I'm going to wait for my slide to come up. There we go. October 3rd, Life of a Showgirl came out. I don't know how many people streamed it so far. But anyway, I thought I would break the talk up into two halves. The first half will be kind of an illustrative example of how to work up biliary atresia. And then the second half will circle back to the ciliary genes, as many people have talked about today. I have no disclosures. So for the illustrative example, first we'll just kind of define what biliary atresia is. This is a picture from a baby that has biliary atresia, and the bile duct in the gallbladder here is really atretic appearing or diminutive, and so that's where the name comes from. And people used to think that biliary atresia was kind of acquired, like you were born and then something environmental happened and then that caused things to scar up. But now we've learned over the last probably 10 or 15 years that that's not really the case. So why am I even talking about it? Because it's a pretty rare disease. But it comes in two flavors. It can come by itself, or it can come in association with other disorders, which I'll talk about a little bit later. But it's really the main indication for liver transplant for kids. It makes up about 40% of all transplants. And we really don't know what causes it. I kind of subscribe to the notion that there's multiple reasons, and I'll talk about some of them, but it's really hard to treat a disease when you don't know what causes it. The main characteristic of biliary atresia, though, is obstruction of the bile ducts from scarring, and then that blocks your bile flow, and then the liver becomes scarred, and eventually kids will need liver transplant. Most kids will need a liver transplant, in fact. I hope to put myself out of business one day and not have to do surgery to fix this, but right now the main treatment is surgery. It's called a Kasai portoenterostomy. It was first described in 1955 by a Japanese surgeon, and we really haven't developed any new treatments since then, to be quite honest. There's no medicine for it. And so the more that we learn about it and what causes it, then potentially we could come up with some new therapies, but for right now, it's just surgery. Okay, so this is an actual real patient, but this is just a little bit of hyperbole. Okay, so Taylor and Travis have a baby. They bring their baby to you, and their baby has jaundice and scleroicterus, and they say, hey, you know, my baby doesn't look right. What's going on? And so turns out 2/3 of babies are going to be born with jaundice. It's not that big of a deal, in fact, but usually after 2 or 3 weeks, that jaundice should resolve. So when it's persistent, then that's worrisome. In Texas, everything is bigger. We have over 1 million babies, and you can do the math. 2/3 of those having jaundice is a lot of kids to think about, but 1 in 2,500 will have pathological jaundice, and that's going to be from a biliary obstructive problem or a hepatocellular problem. Travis and Taylor tell you that the baby's poops look funny too. And so on the right-hand side are normal-looking baby poops for parents in the room. And on the left side are abnormal-looking poops that lack pigment. And, you know, at first glance, it can be kind of hard to figure out which one's normal and which one's not. They all kind of look not appealing. They say, you know, today the baby is 38 days old, and that tells you that this isn't really, you know, physiologic jaundice, that this is pathologic jaundice, because breast milk jaundice or physiologic jaundice of the newborn should have resolved, like I said, after 2 or 3 weeks. So now we say, hey, what are we going to do? We're going to get a fractionated bilirubin. That's really the first step in the initiation of the workup, and we get one, and turns out the direct bilirubin is elevated to 5.2. And so what does that mean? Well, it could mean a lot of things, right? The most common reason would be biliary atresia, but there's almost 40 different disorders that could cause a direct hyperbilirubinemia in a neonate, as I'm sure the neonatologists in the room are familiar with. And so, you know, there could be obstructive reasons, or the hepatocellular reasons, or infectious reasons, like I mentioned, or even some genetic reasons. A lot of monogenic disorders that are very rare can cause a direct hyperbilirubinemia. It turns out that an elevated direct bilirubin shortly after birth is very highly suspicious for biliary atresia. And I kind of alluded to the fact that people used to think that biliary atresia was acquired, but whatever is causing that scarring of the bile duct really starts happening before the baby is born. And that is represented by this elevated direct bilirubin within the first couple of days of life. A lot of work done by a group from Houston actually has shown this to be true. So now they're saying, well, how come when the baby was born you didn't know that this was going to be a problem? And there's no national screening for biliary atresia. And there's not actually like a screening test that's available, although in Utah they have started doing bilirubin screening for all newborns in the state. But if you're born in the United States, you'll get a newborn screen. And in Texas, we screen for 41 different disorders. Massachusetts, I think it's 44. Every state is a little bit different. And there are several different disorders that cause hyperbilirubinemia that come up on the newborn screen. We don't test for CMV in Texas. There's like 5 states that do. So it's not comprehensive, but it's helpful. So now we got Grandma Kelsey, who's wondering, like, why didn't you do more? How come you didn't figure this out earlier? And we say, okay, well, we're going to do this other test that's the latest and greatest, MMP7. So MMP7, I think someone spoke earlier about another matrix metalloproteinase, but this one is involved in extracellular matrix remodeling, and it turns out that it's elevated when there's more scar. In biliary atresia, there's liver scarring and bile duct scarring, and so everyone kind of thought this was going to be like the holy grail when it first came out, and it is elevated in kids that have biliary atresia, but it's not totally specific. From work from our group, we know that it is really good at ruling out biliary atresia. In fact, it's highly sensitive and has a negative predictive value of 100% in a cohort of 100 patients when the value is less than 18. So we're one step closer to ruling out biliary atresia. One of the big issues with MMP7, though, is that it's not tested universally. Right now, Dallas actually is the main center. It used to be at Cincinnati, and then it moved. And so it's a send-out lab, so it's not immediately available right at your center. So we got the MMP7 as 34, not super helpful. And so we say, okay, we're gonna get some imaging. And these things can happen concurrently. And so ultrasound is really the standard imaging. Usually a biliary tree on ultrasound is gonna look black. But this is the ultrasound from Travis and Kelsey's baby, Travis and Taylor's baby. And you don't really see where the bile duct should be. You do see the portal tract with some Doppler flow. For comparison, this is a dilated common bile duct, which you can see clearly. But the fact of the matter is that if you see the bile duct or not, or if you see the gallbladder or not, is not diagnostic of biliary atresia on ultrasound. It's just helpful to find a different congenital anomaly to rule that in versus making the diagnosis of biliary atresia or excluding that diagnosis. Okay, so now we have the peanut gallery involved, and everybody wants to know what's next. So sometimes people will get HIDA scan. We currently just surveyed 44 big centers in the United States, including Boston Children's, lots of the big centers, asking about what imaging modalities, what diagnostic testing is performed, and there's really a lot of variability. We know that HIDA scan can be helpful at evaluating biliary patency non-invasively, but it's not the best. And it adds a lot of extra time. In fact, the pre-treatment for a HIDA scan can add at least a week in the diagnostic period, and that turns out to be really important. I think before people used to think, oh, a week is not a big deal, but it turns out a week in the diagnostic period for a kid with suspected biliary atresia and actual biliary atresia makes a big difference. So now Travis and Kelsey want to know what else we could do. So there's some more invasive things that we could do. We really need to know if the bile duct is patent or not, or if it's scarred and obstructed. And if at your center you have advanced endoscopist that can do a neonatal ERCP and the right equipment, then that's a valuable option. I can tell you like a handful of centers have that. We are lucky enough to have that in Dallas, but half the time the neonatal endoscope is not available. And you could do a percutaneous cholangiogram if you have interventional radiology, and a lot of centers do this, and that works pretty well too. Baby still needs general anesthesia, and oftentimes they'll do a liver biopsy at the same time, but then after they make the diagnosis, baby will have to go back to sleep again to get the definitive treatment, which will be the Kasai operation. So then parents are asking now about genetic testing. Is there a genetic test that we could do to rule in biliary atresia? Not at this moment. In fact, there's a cholestatic genetic panel that Prevention Genetics does. It's for free. I think it used to be 66 genes and now it's 75 or so. But it can rule in a lot of other monogenic disorders. I've heard some other folks talk about different screening panels that can turn around in 2 weeks or so. This panel takes about 4 weeks. So maybe when it's for free, it's a little bit slower. So not super helpful for biliary atresia. Okay, so now we say, you know, the most diagnostic test, the best diagnostic test, the gold standard diagnostic test is actually surgery with a cholangiogram. And so now you got Taylor saying like, oh, we're going to sleep. Okay. So we made it to the operating room to do the gold standard test. And before the cholangiogram used to be done open. In fact, surveying 50 centers, turns out like only 15 to 20% of those centers do laparoscopic cholangiograms, which I'm working very hard to change. But a big cut is pretty significant for a small baby, so we try to do this with small cuts. This is just showing laparoscopic camera with a little catheter going into a gallbladder, and then you can shoot dye in there and then see patency of the biliary tree. And then this kid did not have biliary atresia. But these are the small little cuts, so in general, this is very well tolerated. Now, this kid did have biliary atresia, and when the dye goes in, you can see that it doesn't really go anywhere, it just stops because the biliary tract is obstructed. You can also see the liver doesn't look the best, and the gallbladder is really diminutive. So this child got an operation, and during the diagnostic procedure first, and then the Kasai operation during the same anesthetic, and then did great. So everybody's happy, right? So then you say, well, let me tell you about liver transplantation. So after this whole ordeal, and for most kids this is the situation, the median and average age is over 60 days old for biliary atresia, and that's partially because we don't really have a standardized way to work it up. Sometimes it's because of late presentation, lots of reasons, but the bottom line is most of the kids are 2 months of age or older, and every day older that the child gets, the more likely it is going to be that they need a liver transplant. This is showing just native liver survival based on the age that they were when they got surgery. So if they're younger, their native liver survival is better. If they're older, their native liver survival is worse. And the other thing is, when I do surgery for this operation, you know, even if they have biliary drainage and the obstruction is gone, sometimes the liver disease still gets worse. Nobody really understands that. It doesn't quite make sense, right? Because if they had a blockage, you relieve the blockage. How come the liver can't recover? It's one of the most regenerative organs. And so that really piqued my interest a lot. But this study came out of the Western Pediatric Surgery Consortium, and they looked at over 200 kids and found that for every day older a child is with biliary atresia when they get their Kasai operation, there's a 2% decrease in the likelihood they can keep their own liver. So let's say you get a HIDA scan and it takes a week to get done, just reduce their native liver survival by 14%. That's a lot. So the thinking used to be, oh, you got to get this done by the time they're 2 months old, and really now it's we need to make the diagnosis as early as possible, to intervene as early as possible to give them their best chance of keeping their native liver. These are just kind of all the different things that I went through, multiple different diagnostic tests, and this can be really highly variable among centers, very time consuming and extremely expensive. This is data from the Midwestern Consortium that just came out this year, looking at 10 centers and how variable the diagnostic workup period is. I mean, at some centers, Center G is doing it right. They're fast. That might be Cincinnati or something, but you know, the other centers, there's high variability and it can really take a super long time, and that's a big problem and one of the things we're working on trying to make better. And so once we kind of establish, you know, what all the different centers are doing, then we can have a little bit more standardization and set some national benchmarks in how we can make this faster, more efficient, and better for the patients. So I want to get back to the genetics. And I've always had a strong interest in genetics. And, you know, when you think about biliary atresia in isolation, you know, people didn't really think that there was any genetic links to it. But when you think about the syndromic form of biliary atresia splenic malformation, you do think, like, you know, there must be some genetic component because they have these other congenital problems. And so roughly 20 to 25% of kids with biliary atresia will have also laterality defect or congenital heart disease. And, you know, when we think about laterality defects, as many people have discussed earlier, or even congenital heart disease, you do think about some genetic origin. And so I thought, well, for syndromic biliary atresia, you know, maybe there could be a genetic origin there too to account for the whole constellation of pathology. So this paper came out in 2019, right before I joined faculty at UT, and the Children's Network, they did some genetic sequencing on a small cohort of patients that had syndromic biliary atresia. So all these kids had laterality defects and or congenital heart disease, and they came up with this gene PKD1-like-1. I think someone mentioned earlier PKD1. This is a relative, they're cousins. And so several of these patients had biallelic mutations in PKD1-like-1, and so we thought maybe this is a candidate gene for syndromic biliary atresia. So my lab modeled this in mice, and if you totally knock out PKD1-like-1, it's embryonic lethal, so we did some conditional knockouts and then some heterozygous knockouts. And we found that we can really recapitulate malrotation and heterotaxy, but with incomplete penetrance. And so some of the patients that I've operated on actually have PKD1-like-1 mutation and have had a centrally located liver, have had a preduodenal portal vein. This mouse has a preduodenal portal vein, stomach and spleen are on the opposite side, liver is on the opposite side. This is another preduodenal portal vein here. And many of the mice have malrotation where the intestine's not normally fixed. We looked at the chest also, and several of the mice had dextrocardia and even pulmonary isomerism. And so we thought, wow, okay, well, what about the hepatobiliary system? This is a bile duct from a patient with biliary atresia, and I told you it gets scarred and blocked, and this is where the opening is supposed to be, and it's scarred along here. And so we looked at the bile ducts of these mice, and they have a lot of extra collagen deposition and bile duct hypertrophy that causes the bile ducts not to drain well. And so we also kind of recapitulated the phenotype that patients have with syndromic biliary atresia. And then we looked at the liver because one of the big phenotypes is liver scarring, and many of the mice had some scarring around the portal tracts. And so we essentially kind of connected all the dots. You know, PKD1-like-1 was this candidate gene, and then knocking it out in mice, we can recapitulate most of the features of syndromic biliary atresia to show that, yes, this gene, when it's defective, can drive this constellation of symptoms. But we wanted to know how PKD1-like-1 is really important for ciliary calcium signaling. And so downstream of the cilia is some hedgehog signaling, and I'm not going to get too molecular on all of y'all, but we did notice that there were reduced cilia in these mice. And then when we wanted to look at the mechanism of what's kind of driving this whole picture when you lose PKD1-like-1, we found that the hedgehog signaling was disrupted. And so we gave a drug that suppresses hedgehog signaling. It's called GAN61, and we actually were able to cause the same scarring of the bile ducts that we see in patients. And so that was really promising and really kind of uncovered a whole area that really hadn't been well investigated for syndromic biliary atresia or biliary atresia in general. And so this kind of is like the foundational work. Another group, Saul Karpa's group, showed similar finding for this particular gene. in different ways, but really established that syndromic biliary atresia is a form of a ciliopathy. There's 21 or 22 now candidate genes for either isolated or syndromic biliary atresia. I don't plan to make 22 mice in my career, but I have made a couple. So another candidate gene is CFC1. These were also identified in some patients that had syndromic biliary atresia. We have knocked out this mouse and shown that they do get liver fibrosis, and they also get laterality defects and abnormal intestinal fixation. And then another gene, DCDC2, is involved in kind of establishment of the axoneme and cilia. We have knocked out this gene and found that it can cause really precocious cirrhosis. And so this mouse is pretty young. It has hyper splenomegaly and really a completely cirrhotic liver by 4 weeks of age. And so this is kind of, my main area of focus in trying to understand how ciliary genes can be genetic drivers of liver disease, and how they can affect other organs too, but mostly the liver. And this really opens up a new avenue of treatment, because now instead of thinking about surgery, I can be thinking about how can we correct these genetic defects? How can we identify these genetic defects? So maybe I could operate on a baby earlier if we do genetic screens and identify a bigger panel of genes that can contribute to biliary atresia or syndromic biliary atresia. And then also, how could we give those genes back to treat the pathology? And I think that's really going to be the future of precision medicine. So I just want to conclude with biliary atresia is a surgical emergency. That making the diagnosis is urgent and every day counts. The cholangiogram is the gold standard, but MP7 is helpful, and the fractionated bilirubin is really important. And then the ciliary gene defects also are really important drivers of liver disease, particularly in the syndromic form of biliary atresia. Thanks, everybody.
All right, thank you very much for that wonderful talk. It was really informative. Next, we are going to hear from Dr. Benjamin Zendejas Mummert. Dr. Zendejas Mummert earned his medical degree in Mexico, followed by general surgery training at Mayo Clinic, a pediatric surgery fellowship at Boston Children's, where he is now associate professor of surgery. He has diverse research interests and an impressive publication record, and currently serves as the surgical director of the Esophageal and Airway Treatment Center. I'm looking forward to hearing his talk on intestinal rotational abnormalities.
Thanks. Hi, everyone. You get to hear from another general pediatric surgeon. So now we're going to talk about the intestines. And can we get my slides up? Oh, I see. Sorry. So I just do that. There we go. Okay. So intestinal rotational anomalies, this is the umbrella term for what we're going to be talking about. Everybody thinks about it as malrotation, but malrotation is only one element of an intestinal rotational anomaly, and that's what I'm going to try to convey to you. In general, they're rare, and they tend to be a little more common in male, but for reasons that are a little unclear. They happen with all sorts of conditions, but predominantly things that are associated with the intestines or the guts developing outside of their normal location. So for example, congenital diaphragmatic hernias, gastroschisis, and fallacy. By definition, these are entities in which the intestines are somewhere else where they shouldn't be, and therefore they don't follow the normal path of migration that we're going to talk about. And quite common within these elements for some congenital heart disease is particularly the topic at hand today for heterotaxy. So the way the gut normally rotates is outside the body for the first few weeks of life, and then comes back into the belly roughly around the 10th week of gestation. And you have to think about it as sort of two loops, what they call a proximal or duodenal-jejunal loop, which is sort of like the proximal bowel, or the distal cecocolic loop, which is the hindgut or the sort of distal bowel. And any problem in that rotation, even partial or complete, is going to create a problem in what we call the rotational anomaly spectrum. The one that's more sort of thought of is this one, right? This is intestinal malrotation. It's actually a non-rotation of that first loop. That duodenal jejunal loop stays sort of straight and down to the side, but it's an incomplete or abnormal rotation of that distal loop that sort of doesn't completely rotate, stays kind of somewhere in the mid-abdomen, but generates these adhesions that are called Ladd's bands that are going to partially obstruct the duodenum and also create a pedicle that is very narrow and predispose it to twist. And so this is sort of that presentation where, because the pedicle of the small bowel is narrow, it allows it to twist a little easier, and this is what volvulus is, right? So these bands can also cause obstruction without volvulus, and this can be symptomatic in terms of feeding difficulties, inability to tolerate gastric feeds, et cetera. So the other end of the spectrum, which can happen as well, but can tend to be a little less symptomatic because the mesentery is not as narrow, is this complete non-rotation, right? So the small bowel is all the way to the left, the cecum and the large bowel is all the way to the right, vice versa, sorry, on the screen here. But essentially this is not impossible to have a volvulus, but a lot less likely because that mesenteric width is a lot wider, and usually don't have Ladd's bands, so these tend to be not as symptomatic. So how does it present? Typically the call is the nurse or the parents say, hey, this is really abnormal green stuff on the bed or the blanket, and it's very green, right? This sort of bilious vomiting in a baby, that's always abnormal. So the typical course is a contrast study, a presentation to the ER, or if it's in the hospital, then that's the next step, which would show some sort of a obstruction of flow sometimes versus also basically the bowel staying all on one side, not crossing the midline. There's some radiographic criteria, though now, as I'll show you a little bit later, there's a little more interest in using ultrasound to look at some of these features. And so I think that's some of the things that are coming down the road. We would take this child to the operating room and find something like this, basically a twist of the bowel over itself, where we would untwist it. And this bowel actually looks quite healthy, very pink, not dilated. We got quick to this one. This was an important case where prompt recognition of the problem and expeditious treatment in the OR led to not a problem. So we untwist it, we assess for perfusion, and if there's anything that's concerning, and sometimes they need a bowel resection, sometimes they need a second look, exploration for additional resection, particularly if the bowel's not healthy. But in general, if it's caught on time, it's fairly straightforward to fix. It follows the guidelines of Dr. Ladd, who started and stayed here in Boston for a long time. And basically the procedure involves dividing these Ladd's bands, widening the width of the mesentery. It used to be advocated to remove the appendix, more so because of the diagnostic uncertainty of, well, the appendix now it's going to be in a different location. We should probably just remove it so it doesn't create confusion. But that is, I think, less and less being practiced nowadays, I would say, particularly if it's a child with complex conditions and other issues that may have constipation and may need their appendix for bowel management programs later. So it's not totally required now to remove the appendix, particularly because diagnostic imaging and clinical determination of appendicitis is a lot more straightforward nowadays with modern imaging. However, it does carry, because any abdominal surgery creates scar tissue, it does carry the risk of additional obstructions down the road, not from the initial problem, but more so from adhesions from the surgery. So that can be an issue. And although you remove the main issue, you don't completely restore normal rotation. You convert somebody from malrotation to non-rotation. And so they technically can still have a volvulus. It's less common, but it can happen. And they will always have this sort of non-rotation status. So that's an important distinction to talk about, and also to counsel families about, that they can still present a lot less likely, but they usually have a more wide mesenteric width that helps them prevent that. So the scary situation that we all try to prevent is this situation: a child that looks ill, you get an x-ray, kind of just looks terrible. You go to the OR and it looks totally dead. And so these are kids that really struggle and have high mortality and can have short gut from having to lose a lot of intestine. So really trying to prevent that. So that's like the general elements of intestinal rotational anomalies in the general population. Now, how does it play into heterotaxy? There's definitely some challenges here because the diagnosis is not straightforward because of the whole difference in the sidedness of the organs that can occur here, sometimes the criteria for the definition are a little bit obscure and not totally applicable, particularly when you have this sort of right-sided stomach situation. Some of the symptoms of feeding difficulties, intolerance, some emesis can overlap sometimes with some of the comorbidities that are associated with intestinal rotation anomalies. And there's a bunch of controversies. I'll show you some of the data. Whether do you screen for malrotation or intestinal rotation anomalies? Do you do prophylactic last procedures? What do you do if you need to put a G-tube in this child? Do you also look for that issue? And if so, do you treat it at the same time? So there's a few other curveballs that come into play. The historical perspective is this one. This actually came out of our group here in Boston a while ago. It looked at just outcomes after lab procedures in patients with heterotaxy. And small groups, but still very reasonable. 31 kids on one side, 51 on the other. They compare just general outcomes. The table's probably too small for you to kind of focus on. But the bottom line is this, that they found that if allowed to develop abdominal symptoms, about a third of heterotaxy patients with intestinal malrotation had midgut volvulus. So that kind of raised everybody's eyebrows and says, oh, geez, if a third of them are going to have volvulus, geez, we should probably do prophylactic procedures on all of them and screen all of them, right? And so I think the pendulum swung from that, and we all nowadays say, really? Now should all of them get screened? And there was a lot of controversy. I think the survey that followed that a few years later, both surveying cardiologists, cardiac surgeons, general surgeons, there was definitely a bit of a flip of a coin, as you can see. Not everybody agreed. Some believed in one thing, some believed in the other. It was all over the place. And so that led to different practices across everywhere, basically, and came with additional data over time that some centers that just manage these patients expectantly, for example, 414 patients, only one of them developed symptoms attributable to intestinal rotation anomaly. And they also found that complications and mortality sometimes from the actual intervention was not negligible. So some of these suggested that it really wasn't necessary, right? More and more data showed that, hey, geez, actually these kids are high risk for post-op complications, for shunt failures, particularly some of the more delicate kids in the early post-operative period had high risk of shunt failure. So this really kind of swung the pendulum to the other side to say, okay, we really shouldn't probably be doing all of that. This other study looked at 649 patients where about a third underwent a LATS procedure, but really only about 1% had a volvulus, right? And complications, 10% of small bowel obstruction from adhesions from just being in the belly. So again, were the complications greater than the benefit in this setting? More and more, looking at it from a different angle, this group more recently said, okay, of all the kids that have malrotation and undergo a LATS procedure, what's the issue? And you can see clearly that all these complications, surgical site infection, sepsis, thrombosis, prolonged mechanical ventilation, were greater when performed on heterotaxy patients. So it became, again, the same sort of theme, right? This other study is interesting because this is sort of a contemporary cohort out of Arizona where they tried to follow the expectant management but still sort of screened everybody. So they had 18 kids, shorter cohort, but really had a nice protocol as to, okay, what are we going to do? If they're symptomatic, then they get testing, and that's pretty straightforward. If they're asymptomatic, they would get an upper GI just to know, but then they would only intervene on if symptomatic, and they would follow them serially to see who became symptomatic. And they really saw that the majority of these asymptomatics, even if they had a high proportion of intestinal rotation anomalies, they really didn't need surgery. A few of them had feeding intolerance and underwent surgery for G-tube or something else with concomitant LATS procedure, but only a few underwent surgery for volvulus. Actually, only one of them actually had volvulus. So a small proportion. So they really emphasize this point that the screening or the imaging really didn't really inform the decision to do surgery in an otherwise asymptomatic child. So the recommendations from society guidelines within pediatric surgery is that there really isn't any evidence to support screening in asymptomatic patients. And so that's kind of our practice here in Boston, and many places I believe that's the latest. What I mentioned earlier, just to kind of get closer to wrapping up here, is something that we're going to start to probably look at our institution. There is more and more data from the ultrasound and radiology department that now they're looking at, they used to look only at the relationship between the SMA and SMV, and if you saw a twist or an abnormal relationship with that, then you would say, okay, that's a volvulus, that's a twist of the mesentery. But now they've been a lot more looking at the position of the duodenum, because you can see the duodenum even with fluid. So it's kind of like a contrast upper GI ultrasound where they put fluid in the intestine, usually through either feeding tube or letting the child drink something. And they can see really clearly the duodenum in between, if it's retroperitoneal or not, in between the aorta and the SMA. And if that's the case, then that's by definition not an intestinal rotational anomaly. And they have pretty high sensitivity and specificity, and it's starting to become something that several centers have gone to as a default screening method. Now, this doesn't change the practice of do you screen asymptomatic patients, but when somebody is symptomatic of some sort, whether bilious emesis or just this kid spits up, doesn't tolerate the feeds, or is intermittently in discomfort, is he one of these kids that may be symptomatic? Ultrasound's going to probably, my guess, in the next few years, become a lot more relevant for these evaluations. So to summarize, malrotation is common in heterotaxy. However, symptomatic malrotation and volvulus is super rare. LATS procedures do carry some morbidity and mortality risk in this delicate patient population, so therefore they're not really indicated if the child's asymptomatic. Likewise, screening only, I think, adds confusion and anxiety to the family and to the providers too as to what to do with this information, particularly in an asymptomatic child. We talked about how ultrasound may become more and more popular for some of the screening situations, and really educating families about the symptoms to look out for and having a pathway to evaluate these children is important, particularly when it comes to if they're going to have a feeding access, right, a G-tube, a GJ tube. I think an important conversation at that point in time is to have an evaluation intraoperatively of that with the mesenterium. There's really obstructive lad bands, so sometimes that can be addressed at the same time and may actually convert a child who you thought needed a GJ tube to somebody who just needs a G-tube, because actually the reason why they're not tolerating feeds in the stomach is because there's obstruction in the duodenum from these lats bands. So we've had a few of those. So that's that. Thank you for the invitation, and we'll be taking questions later. Thank you.
All right, thank you very much. Excellent pictures, and it was very helpful. All right, let me get our next talk up here. All right, so next, my pleasure to introduce Dr. Douglas McDonald. He earned his MD PhD from Case Western Reserve University and completed his pediatric residency in Cincinnati Children's, followed by allergy immunology here at Boston, where he works on many things, including everyone's favorite, heterotaxy syndrome. So please welcome Dr. McDonald to talk about the global assessment of immune function and hyposplenism in heterotaxy syndromes. Thank you.
Well, thank you for having me. I've been working with Dr. Shidlow and the heterotaxy team at Boston Children's Hospital for about a few years now, and definitely learning a lot of things, and it's really an honor to be a part of the team. So my goal today is to talk about immunologic assessment in heterotaxy syndromes. So to start off, I have no conflicts of interest to disclose. But the main concern that we have as immunologists is there a spleen or not? And if there is, what is the function of the spleen? So that is the central concern that we have, and then everything else beyond that, is probably less complicated. But really what we want to establish is presence of functioning spleen or not, because having hyposplenism or asplenia really sets patients up for severe, overwhelming infection. So, we've talked about all the amazing things that these patients go through, and what we're trying to do as immunologists is minimize the risk of infection in these complicated patients. And any kind of even subtle immune deficiencies can just add to their risk. So it's really important for us to understand their immunologic function. So we assess the presence and function of spleen, and we'll go over that in greater detail, and then we will monitor their immunologic status over time because that changes in these patients from year to year. So keeping a close eye on them, I think, is really important for minimizing their infectious risk. So just to kind of go over asplenia, it's estimated that there's about 1 million people in the U.S. who are asplenic or hyposplenic, but as we'll see in the next slide, that's probably an underestimation. But common causes of asplenia include trauma and subsequent surgical removal. There can be therapeutic reasons to remove the spleen, hereditary spherocytosis, or autoimmune conditions such as ITP and autoimmune hemolytic anemia that are resistant to treatment. And then, of course, patients with sickle cell disease undergo autoinfarction, so they lose splenic function over time. The less common causes are isolated congenital asplenia, and then, of course, of interest to our group is heterotaxy syndrome. So this slide just shows the many different causes of asplenia and hyposplenism. In our situation, we're interested in Ivermark syndrome, but there are many causes of hyposplenism, and that can include a variety of gastrointestinal diseases, liver diseases, a number of hematologic and oncologic conditions, and then a number of immune deficiencies and immune dysregulation syndromes, infectious diseases. So you can see that there are a lot of different causes for impaired splenic function, and it's probably something that's not evaluated as frequently as would be helpful. So impaired splenic function leads to increased amounts of these cells within the circulation. These are pitted red blood cells. And those pits that you see are actually precipitates of misfolded or defective protein, mostly hemoglobin within the red blood cell. You can also get buildup of other different bodies, one of them being Howell-Jolly bodies, which are remnants of DNA and nuclear remnants that can build up in patients with impaired splenic function. So in heterotaxy, as has already been discussed, the presence or absence of spleen tends to be associated with left versus right isomerism. So left isomerism is also referred to as polysplenia syndrome and is characterized by bilateral left atria, 2 bilobe lungs, and then multiple spleens. And the question is, are those spleens functioning in a normal fashion? And then right isomerism is associated with asplenia, bilateral right atria, 2 trilobe lungs, asplenia, and typically more severe cardiovascular malformations. Although in our discussions, in our monthly heterotaxy meetings, there can be a lot of variability in the presence of heterotaxy. So spleen, it's important to understand the importance of the spleen to the immune system. So it is the largest lymphoid organ in the body. Other lymphoid organs that you would be familiar with would be lymph nodes. But the function of the spleen is to filter the blood, and it filters out damaged or old blood cells, and it also filters pathogens from the circulatory system. The spleen is also the site of immune responses to these pathogens through both innate and adaptive immune system. So broadly speaking, let's see, does the arrow show up? Well, so you'll see in this upper right-hand corner, the venous sinusoids of the red pulp. This is where the blood is filtered. And there are numerous macrophages, cords and sinuses that the blood filters through. The channels that the blood filters through are very small, usually narrower than the width of a red blood cell. So cells that have these pits or Hal-Jolly bodies have a difficult time getting through because the pits are actually not easily deformed, so they wind up getting plucked out as the cells traverse these cords, and then the membrane reanneals, and then you're left with normal red blood cells. The older senescent red blood cells will express a molecule called phosphatidylserine, and that's a marker for removal by macrophages. So that's how the red pulp works. The white pulp shown down here in the middle consists of T lymphocytes and B lymphocytes as well as dendritic cells, and that's the site where the adaptive immune responses occur. So all of that blood filters through the spleen, and that allows the immune system to survey the blood for the presence of pathogens. If different pathogens are detected, then you'll get development of specific antibodies against those pathogens, which are highly specific and help to clear infections. So initially, you'll get blood coming in through the red pulp. The macrophages will clear some of the pathogens as best they can. Anything that persists, then the adaptive response of the white pulp then helps to clear the infection later on. The key thing about the adaptive immune response is that it takes a week or two for it to happen. And the interesting part of the spleen are these zones called the marginal zone, or MZ. That's where a specialized class of B lymphocyte resides. These are known as the IgM-positive memory B cells. And what makes them unique is that they produce IgM antibodies that recognize the polysaccharides of encapsulated organisms like Neisseria and pneumococcus. And these can be produced very quickly and help protect the individual from overwhelming infection from some of these encapsulated organisms. So the consequence of asplenia or hyposplenia is overwhelming sepsis due to these encapsulated organisms such as strep pneumonia, Haemophilus influenza type B, and Neisseria meningitidis. The reason that encapsulated bacteria are so dangerous is that that capsule actually protects them from complement activation, and they are not easily engulfed by the bacteria. So if you lack a spleen, then you're not going to be able to produce that IgM that binds to those capsules and activates the complement, allowing the macrophages to engulf them. And strep pneumonia accounts for 90% of overwhelming sepsis in these patients, followed by Haemophilus influenza type B. But there are other microorganisms that are also dangerous to these patients, including Pseudomonas, Capnophagia, and Bartonella. And it's important for families to understand that Capnophagia and Bartonella are actually part of the oral flora of dogs and cats. So having pets in the home does put them at somewhat higher risk. If they get bitten by the pet, they need to seek medical attention very quickly because that can lead to overwhelming infection. The incidence of fulminant sepsis is estimated to be as high as 7%, but the mortality from sepsis in these patients is up to 70%. So it's important that they be evaluated quickly. The groups that are at highest risk are children who are less than 3 years of age and older adults greater than 60 years of age. So how do we evaluate for spleen and spleen function? Well, the first thing, of course, is reviewing the abdominal imaging from these patients, whether that be from CT scans or ultrasounds, looking for the presence or absence of splenic tissue. One of the more common ways a number of years ago was to look for Howell Jolly bodies in peripheral blood smears. The downside to that is that it's not very sensitive. So we've moved more towards pitted red cell counts, which is a much more sensitive assay for hyposplenism. And that is accomplished using interference microscopy. And then the other gold standard that we use is assessing for those IgM memory B cells, which are part of the white pulp. So the combination of the pitted red cell count and assessing the IgM memory B cells is really what we're basing our assessment of splenic function on. There are now other options for this analysis, including flow-based quantitation of Howell Jolly bodies, and you can send that to the Medical College of Wisconsin, and that's probably every bit as good, if not a bit more sensitive than even the pitted red cell count. And Boston Children's Hospital actually will be doing this assay probably starting in the spring of 2026. So the pitted red cell count, again, that's an assessment of red pulp function. Typically in healthy individuals, the pit count is less than 4%. Counts greater than 4% is considered indicative of hyposplenism. And typically values around 14 to 15% are what you might find in patients who are asplenic. So it's a pretty simple test to order. 3 mLs of blood sent to Cincinnati Children's Hospital, and we found it to be a very quick and reliable source of information for us. At Children's Hospital, we are quantitating the different B cell populations, including naive B cells, the IgM memory B cells, as well as switched memory B cells. And this is also a fairly straightforward assay that we have at our disposal and helps us in managing these patients. The IgM memory B cells, though, I will mention that they can develop in lymph nodes, so it may not be quite as sensitive as the pit count, but typically patients who are asplenic will have markedly decreased population of IgM positive memory B cells. So we have a fairly standard approach to immunologic assessment of our patients. One, obviously reviewing their medical and surgical history. 2, reviewing their imaging studies to look for the presence or absence of splenic tissue. And then the immunologic assessment really is fairly straightforward. CBC and differential, quantitative immunoglobulin assessment, and then, of course, measuring specific antibodies, particularly to pneumococcus, Hib, tetanus, and meningococcus. And this is typically done in slightly older infants who have received at least 2 or 3 immunizations, so we can assess their specific antibody responses. And then, of course, we look at lymphocyte immunophenotyping to look for memory T and B cells and marginal zone B cells. And then we are also looking at RBC pit count. So follow-up really varies a bit from patient to patient, but generally yearly, and that depends on their level of complexity and whether or not any abnormalities were found on their initial immunologic assessments. So I thought it might be helpful to review a case that I'm following currently. So this is a boy who has relatively mild cardiac disease, but has abdominal situs ambiguous and right-sided polysplenia. So his initial evaluation at 3 months showed a mild hypogammaglobulinemia, and I will point out that around 3 to 4 months of age is the time of what we call the physiologic nadir for IgG level. So that's the time in life where the maternal IgG that's transferred placentally is kind of diminishing, and then the baby's IgG production is starting to ramp off. So that's kind of a nadir for IgG level. We noted that lymphocyte populations were good, maybe even a bit of a lymphocytosis, which may have represented a sort of a reactive condition. But importantly, the RBC pit count in this patient was quite high at 18.2%, which, as we mentioned before, is kind of in the realm of asplenia. So that was a bit of a surprise. Follow-up then at 16 months of life, his immunoglobulin levels had normalized. In terms of his specific antibody production, his Hib titer, the PRP, was protective, but really the pneumococcal titers and meningococcal titers post-immunization weren't that great. So this child, given the fact that he has impaired splenic function and not great specific antibody production, he has been maintained on amoxicillin prophylaxis. And Dr. Wilson is going to go over all the ins and outs of antibiotic prophylaxis following this talk. Also, this patient had an increased population of the unswitched memory B cells, so really some solid evidence that he does not actually have very good splenic function in spite of the presence of a spleen. And then at 23 months of age, more recently, again, his immunoglobulin levels remain within normal range. He received some additional boosters, but still not great titers to pneumococcus or meningococcus. Hib titer, PRP, is still protective, but what was interesting to find is that his RBC pit count had fallen pretty dramatically down to 1.9%, which is getting close to normal range. So this is an interesting finding, and I think one of the questions that we have on our team is, in terms of patients with polysplenia, what is the true incidence of hyposplenism? And we hope to further define that. And then another aspect that would be interesting to follow up on, for patients who actually do have hyposplenism, does that improve over time? This observation suggests that that might be the case. So he continues on antibiotic prophylaxis based on this evaluation, and his clinical course has been pretty good. He did have one brief hospitalization this past winter due to fever, and he had a bacteremia rule out. His cultures were negative. He was found to have adenovirus infection. So he has been relatively stable. I'll say that I have had other patients similar to this who, for the first couple years of life, didn't respond well to vaccines, but subsequently, as they got older, around 3 to 4 years of age, they did start to mount meaningful responses to their immunizations, which I think makes their management a lot more straightforward. So these are all issues that I think are worth studying and following sort of longitudinally for these polysplenia patients. Another consideration that we have as immunologists is we heard a lot of really fascinating talks about the surgical repair that these patients go through, and even heart transplants in some of them. What we've observed is that for patients who have undergone heart surgery, particularly early in life, the thymus overlies the heart, and the thymus is a site where T cells, once they exit the bone marrow, they go to the thymus where they get educated in terms of self versus non-self. So with heart surgery, particularly early in life, you remove a lot of that important organ. So what happens is typically you will see decreased number of total T cells, a decrease in naive T cells, and reduced T cell receptor repertoire. So basically, again, just to refresh, the thymus is where naive T cells are educated, and then they go out into the circulation to search for pathogens, and this population of T cells does get reduced. The question is, what is the significance? And I would say the vast majority of these patients are generally healthy, but sort of long-term as they age, some of the potential late effects of thymectomy include premature immunosenescence of the T cells, and that can be worsened by severe viral infections, which can deplete an already low naive T cell population, and they can also have a slightly increased risk of autoimmunity, neoplasms, and increased infections. So these patients will obviously require closer follow-up and may require additional support beyond antibiotic prophylaxis, perhaps even immunoglobulin replacement if immune function deteriorates significantly over time. Potential interventions for these patients could include trying to minimize thymic removal during their surgical procedures and consideration of autografts of thymic fragments. Institutions like Duke treat our patients with 22q11 deletion syndrome who have absence of thymus, so they're actually doing thymic transplants where thymus tissue is purified and then surgically implanted into the thigh muscle, and over time develops normal thymic function. So this type of an approach is potentially feasible, just not clinically available at this time. So that is pretty much our standard approach to immunologic assessment, and it's not a one-size-fits-all. As you can see, we have to follow each patient, year to year to make sure that they're having appropriate antibody responses, and we're keeping them as low risk as possible for overwhelming bacterial infections. Thanks for having me.
Thank you very much. That was fantastic. All right, so we're to our last talk of this session, and we'll be hearing from Dr. Jo Wilson, who earned her MD at the Medical College of Georgia, completed her pediatrics residency and allergy immunology fellowship at Johns Hopkins, and she now serves as assistant professor in the division of allergy immunology and rheumatology at University of Madison, Wisconsin, focusing on mechanisms of some viral atopic interactions in children. And today, let me pull up her talk. Talk about mitigating infectious risk in heterotaxy. Please welcome Dr. Wilson.
Great. Thank you for having me. This has been a really exciting day. I've learned a lot already. So we can jump right in. Dr. McDonald did a great intro for some of my talks, so I'm not going to have to go over everything. So as we've heard many times today, heterotaxy results in abnormal arrangement across the left-right axis, and there are 3 possible spleen outcomes. You can have a normal appearing spleen, you can have polysplenia, and you can have asplenia, and all are at risk of abnormal splenic function in heterotaxy. And as we've discussed, they're at specific risk for encapsulated organism bacteremia or invasive infection. And so as we talked about, and I'll just go over this data pretty quickly because we've reviewed it already. There's about an average of a 5% lifetime risk of bacteremia, and most of our data is coming from the sickle cell population and post-traumatic splenectomy. But what we know about bacteremia is that it's specifically dangerous, and our patients are at risk of this overwhelming infection that happens so quickly. And so we really try to guide our patients as much as possible about the risks, what to expect, and how to act appropriately. But we base a lot of our data on these bigger patient populations, but what do we know in heterotaxy specifically? And just a couple of points to point out here. This was a review that was done back in 2016. And I think the things that jumped out to me here were that, the age that we know right now is that 17 months is the average age, but these were pediatric studies. And so in heterotaxy specifically, we just have a big lack of adult data. And so there's, a lot to work on there. The other thing that really jumped out to me is that, I do think sometimes people see normal spleens or polysplenia and think that maybe that there is some splenic function. And what we know about our patients with heterotaxy is that you just can't rely on that. Just because you have multiple spleens present doesn't mean that those spleens are functioning. So we really have to do the workup that Dr. McDonald suggested and make sure that they have splenic function and follow that along to make sure that these patients are safe from these bacteria. We won't go over infections because Dr. McDonald reviewed that specifically, but this is something that we go over with every patient so they are fully aware of the risks. The one thing I did want to mention was this paper. This is a very old paper now, but I still think it holds true. It's from Boston Children's here between 1950 and 1975, and they looked at infections in our heterotaxy patients. And one thing that I found was really interesting is that in patients above 6 months, it really matches what we talked about previously, that pneumococcus and Hib are really your primary organisms. But in our young babies, the ones less than 4 months, you are seeing E. coli, you're seeing Klebsiella in these neonatal sepsis-like pictures. So those are still organisms that we really have to worry about in our youngest babies. So how do we protect our patients with heterotaxy and abnormal splenic anatomy? So what I talk about with my patients and in our clinic is that there's really 3 pillars of approach, and all are very important. And so those are hypervaccination, antibiotic prophylaxis, and having a really solid fever plan that both patients and providers that they at their local hospitals, especially for rural Wisconsin, are aware of and comfortable with. So we are certainly not going to review in detail every vaccination plan, but I am going to hit the high points. So like Dr. McDonald mentioned, we're overwhelmingly worried about pneumococcus. This is causing most of the issues in our patients. And we are really lucky to live in a time where we have great pneumococcus vaccines. So this needs to be a conversation that we have with our families, that vaccination for pneumococcus and staying on top of current literature is super, super important. So the current recommendations are to receive our standard series, so infant series plus 18 months. And then what happens after that in the age of new pneumococcal vaccines is still, there are no guidelines for. So currently, before PCV20 came out, it was 2 PPSV23, so that's the polysaccharide version of that vaccine. Now that PCV20 is widely available, we are talking a lot about our patients about PCV20. I think it's a great vaccine. There's also really good data that these Prevnar vaccines or PCV20 decrease pneumococcus carriage in the airway. So I think this becomes a really powerful tool that we can use in our patients. Now, I do talk in this table about waning immunity and following antibody levels. Actually, if you look at the British guidelines from 2024, they say don't follow levels. But that is in the age of PPSV23 where we were recommending PPSV23 every 5 years, no matter what. Now in the age of these Prevnar vaccines, I think that we really have to follow levels and see what our patient's immunity is doing and act appropriately, knowing that this is the biggest risk for our patients. Hib is really a vaccine success story. We see much less Hib now due to our vaccines, but we still recommend an additional vaccine for that for our vaccinated kiddos. Meningococcus, as we've already mentioned, is a big risk. So the normal pediatric vaccine series has that in later childhood. And for our kiddos, we are recommending that in the neonatal age range and then repeated throughout life. So there's only one vaccine that is well tolerated or has great safety data for that. So we typically recommend the Menveo vaccine series just the same time that you do the other infant series. Influenza we talk about a lot. We don't think that there's variation in influenza immunity specifically in our heterotaxy populations, but influenza carries a big risk of secondary infection due to mucosal changes. So we talk a lot about it, influenza for the whole family in the household. I did want to mention this now. Dr. McDonald talked about this a little bit too, and we just don't know. This was a small patient population, and we wish we had better studies, but this is looking at antibody levels to certain pneumococcus serotypes after vaccination according to splenic function at the top and according to heterotaxy versus CC, or cyanotic congenital heart disease on the bottom. And at least this paper showed that Our patients can mount immunity to this. There was a lot of questions early on because of those IgM positive, CD27 positive B cells being absent, if they could make strong responses to these vaccines. But all the data we have so far is that they can, and they should be getting those vaccines because it's one of the best ways to protect them. So that second pillar on the image I had was antibiotic prophylaxis. We kind of touched on this earlier, that there's some controversies around it, but there's really no controversies less than 5 years old. And so the recommendation really is beta-lactams, penicillin or amoxicillin, and then there's alternatives listed for our beta-lactam allergic patients. This is what most of our recommendations are based on. This is one of the prop studies in the late 80s for sickle cell anemia, showing that you have a really large decrease in infections, cumulative infections on patients on penicillin prophylaxis. So again, in our clinic, this is a shared decision-making, as so many things that we do are. But the definite recommendations for antibiotic prophylaxis are birth to 5 years old. That is really solid data. And anybody with history of invasive infections, we are advocating for lifelong prophylaxis. And as Dr. McDonald sort of alluded to too, in any of our patients that have other immunocompromising conditions, it's just too many risk factors, and we also recommend lifelong prophylaxis. Beyond those conditions, data is really lacking on extension. And what I would like to see over the next 10 years is really gathering more data so that we can appropriately have these conversations with our patients and risk versus benefits. Because we know that patients, post-splenectomy patients, adult patients are still getting sepsis. They're still at these really high risks of high morbidity and mortality. But we just don't know the other side of things like adherence and effect on quality of life. And we don't know about resistance patterns that might impact how they do when they actually do get if they actually do get sepsis. The other thing that I often worry about, and I'm not sure that this is a real worry, but I do worry about it, is that our adults on antibiotic prophylaxis, that they will have some sort of false sense of protection and not follow their fever plan. So again, this is a really open area of research that we really have to dig further into so we know how to protect our patients. So how do we protect our patients on the patients that we decide don't need, or through shared decision-making decide that we're not going to do prophylactic antibiotics? That really gets to the third prong of the the 3 pillars of plan. So the one thing that we really talk, there's a long first visit in my clinic, is we talk a lot about fever plans. There's a lot of patient education about what we've talked about before, what are the risks and what does the data look like. We provide emergency room letters to our patients, and we usually advocate that they print those out and keep them in their wallet or in the baby bag or whatever it is so that they can present that to the emergency room providers. I have found that to be really critical. I take care of a lot of patients that go to rural Wisconsin emergency rooms, and that has proved to be absolutely necessary to get the appropriate care. We also talk about standby antibiotics because, again, I have a lot of rural living patients that live over 30 minutes from a hospital, and these can be rapidly deadly situations. And so if they live over 30 minutes, that's my typical rule, is I will give them what we call standby antibiotics. Before we go to that, I did just want to review this fever plan that was nicely published in the New England Journal in 2014 and one that I still follow today. And basically, it might be hard to see on the screen, but basically if we have a fever in one of our asplenic or hyposplenism patients, we do recommend that they get to the emergency room as soon as they physically can. And it doesn't always mean, and this is really helpful for patients too with quality of life, as many children have colds and fevers, as it doesn't mean that you necessarily have to stay overnight in the hospital. We do say if baby looks great and everything else is okay, that we can do a blood culture and a dose of ceftriaxone and send home for monitoring. Obviously, if the child doesn't look well, we do obviously advocate that the child is monitored overnight. The standby antibiotics for children and adults is typically Augmentin, but again, there are other options for beta-lactam allergic patients. One thing we talk, especially with my toddlers and or babies with older symptoms, a conversation that we often has is, but she looks, there's colds around, like everybody's in school, it's okay. But one thing that we have to remember is that pneumococcus is our most common organism here, and the most common preceding symptoms of pneumococcal pneumonia are going to look somewhat cold-like. And so it's hard to be reassured completely, even if they're cold, similar symptoms. So important future considerations that I wanted to talk about before I wrapped up. So again, pneumococcal vaccine is such a powerful tool in our toolkit, but it's not perfect. We have to remember that even though our pneumococcal vaccines are covering up to 20 to 23 serotypes, there are other serotypes of pneumococcus, and children run into things that are not in the vaccine. Unfortunately, although this is not happening super quickly, there is evidence of strain replacement shown by the Lancet Infectious Disease paper on the bottom, meaning that as we protect for certain serotypes, the ones that we don't protect for are going to be more common. And so we have to stay up with the literature of new pneumococcal vaccines and following levels and seeing how we can best protect our patients. Again, we've talked a lot today about antibiotic prophylaxis, and that just needs to be shared decision with you and your patient, and staying up on current literature. And then I take a lot of my time in my clinic talking about fever plans and making sure that my patients really understand the risks of that, and I really feel like adherence to fever plans can be life-saving for our patients. And with that, I will close.
Invite the speakers back up to the podium for a short question and answer session. Let's see, I think that mic is good. I'll go ahead and start us since you're here, Dr. Wilson. I love the term hypervaccination. That's great. Do you get questions about the impact of daily antibiotics on diarrhea, or people using the term gut microbiome, which is not my favorite area of study, but I wonder if you could comment on that.
Yeah, I got that question Wednesday. Had a long discussion about that. It happens. It's an antibiotic. The gut microbiome is real. We are interrupting it by using daily amoxicillin prophylaxis. Again, I haven't had it to where the quality of life makes it so we're coming off of antibiotic prophylaxis, but it's a common conversation that I have with patients that, and again, as most things that we do, it's shared decision making with how much is quality of life adjusted by that.
Awesome. That's great. Thank you.
I have a question. For our youngest and most vulnerable patients, I guess what is the conversation or the framing to have with parents about using breast milk or even donor breast milk to help get some of the maternal protection while they're too young to get their first set of vaccinations?
That's a great question, and I'm not sure I've had that conversation in the setting of heterotaxy, but I think it's an important one. We know that those outcomes are better, and it's just not, I'm not usually in that neonatal period when we're deciding to breastfeed or not. I feel like I usually come in a little bit after that, but I do think it's an important point, and I don't know that there's strict guidelines or even recommendations that say that we should be thinking more about that in our heterotaxy population.
So I had a question about the pitted red cells. So it looks like if they're low, you repeat them. But if they're normal, do you still feel like, as you're following them, that you have to repeat these over time?
You're referring to the IgM memory B cells?
Or to
the PITs.
Yeah, or
Right.
either one of those maybe.
Right. So what I would say is that for asplenic patients, it really doesn't make a whole lot of sense. But what I've been seeing with the hyposplenic patients is the first thing I want to know is there evidence of hyposplenism or not? So obviously, if there is hyposplenism, then we need to treat those patients accordingly. So then the question is, what is the time course, or what is the long-term outcome of these hyposplenic patients who have polysplenia? And that really isn't well understood, but we're seeing the data like we talked about just a few minutes ago, that can change over time. You know, spleen grows up into adolescence. So it may be that some of these patients with polysplenia and hyposplenism over time may develop adequate splenic function to keep them protected. So I think that's an area of research that'll be helpful for us to look at.
I was just going to say too, there's not a lot of data about this, but there is a documented immune system immaturity that you can see pitted red blood cells in normal infants. And so I don't think we know fully how that works. So I do think, you know, the test is really not validated under 6 months of age. And so we have to act accordingly to protect our patients, but it should be reevaluated over time because maybe their splenic function is normal.
This is a terrific session. It's so great to see folks from immunology and general surgery engaged with the heterotaxy population. I wanted to shift gears for a sec to ask about biliary atresia. And if I may, I'd love to share an anecdote, which would take all of 45 seconds. But one of the first patients I cared for coming on faculty at Boston Children's was an individual with a hypoplastic left heart variant who underwent his stage 1 Norwood, and it wasn't until 6 weeks later when we saw jaundice in the bilirubin rising that we were able to identify biliary atresia. So it was a very humbling experience, and now we routinely screen with direct bilirubin. So hopefully helpful to share that. My question really is related to prenatal diagnosis. I would say around 3-4 times a year in our prenatal clinic, we identify heterotaxy polysplenia phenotype, with the only cardiovascular abnormality being interrupted inferior vena cava. And from a cardiac perspective, in general terms, we're saying, you know, outlook is terrific and really not too many concerns, but there is that nagging voice in the back of my head that wonders about biliary atresia, and it is something that we speak about with families. So that's a long way of asking this question, which is there a way to identify it prenatally?
Prenatal ultrasounds can show the cystic variant of biliary atresia, which is pretty rare. It's less than 5% of the cases. But outside of that, it's really hard to diagnose prenatally. So I think particularly for this patient population, getting that fractionated bilirubin when the baby is born, especially when they have, you know, either prenatally diagnosed laterality defects or congenital heart disease, is going to be the best test.
It's super interesting to hear that some of those liver changes occur before birth. So thank you.
Okay, hi. Thank you for taking on some of the highest yield and highest risk issues in heterotaxy, yet also are faced with the greatest level of uncertainty for how to screen and how to manage and how to diagnose. So we appreciate you taking on this very difficult challenge, the four of you. So vaccines in heterotaxy obviously are critical because people can die from fulminant sepsis. Yet it seems like in this country there's been a massive trend towards greater vaccine hesitancy. That's gone way up the ladder to the CDC and the AACIP, and I won't get into politics today at all, but what I'm trying to say is when is it the right time for a medical organization like us, for example, to issue a strong statement? Not that we're issuing formal recommendations and requirements for the rest of the population, but when do we reach that level at which our organization needs to take a proactive approach at maybe counterbalancing some of the population hesitancy and maybe even miseducation towards vaccines?
I think that one's for me. You know, of all the things I worry about with vaccines, that's certainly one of them. You know, I am lucky that I think I have the time to spend with my personal patients to talk about how important this is, and I have never to date had, I have many people that don't like vaccines in my practice in other situations, but in these, that's never been a tough sell. I think the data sort of speaks for itself in terms of risk benefit here. I do think my concern is more for the future, actually. So, you know, I showed some data that said that there is strain replacement in pneumococcus. We know that that happens. And as we limit data, or as we limit, you know, research money for developing new vaccines and putting less emphasis on the need for new vaccines, I think our future patients are suffering. So that's where I think that we should advocate is money for future vaccine development. And yeah, I don't know if that answered your question.
Yes, thank you. And the effects that it might have on herd immunity, right?
Absolutely.
Yeah, so,
I just have one final question. This is about the ultrasound screening of volvulus. The fluid, is that some kind of special fluid or any feed or water, or is there a special contrast that they're using?
No, I think just any fluid.
Any fluid. Okay, so that's really nice and convenient.
It just helps distend the duodenum so you can see it better.
Yeah, okay. We need to learn more about that. Well, thank you all for, oh, we have one more question. Go for it. Yeah,
It might be
great.
a quick one, but Chris Mathis from Kansas City. But regarding malrotation for, I guess, for either general surgeon, for patients with heterotaxy who are undergoing evaluation for G-tube placement, regarding dysphagia, what are you looking at or assessing kind of in terms of considerations for like concomitant LAD procedure in those patients? Is that, in your mind, is that kind of a knee-jerk reaction to assess for LAD bands during G-tube? Does it depend on kind of the reasoning for G-tube?
Yeah, I think it depends on the symptoms. Is it clear, just like, okay, the kid tolerates G-tube feeds, is doing well, and by the way, but is really tenuous, and limiting the anesthetic is the best sort of thing for this kid. So doing a 15-minute G-tube and getting in and out quick is probably the best thing. Then that may be a kid where you may just get into a G-tube and not spend too much time looking for things, right? But I think it's a kid that is like not tolerating gastric feeds, intermittent vomiting. That question's always like there, right? Is the reason for that request for post-pyloric feeds or GJ feeds because there's obstructive bands of the duodenum? I think that's the one that you probably ought to do. And you know, many times just looking at the chest, the X-ray, the belly X-ray, you see where does the NG tube end or where does the feeding tube end, and you can kind of get a sense sometimes from that. But I think those are the kids that maybe ultrasound or just intraoperatively spending a few more minutes looking for that. It may be worthwhile, but you sort of have to counsel that you know, I think going that LADS pathway does add maybe 45 minutes to potentially an hour, depending on how the, you know, exposure is. So it does add a little bit more time in a child who may not be totally symptomatic. It does. That's probably why we see some increased risk and complications when those were done across the board. But I'm curious to see what they do in Texas.
I agree with everything that you said. I think I've found myself in a situation many times where a kid was tolerating gastric feeds and had rotational anomalies, and then intraoperatively saw some adhesions that weren't symptomatic. And then you're like, well, am I going to help this kid if I do something about these? And I think you just kind of have to consider them on a case-by-case basis. What I typically counsel families about more often so is, particularly if the stomach is not in the normal anatomical position, where that G-tube is going to be sited and how that could change things, especially if the liver and the stomach are on the same side, then G-tube, you know, it's got to reach. And so that can be really challenging and cause some other issues in terms of the way the stomach drains and things like that.
All right, well, oh, yes, one more. Great.
Just because I can see there's a little bit of time, I always
Yeah,
get to
absolutely.
be
Yeah.
first at holding everybody up. Thanks again. I actually have a particular interest in portosystemic shunts, and I was wondering if some of the panelists could talk about how you guys deal with portosystemic shunts, like evaluating for them, treating them at your centers. I end up, as an interventional cardiologist, I actually do a fair number of them with us, but I work really well with our liver surgeons. And as a side note, that came about just from helping them with hepatic vein outflow obstruction, right? So I just ended up kind of serendipitously having a good relationship with our liver surgeons. But I was just curious how you evaluate for them, because specifically in a lot of these polysplenic heterotaxy patients, they're very hard to identify.
Where I trained at Vanderbilt, we had a pretty large series of congenital portosystemic shunts, and a lot of those kids were intervened upon either with a combination of interventional radiology and the transplant surgeons. At Dallas, I haven't really seen that since I've been there. I know that Dr. Superina at Chicago, he takes care of a lot of those kids, but maybe you also.
Same here. I haven't been involved in that aspect of the care of these patients. I do think, I mean, Dave may know a little more about it, but there has been some that we have collaborated with again, also our transplant team and the interventional cardiology component. So,
yeah, we seem to have had a run in the last several years. I would say we've probably had 6 in the last 3 years. We've had 2 banded in the last year by our transplant surgeons. HB Kim has done them. And it's been pretty eye-opening to see sort of their criteria, what pressure he would band versus occlude. It's crazy. Yeah, I know. So, but it's, I think it's super important to find. We actually, a patient of mine earlier this year had AVMs by 7 months and already had pulmonary hypertension after a complex biventricular repair with a port systemic stent is now banded. So I do think it's an important element, and you really have to be aggressive about treating it before you get behind the eight ball.
Just my little bit of a plug, because the same thing happened with me, again, just serendipitously. I suspect they're a lot more prevalent than what, there's actually some publications from Boston. One of my old mentors looked it up, something like 20% of the kids have them, specifically with a polysplenic variant, and I think just surveilling for them is important. Yeah. And then treating them.
Doing something about it, yeah. But early, I think early cath and really understand the hemodynamics and abdominal imaging and MRI, and I think there's a place to go full Monty.
Any other follow-ups? All right, well, thank you very much, our speakers, and thank you for everyone else for your attention. And the reception is at 5 o'clock in the room with refreshments. Yes.
All right, we welcome everybody to come visit our posters. We have some really nice research to display. There's going to be a nice reception. Also, we have a little surprise. Some of the young people out here with heterotaxy were really interested in joining with us and sharing some of their stories with the doctors, sharing some of their artwork. So it'd be great if you all could kind of engage for a few minutes in some of these young people that wanted to meet you.
Just quickly, there are drink tickets, 1 drink per ticket per person. Pick those up at the registration table.